Okay, we should be live.
Thank you, Mr. Clerk. I would like to call to order the March 15th public hearing of the Insurance and Real Estate Committee at 9:03 a.m. Before I begin, I want to just see if my honorable ranking member, Senator Wong, has any opening remarks.
Thank you, Mr. Chair, and eager to get started and listen to the feedback from people. We've got a busy next couple of days. Thank you, Mr. Chair.
Yes, thank you, Senator Wong. And yes, we have 3 public hearings this week just in this committee. And I know that there are many other committees that are churning through business as well. So thank everybody for bearing with us this week. We're going to be looking at a lot of different issues. And first up, we see our old friend, Commissioner Andrew Mace from the Connecticut Insurance Department. Commissioner, welcome back, welcome home, and good to see you, sir.
Thank you, Senator. I'm not sure old friend is really a positive at my age, but I do appreciate the sentiment. Senator Lesser, Representative Wood, if you're on, I can't see you on the screen, but Senator Wong, Representative Pavlak D'Amato, and to all members of the Insurance and Real Estate Committee, my name, as Senator Lesser said, is Andrew Mays, and I'm Commissioner of the Connecticut Insurance Department. And I'd like to thank you, first of all, for the opportunity to provide testimony in support of the department's bills this year. Let me begin with House Bill 5388, which is an act concerning the Insurance Department's recommendations regarding value-added products and services and prohibited insurance practices. The core mission of the Connecticut Insurance Department is and always will be consumer protection. The department carries out its mission by enforcing state insurance laws to ensure that policyholders and claimants are treated fairly, as well as by closely monitoring the financial condition of insurance carriers to make certain that they are solvent, appropriately manage risk, and of course are able to pay policy claims as they arise. As Commissioner of the Insurance Department, and so many of you know, I am a strong proponent of innovation and technological advances within the insurance industry because I believe this serves the needs of consumers. An act concerning value-added products or services will provide an opportunity to consumers to have access to innovative products and services. The National Association of Insurance Commissioners, the NAIC, has developed amendments to the NAIC Model Unfair Trade Practices Act that will allow for certain value-added products or services at no or reduced cost when the products or services are not referenced in the policy. Now, this bill will amend our existing statutes that currently prohibit insurance companies from providing consideration or inducement not specified in the insurance policy, but there are significant limitations. To be allowed, such value-added products or services must have a legitimate nexus to the value of the insurance coverage. They must be designed to provide loss control, to improve health, to reduce risk or other intents, and they must be provided in a fair and non-discriminatory manner to insureds. In essence, what we're saying is that providing these products will enable insurers to do good while they're doing well, and it will certainly benefit consumers who will have the outcomes that they need, the reduced possibilities of loss, increased health, and so forth. Now, the department will have the ability to track the types of value-added services and products being offered, and we will be provided with the data that will show what, if any, outcome derives from these services or products. The possible outcomes, as I mentioned, could include lower incident rate. Let's, one example, for instance, if you have something to monitor your water flow to make sure there's not a flood. There could also be rate reductions because, of course, as the cost of the covered incidents would go down, so would the cost of the required coverage. So I would strongly urge you to support this. House Bill 5382 is an act concerning the Insurance Holding Company Act. And what this bill does is it adopts the most recent amendments made by the NAIC to the Model Insurance Holding Company Act concerning group capital calculation for the purpose of group solvency supervision, liquidity stress testing for macroprudential surveillance, and the continuation of essential services and functions to an insurer in receivership by affiliated entities, and will further clarify ownership of data and the records of the insurer. Now, states with insurance groups impacted by the covered agreements, such as Connecticut, have been strongly encouraged by the NAIC to adopt the GCC provision by November 7th of this year, and the LST, the stress testing provisions, as soon as possible. The covered agreements are the bilateral agreement between the United States of America and the European Union on prudential measures regarding insurance and reinsurance, and a substantially similar agreement with the UK and the US. Both of them were signed by Treasury on behalf of the United States. The first was signed in 2018, the second, 2017, sorry. The second was signed in 2018 after the United Kingdom began the process of withdrawing from the European Union. Now, the GCC, the group capital calculation, is intended to meet the requirement that the states have, and I quote here, a worldwide group capital calculation, close quote, in place by November 7th in order to avoid the EU imposing a group capital assessment or requirement at the level of the worldwide parent undertaking. Failure of any state to do so for any U.S. group operating in its jurisdiction raises the potential for any supervisor in the EU or the UK to impose its own group capital calculation on that group, and therefore all of the U.S. insurers within that group. Both the GCC and the LSD will likely also become NAIC accreditation standards, and the amendments adopted by the NAIC in 2021 are currently being proposed and implemented in numerous other states, specifically states like ours that are worldwide supervisors of an insurance group that has affiliates in either the EU or the UK. Adopting this is vital to ensuring that we remain the ones in charge, and it means that capital standards that are designed for the US market, capital standards that reflect a regulatory system that works for US consumers and for US industry, will remain in effect. This bill will also make further technical changes, and that would include updating the definition of an internationally active insurance group by clarifying additional sources of funds to be included as part of gross written premiums. By and large, it is a very technical bill, but it is a very necessary one in order to maintain our integrity as a group supervisor. The next one I'll go to is Senate Bill 359, and that's an act concerning the standard non-forfeiture law for life insurance. And this bill amends our statutes to be in accordance with the NAIC model law guidance, and it lowers the minimum non-forfeiture interest rate from 1% to 0.15%. And this amendment was clearly made due to the changing economic environment and the determination that it was unreasonable to require insurers to offer interest rates that were higher than investors could secure through a financial institution. We do anticipate, we do expect that this change will be adopted by all other states. I'm going to move on now to Senate Bill 360, which is an act concerning various changes to the utilization review statutes. And this one is in line with the governor's mission to help Connecticut become more business friendly and remove administrative red tape. What we're proposing is a change to our utilization review statutes to streamline the process for utilization review corporations doing businesses here in Connecticut. The bill would change the current utilization review license from a one-year license term to a two-year term. License renewal fee is the same each year, but it's paid only once during the two-year term. So the fee has been changed from $3,000 to $6,000 in this bill. Now, in addition, usually what happens is we get a 750-page, roughly, proposed license each year. What we're planning to do going forward as we're move from single year to a two-year period, we plan to make sure that consumers are properly protected by revising the requirements so that the companies will have to notify the commissioner of any material change, and that will include notification of a material change to the utilization review company's policies or procedures that were previously approved, or any material change to the denial letters or criteria being used. Now, I have one closing item that I'd like to mention, and this covers a number of other bills that are before the committee, including Senate Bills 354 and 355, and House Bills 5383 and 5387. And what I would like is a technical change, then that the regulation making the requirements be changed from shall to may. Now, the department is happy to draft these regulations at your direction, but if they're all required using the shall language, the time frame to complete them would be the same for them all. And frankly, the department doesn't have the bandwidth. We just don't have the staff and the legal division to complete all of these regulations at the same time, in addition to any others that may already be in the pipeline. And with that, I yield. Thank you, Mr. Chairman.
Thank you, Commissioner, and appreciate your fine work and the fine work of the folks over at the Connecticut Insurance Department, who are, really national leaders in insurance regulation. And I just had a few questions about the bills that you've testified on, and a couple on some bills that you didn't testify on. First off, with regard to the, forgive me, my legislative assistants there in the background. With regard to the value-added products and services bill, we heard some concern last year about whether or not that would incentivize people to purchase insurance plans based on factors other than networks and cost. And so there was a concern from some of the medical specialties that might have, forgive me, that might have some adverse consequences. But my understanding is that bill is already reflected in bulletin that you've issued. Is that correct?
Yes, it is, Senator. As we discussed last year, and what we've done is we've ensured that this is not being used on the marketing side. This is being used as part of the product. And I think if we want to draw an analogy just to, and I'll stick with healthcare here, the Affordable Care Act, for example, specifically provides for this, as do we on our state health plan. If you're on the state health plan, you get, I get all of these notes. You want to get a diabetes meter. You want to get, all of these other health enhancement program issues. Those are all available, and that is the kind of thing that would be available to all consumers fairly under the changes that we propose. I have not heard, I did hear last year, as you well know, there were some concerns, and I've got an open door. I will tell you, in the past year, I have not heard any concerns expressed.
Yeah, thank you, Commissioner. And I don't see that testimony reflected in anything that we've received in the committee, but just because that was an issue last year, I figured I would check in with you about it. Regarding the bill about harmonizing Connecticut's laws with regard to the covered agreement with the UK. I did notice that you had a press conference last week, I believe, to announce. Yes, that's right. Exactly. That was my take too. It's regarding InsurTech investments from the UK, and just wanted to see if those were related. If you could, give an update as to where we stand with regard to the UK and UK insurance.
Well, they're not directly related, in that this bill will cover the entire world, essentially. This is the way we're looking at it. What we are trying to do here is to avoid what happened in the European Union back when the UK was a member and so forth, when they had a group capital standard that they put in place that did not reflect what US consumers wanted. There are some products, for instance, the long tail retirement products, that may not be as necessary in Europe as they are here. Okay, we need to make sure that our companies are able to provide those profitably. And we also need to make sure that state insurance regulation, which we have shown has been more effective than probably any other regulatory system over the past 150 years that we've been around, that remains in place and is not preempted either by the federal government or by the European Union imposing its own standards. Now, the UK issue is a reflection of what we in Connecticut, and that's a reflection on what the legislature, the governor's office, the ECD, Metro Hartford, and others have done. It's a reflection of the openness of Connecticut to innovation and to new business. It's all recognition that we are, and we always should be, the center, as I put it, of the insurance universe. And we met earlier on. Metro Hartford's been doing lots of great work on this. I did meet with Minister Glenn, the city and economic minister from the government, from Her Majesty's government earlier this year. We had discussions. I've been having ongoing discussions with various insurtechs that are in the UK. And we do think this is a fabulous way to benefit both sides. We're providing access to the U.S. market. We're providing advice and support to UK insurtechs, and we open the way for our U.S. companies to expand in the UK market and through the UK market to other areas in the EU. We already have, as I think was mentioned at the press conference, one UK company that will be coming here, and we look forward to there being many others. As many good jobs as we can get in our state, using the vast talent, the vast resources that we have here is my goal. And I'm happy to work with as many people as possible to make that happen.
Thank you, Commissioner. And I'm sure the announcement by Bradley Airport that they're hoping to have a direct flight to London. I think that was yesterday. Couldn't hurt with that. Can I ask you about a bill that you didn't testify on? I believe Senate Bill 356, which would seek to incorporate affordability in rate reviews. My understanding is that the department currently has there's a May language that's currently in statute. Has the department looked at that and seen if it has a comment on that one way or the other?
I can get back to you in more detail on that later, Senator. We are reviewing this. I think what we've done, what I would like to focus on, is the work that we've done with the Office of Health Strategies, with the other members of the Governor's Healthcare Cabinet, DPH, DSS, and with the Office of the Governor, that's shown in the Governor's bill. Affordability, as you know, is a malleable concept. And right now, what the department has to focus on is whether or not the rates are excessive, unfairly discriminatory, or inadequate, which we have the resources and ability to do. Anything beyond that would A, require defining affordability, and B, it would also mean that we would have to significantly increase staff. Whereas we feel that what we've done in terms of the work that we've done with the Governor's Cabinet would allow us to address those the underlying cost of healthcare, which really is the driver when you look at health insurance costs. If you look at the cost of prescription drugs, for instance, they're going at 25% of the usual bill right now. It's going up significantly, certainly in excess of the cost of inflation. And that's what we've tried to address in the Governor's bill. So that's what we would support at this point.
Thank you, Commissioner. And I may have additional questions, but one last one before I turn it over to Senator Wong. With regard to the bill about the utilization review statute changes, we've gotten some testimony urging from some of the folks in the mental health provider community, asking for some tweaks to that language, but supporting the changes. Perhaps offline, we could take a look at that language. I just wanted to see if the department had any comment on the suggested language changes. I
can't comment on the language at this point simply because I have not seen it, but I would be happy, as you know, sir, to continue the conversation offline if they feel that there is help that we could offer.
Entirely fair. Thank you so much, Commissioner. I may have additional questions, but before I get to them, I want to make sure that other folks have the opportunity to ask you questions. Senator Wong.
Thank you, Mr. Chair, and welcome, Commissioner Mace. First, I wanted to really compliment you that your staff and your professionalism is well respected, not only in this state, but throughout the country, as I've interacted with many other insurance professionals, and particularly in the area of transparency and accountability in regards to the self-insured marketplace. You've done a really wonderful job, and I wanted to personally acknowledge and compliment you. The value-added product is one great example of your professionalism. It was an issue that I had concern with in the last legislative session. your colleagues and as well as yourself reached out and heard our concerns, addressed them, and now you have a position paper on it. So these are examples that kind of validate what I said earlier. I'm going to read the bills, and you've offered a lot of good input as we kind of drafted it. So I wanted to acknowledge that and appreciate it. But there are a couple things that weren't on there that I'd like to get your thoughts on, particularly as the chair mentioned earlier, the real focus right now on mental health and mental health insurance parity. I'd love to get your thoughts. It's not a point of consideration, but it is the point of consideration for many of us in the legislature and many people impacted by mental health concerns. What are your thoughts, and what would be some of the solutions that you see from your expertise, how we can get to mental health parity? I know the care process is entirely different, but it's important for us to consider that for many years, we've considered mental health parity on the insurance basis, but we've never been able to fully realize it. Thoughts, sir?
That is a difficult question, Senator. And it is a question that concerns probably all of us in this community. One of the things that we've seen clearly established over the last couple of years as a result of COVID is the inability to provide consumers with all the mental health resources that are needed. When it comes to parity, there are specific requirements that are done under the the Quality Act, NQTL, and I'd be happy to have my Assistant Deputy Commissioner, Paul Lombardo, provide you with all of that information. I think we do send a report, and it's probably annual to the legislature on that. As we look, one of the things we're concerned with is how do you get, given the scarcity of the resources, and I will tell you, you and I are both in Fairfield County, Senator, if you want to find a psychiatrist that is within a network, it is going to be close to impossible. You are going to have a long wait. Perhaps one of the things that we could start focusing on as we look in primary care is also to look at LCSWs and others who may be, we may broaden the availability of those by increasing the number of those. That's one of the things we've been considering with regards to, with the governor's bill. And as we look at the broader healthcare network within Connecticut, not entirely sure how much more we can do right now. We have to keep plugging away at this. I mean, frankly, it is, to me, it's a significant concern. I mean, we just don't have enough providers. And what we've done, clearly, based on the NQTL standards, we have been able to ensure that there are a sufficient, according to those standards, number of providers. And over the course of the past couple of years, I can tell you there have been companies that we have fined when we have found them falling short of our requirements. We will continue to do that. We will continue to enforce the law as written, and we will continue to work to increase the number of providers, because that really is, at least from my point of view, and I say this as, insurance commissioner, but I also say this as somebody who personally thinks it's important to increase those services. We need to be able to increase the services that are available by increasing the number of providers who are giving those services within the state.
I appreciate that. And as the ranking member in public health as well, I know we're focused in on that area, looking at tuition reimbursements for healthcare professionals and addressing that supply issue. Obviously, the demand is there. Another area along that same line is the fact that we've heard from a psychologist, the Connecticut Psychology Association, and I want to acknowledge Representative Comey and Representative Kerry Wood's strong leadership in that area and listening to them. There are concerns in regards to the insurance, in regards to some of the clawbacks and reimbursement considerations from a parity application. I thought in the past years we had passed mental health parity. It's something that we're all very proud of, but truly the application has not been in place. And what is the complexity in regards to real mental health insurance parity that we've heard the disconnect from our providers, that feels though the reimbursement's not there, some struggles with clawbacks. It's really been hard for them. That feeds into our supply because it's very hard to make a viable living in some cases with the challenges of the industry and the demand.
I understand that, Senator, and part of the issue is what happens when you have a contractual dispute. Now, the Connecticut Insurance Department's role is not to be involved in those contractual disputes. We don't have the resources for that, nor do we have the skill set at this point in time to become involved in those disputes. However, should you have a contract? Should there be a concern? I can tell you I've certainly taken up some of those. If you have a concern that you're not getting paid, or that a particular company or companies is in any way not in compliance with the law, deliberately or not, I would encourage you to reach out to the department. We will investigate, and if there is something wrong, we will make it right.
Well, I appreciate that. And I appreciate the indulgence of the commissioner to the chair to allow me to kind of deviate a bit. But in regards, I'll close by addressing the bills that you have presented. These are business proactive, business efficiency bills that the department has provided. And again, I'll end by this compliment that you have managed the department as efficiently, as effectively, and also proactively to grow our insurance industry in the state of Connecticut. So for that, I'm going to end by saying complimentary terms again. But I have to tell you, it's a brave new world of Zoom. We have childcare, and my internet just all collapsed. I have no internet. So welcome to the new world. But again, thank you, Commissioner Mays, for all your time and your continual interaction with us as a committee and giving us good insight. Thank you, Mr. Chair.
Thank you, Senator.
Thank you, Senator Wong. I think Representative Nuccio had some questions.
Thank you. I'm all set, sir.
Thank you. Any other questions for the commissioner while we have him? If not, wow, you got off fairly easily today. Thank you, Commissioner. Good to see you as always. Really appreciate all of your fine work.
Thank you, Senator. Thank you to the committee. And as always, I just want to reiterate in closing, if you do have any questions on anything coming up, please feel free to reach out to me directly or to staff. We are happy to discuss and to provide any information we can for you. Thank you.
Thank you, Commissioner. Mr. Clerk, do we have Senator Looney in?
No, he hasn't signed in yet.
Okay. So next up, I think we have Representative Gary Turco.
Hello, Senator Lesser. Hi, Representative Wood, ranking members Wong and Pavlok D'Amato, members of the Insurance and Real Estate Committee. I am State Representative Gary Turco. I represent the 27th House District, which comprises most of the town of Newington. I'm really excited to be here today. It's the 4th year in a row, I believe I've either been on this committee or testified in front of this committee. And today I'm testifying in support of Senate Bill 358, an act concerning required health insurance coverage for breast cancer benefits. So if it feels a little like deja vu, it's because I did testify on almost this exact bill, different bill number, but almost the exact language a year ago. And that bill passed out of the Insurance and Real Estate Committee and then passed the floor of the House after a really heartfelt debate, bipartisanly 145-1. And then unfortunately was not taken up in the Senate. But this year being a Senate bill, it will have to go through the Senate first, and then we'll get our chance to pass it again in the House. You're going to hear from several experts in the medical field about this bill later, and from my Newington constituent, Jan Kritzman, who has become an expert in this as a breast cancer survivor, and also someone that works tirelessly as an advocate throughout the state for better early detection of breast cancer and better treatments to help save lives. My mom is a 3-time breast cancer survivor. I'm grateful that she was able to early detect it, went through really tough times with chemo and radiation and surgeries, but she did survive, thankfully. But thousands of women in Connecticut do not. This year, it's estimated that 3,000 women will be diagnosed with breast cancer and hundreds of men. And you'll notice something in this bill is that it removes the word woman and adds insured, because men do get breast cancer too, as well as those who do not identify with either gender, woman or man, get breast cancer. So it's important that we cover everyone. Another really important part of this bill is that it adds the word diagnostics. So this bill's whole intent is for better health insurance coverage for early detection of breast cancer. You catch it early, you have a much better chance to get the treatments needed to survive. It's also a lot more cost effective than really expensive surgeries and chemo and other treatments. So it saves insurance companies money, it saves our whole public health system money, and it's saving lives. Those, I think, are really, really good goals as legislators we should try to promote in insurance legislation. But in 2019, we did pass a really great bill that started this process, that made it that there's no out-of-pocket cost for screenings that individuals may need, such as a mammogram, a MRI, and an ultrasound, especially for women that have dense breasts and a mammogram's not good enough to detect early cancer cells. You may need an ultrasound, you may need an MRI, and this that bill we passed in 2019 would provide coverage for that without out-of-pocket cost. We realized after passing that bill and hearing from women across the state that some of their mammograms, ultrasounds, and MRIs were being coded as diagnostic, meaning something was picked up in the original scan and they needed to come back and have further testing. And because it was coded as diagnostic and not an original screening, they were seeing out-of-pocket costs, thousands in deductibles, co-insurance, and copays. That was not our intention in 2019. We wanted all of these screenings and diagnostic tests to be covered, and this bill will clarify that. So there's a lot of good things this bill is doing: lower the age of baseline testing, such as mammograms, ultrasounds, and MRIs, including diagnostic testing, and making sure that all genders are, and those that don't identify with either gender, are covered with no out-of-pocket cost. So that's the basics. Please listen very carefully to Jan Kritzman, my constituent from Newington, that will be testifying later today, because she really has become such a great expert in this. Ask her lots of detailed questions. If she doesn't know the answer, she's going to talk to, the best and brightest doctors in the country that she talks to and works with on this, and will provide answers for you. And I hope that this year we will again bipartisanly work together to pass this bill in the Senate and the House. It will be signed by the governor, and we can honestly say that we helped this legislation save lives in early detection of breast cancer, and then preventing the individuals from going through all of that very terrible that I watched my mom go through, chemo and radiation and surgeries and things like that. So thank this committee so much for listening to me today and your consideration, and I'm open to any questions you may have.
Thank you, Representative Turco, and thank you for being such an important advocate on this issue. And I, remember that it was a few years ago. I think it was in 2019 that you and I and Representative Wood and Representative Borer and others on both sides of the aisle worked together with Jan, our constituent, to pass an important bill on breast cancer coverage. But unfortunately, as we've heard, I think we're going to hear from advocates today, there have been loopholes in that law that have really limited its ability to make sure that anybody at risk of breast cancer is able to access these services. So I just want to thank you for bringing that forward. You are an incredible advocate, but as I think you know, you don't hold a candle to Jan, and so I'm excited to hear from her and other members of the community, the community later today. And hopefully this will be the year we get this done. Are there any questions or comments from members of the committee? Yes, Representative Wood.
Thank you, Mr. Chairman. Chairman. Representative Turco, I want to thank you for your advocacy on this topic. I know you have worked extremely hard offline throughout the summer, throughout the fall on pushing this topic forward. And you really have been a leader. And I appreciate the time that you've put in and how much you have educated myself and others on the committee on this topic. So I just want to say thank you.
Thank you, Chairwoman Wood. I appreciate that. This really has been, since 2019, a real team effort in helping get legislation passed and helping bring awareness to the need for improved insurance without out-of-pocket cost. And Representative Orr, who's going to be testifying later today, really was one of the first people that pulled me aside when I was elected and started serving here in 2019 and started educating me on the issue, introduced me to my own constituent, Jan Kritzman, so I could start working with her on the issue. And you, Representative Wood, and Senator Lesser as well, have just been amazing advocates in trying to continue to get improved insurance coverage. So thank you all for everything that you're doing. And I should mention too, this has been a real bipartisan effort with former Minority Leader Themis Claridis really helping lead the charge with us too.
Thank you, Representative. Are you done, Representative Wood? Okay, great. Representative Meskers.
Thank you, Chair. Representative Turco, I want to thank you for this. When I was in high school, my mother was diagnosed and suffered horrible radical mastectomy, chemotherapy, radiation, etc. And thank God, God willing, she's still with us. She'll be turning 91 in a couple of days. And I can't think of anything more important than improving and protecting our mothers, our daughters, our wives, and the general population, as you mentioned, because it's not solely a woman's disease. Going forward on this, I want to have one, you should be thinking and counting on my support. I think the bill is important. I think the second piece of that is going forward, I want to have a serious conversation with the insurance industry on these processes and products, because preventative care, as we legislate, should ultimately lower the cost of insurance. What we're talking about is improving the healthcare and the outcomes for our residents. And if you look at the pain, loss, and suffering, and the tremendous expenditure going through, talk about the human cost and then the financial cost, this should be the type of legislation we stand behind, because it should reduce all of that. It should make us a better place and bring us to a better site. So I really want to thank you for your advocacy. It's important that we stand up for things that we believe in. And I'll take your guidance on this, as well as those of the chairs. Thank you.
Thank you, Representative Meskers. And that's a strong case that I want to make sure we make is, yes, we are saving lives. We are catching the cancer early through early detecting tests, but it also is going to save a lot of money for our whole public health society and for insurance companies. You'd much rather pay for that screening test than, like you mentioned, the same that my mom had when I was in high school the first time, and she went 2 more times after that, but chemo, radiation, and very expensive surgeries. Talking about millions of dollars for all of those treatments.
Thank you, Representative Turco. Thank you, Representative Meskers. Any other questions or comments for Representative Turco? If not, thank you very much for being here today.
Thank you, Mr. Chairman.
Next, we have Ted Doolittle, the state's healthcare advocate. Good morning, Mr. Doolittle. After Mr. Doolittle, we will hear from Representative Borer, unless we did skip over a couple people earlier, so unless they jump on, but otherwise we'll hear from Representative Borer.
Good morning, Senator Lesser. Can you hear me?
Yes.
Okay. I had my motherboard went yesterday, and IT got me a new computer, and I wanted to make sure I was online. Thanks very much, Senator and other honored members of the committee. My comments will be relatively brief today, directed primarily to Senate Bill 356, which is the affordability review statute. So this is a statute that would in no uncertain terms make clear that the insurance department has the authority to examine not just their traditional lookouts of whether the company is going to be insolvent, but also whether the products that are being offered are affordable. And that means going back to the traditional already existing language that is in the statute that allows the commissioner to determine whether or not plans are excessive in price. This requires an affordability review to look at the cost for people in Connecticut. It also, in my opinion, requires the insurance department to go deeper than they ever have into the filings in terms of examining the actual underlying prices. OHA, the Office of the Healthcare Advocate, for years has taken the position that if a premium is based on prices that are excessive, the premiums themselves must be excessive as well. This would align our state with the neighboring state of Rhode Island that has had an affordability review process in place for a number of years and has had good success with it. I would also add, in terms of adding these new duties to our executive branch here, that we are blessed by having Professor John Aloysius Kogan as a professor at the University of Connecticut Law School, right down the street from the Capitol where you're based out of. And he was intimately involved in setting up the affordability structure in Rhode Island. I also draw to this committee's attention the fact that the National Academy of State Health Policy, a nonpartisan expert group that examines all types of health care and health insurance policies, has recommended affordability review as a proven way to reduce healthcare premiums. And they have model statutes as well as model regulations that certainly could aid this state as we build this new program. I would also say that this is one of our real key priorities from OHA this year in terms of getting the healthcare expenses down. I view it as a bit of a companion piece. This affordability here would focus in most regards, practically, I think it would focus on the high hospital costs, but there's a companion piece in the Aging Committee, honored representatives, the Prescription Drug Affordability Bill, which is SB 260, and that targets expenses on the prescription drug side. If this bill were to go through, we'd have a strong new tool to manage the hospital side of the outrageous cost equation. And if we were able to get a prescription drug affordability board through at some point, again, Connecticut would be well positioned to control both major sides of the affordability crisis. Those conclude my comments. Happy to answer any questions, and I thank the committee for its time and attention.
Yes, thank you, Mr. Doolittle. And we did see we heard some comments earlier from the commissioner. I understand that there's currently May language, but I'm interested to see how this works in Rhode Island. And so specifically, a lot of the comments we've gotten from industry have indicated that right now rates are determined based on their actuarial justification, and that this would introduce some sort of additional metric into that. I just was curious how you see this lowering health insurance rates. If not actuarially justifiable, presumably they're not approved.
So the way I would see it working, Senator, is that for the first time, this would allow yourself and your constituents to have a window into the prices of the healthcare that underlie the premiums. What this bill does is it gets us down one more level. We're already looking at the premiums, but you can't really look at the premiums unless you understand the prices that they are based on. The price, for instance, that a Hartford Healthcare charges for a knee operation. And what this bill would allow for is to, for the first time ever, require the providers, such as hospitals, to explain and justify their pricing. Right now, we've got this weird system where there's negotiation between the health insurance industry and, say, the hospitals, but then most of those expenses are not even paid by either of those parties. They're paid by an innocent third party, the consumer. And what having a new public affordability process would be, would for the first time ever, give the consumer a seat at that table. And furthermore, Senator, and this is very important, having the hospitals and other providers know that someday they will have to explain their pricing will give the insurers substantial additional leverage during the price negotiation process. Right now, it's done in private. And if the hospitals know that, and other providers, I don't want to pick on the hospitals, but if high-priced providers know that they will be called on to explain and justify the pricing, then we will change the dynamic of the negotiations very much. And over the course of years, I believe there will be downward pressure on overall system prices and cost.
Thank you, Mr. Doolittle. Are there questions or comments from members of the committee? And, but before I pass it over to anybody else, just a quick question. You mentioned Rhode Island as a state that we can look to. Are there other states that you're aware of that have been able to incorporate this successfully? And just out of curiosity, how do their rates compare to ours? I know that there are multiple variables that obviously impact insurance.
I think really the best point of comparison is Rhode Island. They've had this in place for a number of years, and there are data suggesting that it has had a favorable impact. This is, you know, the next wave or the cutting edge, if you will, Senator. As I say, NASHB, which is on the cutting edge of healthcare policy, is promoting this. So right now is the time to make a move. As we all know, at the federal level, they have not been able to grapple in any significant way with the underlying prices of healthcare. Their solutions tend to be to throw money at the problem, to increase the subsidies in the ACA, and not have an inquiry into why the prices in our country are so much higher than they are in our economic competitors.
Thank you. And Representative Nuccio, you have a question?
Yes, thank you, Chairman. So Ted, you're speaking my language. I say this all the time. You know, we can't affect the price of insurance until we affect the price of healthcare. So if I'm hearing you right, and please correct me if I'm wrong, what your suggestion is that there would be another report that would show basically how the rates are derived, right? So negotiated contracts, it would be a layer of how we get to there based off of the cost of those services. Can you kind of give me a little more detail on exactly how you see this working and what's been successful in Rhode Island?
Sure. Well, yes, Rhode Island does have an inquiry, and Rhode Island's regulatory structure is different from our state, and they have, you know, they have a separate Office of Health Insurance Commissioner that has more impact over hospital pricing than we do. But the way it would work here, and it's important to note that the concept of affordability is really being worked on strongly in a lot of states, but certainly in Connecticut. The Office of Health Strategy has its affordability metric that is up and ready for use and available now for the commissioner to examine not just the prices of the premiums, because that's Representative Nuccio, that's only half the cost, if that, of the product. The cost of the product goes into the deductibles and so forth, the actual bills that are being paid by consumers. All that information is available, and under a new law such as this one, it would be clear that the insurance department has the authority to make those inquiries into the underlying prices that are driving the high premiums. It's not just look at the top layer of premiums, derive where those premiums are coming from, and are they excessive or are they affordable with prices underneath those premiums.
So would this then give us the opportunity, for instance, you mentioned what's happening in OHS, and we hear all the time about the number of incidents and the higher increase of cost for those incidents, and the power of negotiation when you are a large provider like Hartford Healthcare. Their rates go up and we don't know why. So this would kind of give us more insight into the why they're going up. If accepted, is that kind of the intent here?
Yes, I think so. And this is not the same as the system they have down in Maryland, where they just have a public hospital rate setting process. But it is in the same category of creating a public accountability moment for the providers, the high price providers in particular, be they hospitals or pharmaceuticals or others.
Okay, so one of the things that I'm always interested in is getting to the cost of care. When we see the increases in insurance and that, I'm one of the people who are saying, but why is it going up that much? And I know enough about industry to know part of it is definitely incidences and claims and understanding that. But then to dig down to that next level you're talking about, I think is where we get the information from Vicki and her team to say, yes, but incidences are going down, costs are going up. And I think what you're saying here, this bill, and I'd really be interested to see exactly what Rhode Island is doing, would help us kind of dig into that, which I think is where we need to be focused and where we need to go, because that helps all insurers across the board. So I'd like to set up some more time to talk to you if we can.
Terrific. Looking forward to engaging on that.
Perfect. Thank you so much, Chairman.
Thank you, Representative Meskers.
Yeah, I wanted to follow up with the commentary, Ted. We've spoken in the past. You know, the insurance industry has got us structured with, a myriad number of products, inclusive. I know you're not as big a fan of the high deductible healthcare plans, but I think incumbent on how we manage our healthcare and healthcare insurance is understanding the cost. So I think to the extent that this brings further disclosure to the consumer, it's super important. If I've got a $5,000 deductible and I need to go and get a shoulder or a hip replacement or any medical procedure, the disclosure is appalling. The amount of information or the price, it's so hard to get there. And to figure out what the negotiated rates look like and figure out where your deductible is going, that everything that improves both the transparency of the model and helps the consumer to be able to purchase the right healthcare policy or insurance policy is super important. So to the extent that this improves that disclosure, or how far away, I guess the question I want is, if my premise is correct, in what time frame do you expect we'll get to that better level of disclosure using this process?
Yeah, well, in terms of the time frame, it's a major new activity, and it would take time to develop. I want to say, and I want to say that the time between when Rhode Island passed a statute to when they had their first significant, affordability-based rate review season was like 2 or 3 years. So there is some lead time that needs to be had. And I would say that, this bill doesn't have any enforcement attached to it that I could see, any penalties or anything of that nature. But even the transparency, which was your point, Representative Meskers, can be very, very telling and very helpful. For instance, we have all kinds of disclosures when we go to the grocery store nowadays. This is organic, this is cage-free, this is pasture-raised, and those terms are defined. And if we can bring that level of description and accountability to our consumers on the healthcare side, products that are deemed affordable versus not affordable, that would be very helpful, even without any type of heavy penalties or anything of that nature.
All right, thank you. No further.
Thank you, Representative. Are you interested in, I mean, Mr. Doolittle, are you interested at all in piercing the sort of the plan design issue? So obviously, you know, if the cost of a plan is X, you know, as you mentioned, there's a mix between premiums and other forms of cost sharing. Is that something that you think that the state insurance department should be involved in terms of looking at that mix in terms of ascertaining affordability?
Yeah, absolutely.
And if
right.
so, how would we do that? I don't know if there's a sort of
So absolutely. Right now, as I've said today, and I'll repeat that, you know, we're only looking at half of the cost of healthcare, right? We don't go in, and maybe even not. I mean, on the health insurance exchange, Access Health, something like 90% of the health consumers there never reach their deductible. So what that means is 90% of them are paying 100% of their non-preventative medical costs. So that information is available. The plans have it. They use it to design their plans. And what an affordability review statute would make clear that the insurance department can and should keep track of those out-of-pocket costs, as well as the premium costs.
Got it. Thank you. Other questions for Mr. Doolittle? If not, thank you very much.
Thanks, everyone. I appreciate everybody's time on this important issue.
Mr. Clark, I don't see our next person in the on the panel. Is there a way to promote them?
Yes, I'm promoting number 7 from the public right now. And he will have to accept the promotion.
We're waiting on Dr. Aronow to accept the promotion. I think he's got his hand up. Dr. Aronow, we're not going to be able to hear you unless you accept. Oh, there he goes. Good morning, Dr. Aronow. Welcome. You're next. Dr. Michael Aronow. We were also hearing several legislators are scheduled to testify. I know that they're bouncing between multiple commitments, so we may return to them in a little bit. The next
okay.
one, yep. Good morning.
Can you hear me now?
Yep. Yes, we can.
Okay, thanks. Senator Lesser, Representative Wood, and distinguished members of the Insurance and Real Estate Committee, on behalf of the more than 200 orthopedic surgeons of the Connecticut Orthopedic Society, thank you for the opportunity to submit written testimony on HB 363, an act concerning health insurance reimbursement parity for podiatrists. I am Dr. Michael Aronow, a foot and ankle orthopedic surgeon in the Hartford area and immediate past president of the Connecticut Orthopedic Society. Thank you for the opportunity to share the Society's collective opposition to this bill. Health insurers, including Medicare, do not currently pay all healthcare providers the same amount for a specific service, even those in the same specialty. These are contracted rates negotiated between the insurance and healthcare provider practices. If this bill was enacted and a podiatrist contracted directly with an insurer, which of the multiple different fee schedules throughout the state for that service would be chosen? Would it need to be the highest? If so, then many of the other healthcare providers in the state would be paid less for the same service than podiatrists, and all podiatrists in the state would need to be paid at a higher rate. Would this bill lead to increased reimbursement to podiatrists, or would parity instead be obtained by decreasing reimbursement to all healthcare providers? This bill incorrectly assumes that the value provided by all service providers is equal. It implies that additional years of arguably higher quality training, education, medical, and osteopathic physicians receive as compared to other healthcare professionals as well as a relative increased scope of practice physicians maintain, has no value to patients or insurers. This bill also implies that all podiatrists practicing in Connecticut provide the same level of care and should be paid the same, despite some having done 3-year residencies and fellowships, including ankle surgery, and some doing no residencies at all. By analogy, would the legislature consider mandating that all legal work be reimbursed at the same hourly rate, irrespective of the experience, expertise, and track record of the attorney, or whether the work was instead performed by a paralegal? We're not aware of any data that indicates podiatrists in Connecticut are being paid less than other healthcare providers providing the same covered benefit. The data could show that some podiatrists are being actually paid more. Why would the legislature via this bill provide parity just for podiatrists and not for other healthcare providers, such as or including medical and osteopathic physicians? Furthermore, why would it be inappropriate for an insurer to pay a healthcare provider, including a podiatrist, more if they can provide a service more cost effectively with a better outcome and lower complication rate than another provider? Connecticut Orthopedic Society asked this committee to oppose this bill in its entirety. The bill is a dangerous precedent for all professionals who contract for their services, may increase costs to an already burdened healthcare system, and may adversely affect other healthcare providers and the patients. Thank you for your consideration of the concerns of Connecticut's orthopedic community.
Thank you, Doctor. Are there questions or comments for Dr. Aronow? Doctor, while you're here, I'm curious. Do you view that is there a problem for orthopedists if podiatrists are able to perform a similar service at a lower cost? Is that something that you feel that may result in steering by payers to that other specialties? Is that something that might adversely impact?
I don't think it's the concern. I think the concern is that mandating that all providers be paid the same, not taking into account experience, training, results. I mean, if one provider can do something and they use less expensive techniques, so they have a lower complication rate, so there's less cost associated with taking care of complications, it may be worthwhile to that insurer, and it may be beneficial to that patient, for them to get care. And it's not an issue of orthopedic surgeons need to be paid more than podiatrists. I just think that the state shouldn't be, saying that all providers need to be paid the same no matter level of training. And this particular bill just applies to podiatrists. If you're going to have a bill saying needs to be parity, why should the parity be just for podiatrists? Why shouldn't the parity also apply to physicians, nurse practitioners, PAs? So I just think it's a misguided bill. And also, I don't see any evidence that there is a need for it. I haven't seen any data that's saying this is a problem. So.
Thank you. Thank you, Doctor. And I was listening intently. I just had trouble finding the mute button on my computer for a second. Representative Comey.
Thank you, Chairman Lesser. Doctor, thank you very much for your testimony. I just wanted to comment really on, I have heard that it's really not, my understanding is that it's not so much a matter of the cost to do the procedure, but it's the reimbursement cost, the reimbursement. And I have heard, you said you're not aware of any disparities. I have heard, from companies that from the podiatrists that there is significant a difference in the reimbursement for the exact same procedures and the exact same coding on, that it is the same coded procedure on that. So while you may not see it on your end, the folks that are getting charged or that are getting reimbursed at a lower amount are reporting this as being widely, widely happening. So I didn't know if you had any comment on that.
Well, two comments. One is I don't know if they've actually showed you data. I'm not allowed to see what other orthopedic surgeons or podiatrists are being paid. I know I can find out what I'm being paid. So I think if I say that, I'm being paid more or less than somebody else, it's just my hunch, because, I'm not allowed to get the payment rate for every single, provider in Connecticut is the same service I do. So, I mean, if these people who have told you that can show you data saying that, that they on average or all of them are being paid less for the same services. I mean, most companies based on the code, not the provider. So I just, like I said, I haven't seen that data. I'm not sure where they would get that data from. So.
Thank you so much for coming here today, Doctor.
Thank you. Appreciate it.
Any other questions from the committee? Great. Thank you, Dr. Aronow. We appreciate you coming. Next up, we have Tim Fallon, followed by Eric George.
Thank you, Representative Wood and Senator Lesser, and other members of the Insurance Committee, Senator Wong and Representative Pavlak-D'Amato. And I also want to say hello to my friend and State Senator James Maroney, as I see him on the screen. It's good to see you, Senator Maroney. I'm here, for the record, my name is Tim Fallon. I'm the president of the Connecticut Retail Merchants Association. CRMA is a statewide group representing some of the world's largest retailers and many of the state's Main Street merchants. I'm here today to testify in support of House Bill 5383, an act concerning association health plans. I've submitted written testimony, so I won't read that, but I do want to make some brief remarks, and then we'll be happy to answer any questions you have. Today, I'm here to testify really on behalf of many of the thousands of smaller independent retailers that are located throughout Connecticut. And we appreciate you raising this bill. We believe that association healthcare plans is a viable option for group businesses like many of my members who want to lower their healthcare costs. And we certainly believe it's a better alternative for this committee to consider than a public option. The reality of health insurance is that while it's not a mandated coverage like workers' compensation or other insurance, no business in Connecticut can not offer health insurance to their employees. Yet the health insurance choices for Connecticut businesses, especially smaller retail businesses and many other types of smaller independent businesses, are not all the same. Small retail businesses cannot access the same rates on premiums, so therefore they cannot compete for employees with larger businesses that can offer more attractive health insurance packages for employees. What is in proposed bill, House Bill 5383, would allow organizations like CRMA to pool members together and then negotiate with carriers based on our collective size, just as big unions can and big business can. It levels the playing field for our businesses and our employees. Now, we know this issue has drawbacks, and we know that this bill as drafted may need additional work, but we want to make clear that our goal in this bill is not to eliminate any mandated coverages that are currently called for in Connecticut law. Rather, we just seek the ability to go into the market as a group to do our best to lower rates, to provide better choice for our members, which they can then offer to their employees. A similar concept of AHPs, in this case called cooperatives, is allowed in other states, particularly our neighbor in the north of Massachusetts. My counterpart in Massachusetts, the Retailer Association of Mass, now has a thriving group, and they've been able to give thousands of their smaller retailers real choice where they get health insurance and providing them real savings. We would like the same opportunity for our members here in Connecticut. So we think the time is now for this committee to give Connecticut retailers that same opportunity, and especially given the challenges that they've faced the past 2 years navigating through this difficult pandemic and facing a difficult economy. So I want to thank you again for raising this bill this year, and appreciate you giving me a few minutes to make these remarks, and I'd be happy to answer any questions you might have.
Thank you, Sam. And just one quick question. If this was passed, this would not just be applicable to the retail merchants, correct? It'd be applicable to all small businesses, right?
Absolutely. All small, it's not, we wouldn't make it exclusive to retail merchants. We would, well, obviously, we care about it, but any small group would be able to, sort of pool their resources, negotiate rates, go to the Department of Insurance, make sure everything is complying with Department of Insurance regulations, and then offer it to members for any interest, but would not be limited to just retailers.
Great. Thank you for that. Any questions from the committee? Great. Tim, thank you so much for coming on.
Well, thank you again for raising the bill. We appreciate it.
Next up is Eric George, followed by Tom Mangello.
Thank you very much, Representative Wood, Senator Lesser, Senator Wong, Representative Pavlak D'Amato, members of the Insurance and Real Estate Committee. My name is Eric George, and I'm president of the Insurance Association of Connecticut, a state-based trade association representing the property and casualty and life insurance industries. I'm here today to offer comment on numerous bills. I'll be as quick as I can. First is the Connecticut Department of Insurance's Insurance Holding Company Act. This would adopt the most recent amendments adopted by the NAIC, and it deals with group capital calculation, liquidity stress test for macro-prudential surveillance, and the continuation of essential services and functions to an insurer in receivership. It clarifies also the ownership of data and records. We've been working with the department on language, tweaking it, and you will be receiving from the department soon that language. Want to fully give our full support to sections 1, 2, and 4 of House Bill 5382. Another department bill that we strongly support is House Bill 5388, the value-added services and value-added products. This legislation would enact the DOI's recommendations on this area, and it will promote both innovation and technological advances in the Connecticut insurance industry. The NAIC recently updated its model act on the unfair trade practices, and this would reflect that. It also would reflect the department's bulletin on the matter. It would permit insurers to offer consumers various value-added products and services as long as certain criteria are met. I'd also like to offer comment on House Bill 5384, the peer-to-peer bill. We strongly support this. This will bring our current peer-to-peer law more in compliance with the NCOIL, that's the National Conference of Insurance Legislators Model Act that was adopted in 2019. The model law was developed after arduous and long discussions with all the stakeholders, including the insurance industry and the peer-to-peer industry as well. It deals with uniform measures for consumer safety, transparent pricing, and insurance coverage. That's the area where we are most interested in. So we do support the bill in terms of bringing the current law into greater compliance with NCOIL. Also want to offer comment on the standard non-forfeiture law, which is Senate Bill 359. We strongly support this bill. And finally, I want to also, I have to oppose something. So we are opposing Senate Bill 356. This is affordability in group health plans. Why is the IAC even talking about group health plans? Well, it's because a lot of our guys do offer group benefit plans. And what this does is it would introduce a very subjective standard of unaffordability into the decision rate-making process, where the Department of Insurance already has the ability to limit rate increases if they are, or decreases for that matter, if they are excessive, inadequate, or unfairly discriminatory. That is precise language, and the department is able to effectuate that language in its discretion. We don't believe that this bill is adding less clarity is not what we need. We need more clarity when we're dealing with insurance rating. I am happy to answer any questions.
Thank you, Eric. I was wondering if you can elaborate a little bit on your opposition to 356. You feel that it's redundant, basically, is what I hear, but like we are already able to do this through the Department of Insurance's scope?
Point one is, yes, it's redundant. It's unnecessary because the department already can do that. And what it wants to interject is a subjective, undefined term of affordability. Affordability, sadly, is not defined by everybody in the same way. Everybody's condition and place in the world is different than others. So it really creates an unknowable standard that we would have to be dealing with when a standard, a very precise standard, already exists.
Great. I appreciate that. So the definition of affordability would be interpreted differently. Okay, got it. Thank you for those comments, Representative Delnicki.
Thank you, Madam Chair. And good morning, Eric. Good to see you.
Good to see you too, Representative Delnicki.
I'm looking over your testimony pertaining to the NCOIL language and the so-called peer-to-peer ride-sharing law.
Sure.
Specifically, you make a reference in here clarifying that car sharing program agreement does not mean a rental car agreement, yet a person is renting, in essence, that car, that vehicle for a period of time. How do you clarify that, and how do you address that?
So I know that this was discussed and negotiated between the peer-to-peer industry and the insurance industry. And while I'd like to say that I'm a national, I have national entity ability, I don't. I am the Connecticut insurance industry. It was our national trades that negotiated that. I would encourage you, if we have peer-to-peer industry members coming to speak today, that they might have more clarity in terms of how that was landed on. That's what the NCOIL law does. Our greatest interest in the NCOIL law is the insurance piece. You and I have had conversations about this. The insurance piece in these areas is critical, because what you don't want to have is any gap in coverage. And we've seen this. This is how, you know, the insurance laws were developed for the transportation network companies. And this is very similar. And those are the Uber and the Lyfts for people who don't know TNCs. This is very similar to that.
So basically, though you put the definition in there that clarifies it as not being a rental, even though in essence it is a rental, you really don't have a solid knowledge on that. Is that correct?
No, that's not what I'm saying at all. I'm suggesting that you talk to the peer-to-peer industry as to why they asked for that to be in the NCOIL law.
Okay. Now, a person renting their car, or let me rephrase that, sharing their car. So they rent it to somebody. Do they have to disclose to their own insurance carrier? Say if I've got, say, State Farm. Would I have to disclose to my State Farm agent that, hey, I'm going to be in essence renting, or I should say sharing the car with someone? Would I have to disclose that to my insurance carrier?
If you are going to be in the practice of having your car available to be acquired by somebody through the peer-to-peer framework, I think it would behoove you to make sure that your insurance meets the standards of what a primary policy would be, that there's primary coverage. What you want to make sure is that if you're going to be getting into this, I think it is paramount that you talk to your insurance company to find out what you are covered for, what is also excluded. You don't want to have a personal policy that would exclude commercial activity and livery services. So that for somebody who's entering the peer-to-peer market as someone who's going to offer their car, I think it's in their best interest to find out what insurance coverage they have.
So then the person could find out very well that they would have to have livery insurance coverage or some kind of commercial.
What you want to make sure is that you don't have an exemption that would put you in a bad spot.
I like the way you put them into a bad spot, because looking at this, I have tremendous concerns. You made a comment in here provide additional requirements on the car sharing program to keep, and in certain instances, share records. What do you mean by that?
That's included. So that is what is in the NCOIL Act. Here today to talk about the insurance pieces. If you want to discuss those pieces, I do encourage you to talk to the peer-to-peer industry folks who will be coming afterwards.
Okay. Again, I maintain that there are more unintended consequences that meet the eye. And I'm going to be asking quite a few questions today on it. And I appreciate you coming forward, Eric.
Thank you, Representative Delnicki.
Thank you, Representative Meskers.
Thank you, Chair. In relation to this, Eric, thank you for your testimony. Thank you for your counsel during the terms of my service. I find you very informative. I don't think we always see eye to eye, but I think we always are clear in our communication and structure, and I think you provide a wealth of information. In relation to this and the questions from Representative Delnicki, I'm going to be asking your guidance as well as we move forward. There are two pieces to this. I want to consider the coverage that you're outlining and the risks in coverage for Liberty / peer-to-peer rental businesses, non-rental rental businesses. And I'd like you to have a conversation with your carriers and with the companies, Uber and Lyft. I want to make sure that we've got the adequate level of disclosure to the participants in the system so that they're signing and acknowledging the risk factors so that, you know, my concern, which we've opened up, is the can of worms, if you will, of the coverage. So I want to make sure that people who might engage in this commercial activity have fully eyes open in terms of the coverage and necessity of the coverage. You know, I'm a bugaboo on insurance and risks for your personal life and future. And the idea that you might have a car that gets into Uber and it has an accident, and you might have personal liability because you have the improper insurance coverage. I don't know if I want to lean on you in the industry on disclosure in terms of when people are renewing policies with some prominent wording in the renewal of insurance policies, or whether I want to make sure, or on the other side, whether Uber and Lyft, as they operate in Connecticut, make those disclosures very aware. I think it's the importance that people are safeguarded from unknown risks of being uncovered on the insurance. So I just would like to work with you on that going forward.
I welcome that. I wanted to say a couple things. First, I really enjoy working with you too, Steve. We don't always see eye to eye, but we do share in for, you know, thoughts and arguments, and it's been a very good give and take. Point number one, I want to make sure you know there already is a peer-to-peer law in Connecticut statutes. And so these would be tweaking the current law. That's number one. Number two, I just also want to make sure this is the peer-to-peer setting. This is not the transportation network setting. So this is not Uber and Lyft. This is the Turos and the other peer-to-peer companies. That's just for points of clarification.
Okay.
Thanks.
So on those, then make sure that's where I'm really particularly worried then, that I would hate to see people solicited for business without the adequate level of disclosure from the peer-to-peers. People need, you know, God forbid you're trying to make a couple extra bucks because you're in a bad financial situation and you're not covered.
Without, and you know, just like I said to Representative Delnicki, I do hope that you engage in a good, fruitful conversation with the peer-to-peer industry folks who are going to be coming later. I would think that it's in their best interest to disclose all of the requirements to their folks who are offering their cars for these services. So I would be just as interested as you are to find out how they are disclosing that to their vendors, if you will, for lack of a better term.
Perfect. Well, I expect that I will be supportive of the bill, and that those will be the issues that I want to make sure we clarify. So thanks.
Appreciate it.
Thank you, Meskers. Representative Delnicki.
Yeah, just to follow up, Madam Chair. NCOIL. Is it mandatory that a state has to adopt their guidelines as opposed to what guidelines a state developed in a previous public act?
Absolutely not. There's no requirement. There's no requirement, Representative Delnicki. Probably is important to understand what NCOIL is. So that's the National Conference on Insurance Legislators. We talk a lot about in this committee about the NAIC. That's the National Association of Insurance Commissioners. NCOIL is the equivalent for folks like you and other legislators who work in the insurance area. What it is it's a grouping of insurance legislators who do take on and tackle broad range topics. Peer-to-peer is one, but the Transportation Network Company is a different one. It's topics that transcend and go beyond state borders, where while there is no federal rule in place, a uniform standard is something that we try to achieve, because, you know, people don't know the boundaries between Connecticut and Rhode Island and Massachusetts and New York. They will traverse these areas, and to have a framework that is uniform is important. But to answer your question, you are under absolutely no obligation to ever adopt a model law. That's all they are model laws offered by any organization, whether NCOIL, NEIC, or otherwise.
So then, in our deliberations on this, we have to make a decision as to whether or not we want to preempt the law that was passed, the Public Act that was passed last year.
You're going to make the decision of if you want to amend the act that was passed last year. Absolutely correct.
Well, thank you, Eric. I just wanted to get that clarification, because I wasn't sure whether there was some sort of mandate that we would have to do something like this. And just to be clear again, the owner of the rental car, the sharing car, would have to, or should, disclose to their insurance carrier that they are engaged in this business, this commercial business, so that they have the appropriate primary insurance on their car. Is that a fairly accurate statement?
Absolutely. And I mean, if I was entering into, and I can only go from my own point of view, if I was entering into a concern, a business concern, meaning that I'm going to be starting a new way of making money, and it's going to involve my automobile, you darn tootin' that I would make sure I know exactly what is in my policy, exactly what is covered. I would recommend that anybody who goes and takes on such an endeavor do the exact same thing.
Good advice. Thank you. Thank you, Madam.
Representative Melnicki.
Thank you, Representative. Are there other questions for Mr. George? Seeing none, thanks for being with us, Eric.
Thanks, Senator. Nice to see you. Take care.
Nice to see you too. Next up, we have Tom Mangello from the Connecticut Bankers Association.
Good morning, everyone. It's great to be here. It's been quite a while since I've been before the Insurance Committee. I'd like to thank the chairs, the ranking members, and the members of the Insurance Committee for the opportunity to testify today. And I have to give a quick shout out to Chairman Lesser, Chairman Woods, and they both represent my hometown, Go Newington. I'm here on behalf of the Connecticut Bankers Association and the banks across the state that we represent to support and urge the passage of Senate Bill 357, dealing with copay accumulator programs and high deductible health plans. As you may know, a number of our banks offer and administer HSA accounts to the businesses and the people of Connecticut. Last year, Public Act 2114 created a cost-sharing approach on HSA qualified health insurance plans that, in the view of subject matter experts we consulted, conflicts with IRS requirements for HSA qualified plans. That conflict would prevent many HSA account owners in Connecticut from continuing to contribute to or get tax deductibility from their HSAs. This came to light when the IRS wrote a letter to the Illinois Insurance Department last year, stating its position that these types of laws conflict with the IRS requirements for HSA qualified health plans. By the way, 11 other states that we know of have passed laws similar to Public Act 2114 and may also be impacted by that IRS ruling. Of those states, several of them are actively considering amending their laws to address this issue. I believe Virginia has already passed a fix. Illinois and Oklahoma are the furthest along behind Virginia. It's important that Public Act 2114 be amended to ensure that Connecticut residents with HSA qualified plans have uninterrupted use of their plans and they don't experience any negative tax consequences, or as I call it, a continuity of tax deductibility amongst other issues. With that said, I'm not a subject matter expert on the complexities of HSAs and last year's law. However, I am pleased to report that we've invited just such an expert from the American Bankers Association in DC, and that's Roy Ramthan, who I believe is 23rd in line to testify today. As such, I'll defer any questions over to Roy. Before I close, I'd like to thank the committee for raising this important bill, and the Department of Insurance and the Office of the Healthcare Advocate for working with all the stakeholders in crafting this legislation. Thank you again for the opportunity to testify through you, Mr. Chairman.
Thank you, Tom. It's good to see you. And I will save some of my technical questions for Mr. Ramthan then. I just wanted to ask sort of on a high level, we did hear from 13 patient advocacy organizations this morning who understood the need for this legislation and protecting the deductibility of HSAs, and that makes total sense to me. They offered a slight language tweak that they thought would be potential compromise. I'm not going to ask you to weigh in on their language. Obviously, we'll have to talk to the experts on that, but just wanted to see if conceptually you'd be open to talking to some of the patient advocacy organizations that had supported this legislation previously to see if we can come up with some strong language that accomplishes the goal that I think we all want.
We'd be happy to. Thank you for that offer.
Thank you, Tom. Are there questions for Mr. Mangello? Seeing none, thank you so much for sneaking over to the Insurance Committee today.
Thank you. Have a great day.
Thank you. You too. Next up, we have, I think, is Representative Borer back?
I'm back.
Hello, Representative Borer.
Hello, and thank you for your patience while we're, bumping in between meetings here. I was on and then I had to go to public safety, but thank you for indulging me. You ready for me?
We sure are.
Okay, so then good morning to you, Senator Lesser, Senator Wong, Representative Carrie Wood, Representative Pavlak D'Amato, all the members of the Insurance Committee. I'm Dorinda Borer. I'm representative of the 115th District, West Haven. And I want to thank you for allowing me to testify today in strong favor of Bill 358, an act concerning required health insurance coverage for breast health benefits. This is a bill that I've been championing for a few years, and a bill that I know that you, Senator Lesser, Representative Wood, Representative Turco, so many of you have been equally passionate about and worked on. As Representative Turco mentioned earlier, I heard his testimony. This bill passed out of committee last year, and it passed with great bipartisan support in the House, 145-1. But as we know, the Senate ran out of time, and therefore this bill is back on the table this year as a priority for all of us. For our audience who may be new to the subject, I just want to acknowledge that the reason it's critical for coverage for ultrasounds for breast cancer detection is that we know that mammograms do not always detect abnormalities, as the dense breast tissue could hide or mask those abnormalities. And for clarification, dense breast is not related to the size of the breast, it's related to the type of tissue you genetically have within your breast. I am a woman with dense breasts. I'm sure many of you have dense breasts, as 45% of the population has dense breast. Many years ago, it was through the work of the Are You Dense organization and Nancy Capello, who was their leader, who had breast cancer, who has since passed away. Her organization really led the way to pass a law in Connecticut that requires notification if you have a mammogram and it's detected you have dense breast, that you receive a notification saying you have dense breast and this may not be a complete detection tool and you would benefit from an ultrasound. So we were a leader in the nation when we passed that bill at that time, but since then we've fallen significantly behind, and now Connecticut has the unfortunate distinction of being number 2 in the country in breast cancer incidence. So after many years of inaction in this area, finally in 2019 together we passed landmark legislation for Connecticut with respect to insurance coverage for ultrasound screenings. But this will now take that one step further and really brings mammograms and ultrasounds into alignment, as it will cover the ultrasounds for diagnostic purposes as well. When I was first elected, I asked my gynecologist, what is the one bill that would be a game changer for in the field of women's health care? And this is what she said was critical. Having coverage available for women and men who can't afford the necessary preventive and treatment care for breast cancer was critical. So we as a legislative body have continual conversations about how we can bridge the gap between healthcare for those who have and those who have not. And this bill will be one more step in that direction, and covering the biopsies and the mastectomies for those who are in the most critical time and stressful time in their lives is paramount as well. So, you know, my heart goes out to those who have breast cancer, those family and friends who have lost someone to breast cancer. And we're in a position to help change that going forward. And this is the year I'm confident with all of you and your leadership that we will be able to do that. So in the words of our great advocate, Jan Chrisman, I thank you, my breast friends, for all the work that you do and your consideration. And I am available for any questions.
Thank you so much, Representative Borer. It's great to see you. You are always welcome in this committee, and just want to thank you for all of the advocacy you've shown on this issue. I know you're passionate about it, and I see that Senator Wong has some questions, and I'm going to get to him in a second. But I don't think I'm too out of place with saying that even though we ran out of time to get to this last year, I think that Senator Wong and I are both, really interested in this issue, and hopeful we'll get this passed this year.
It's a Senate bill, so you're going first.
We know we're on. Yeah, we're on the hot seat. So thank you so much, Representative Borer, for that. And I know we are on the shoulders of giants, folks like Nancy Capello, and of course my own constituent Jan Chrisman, who's just been such a fabulous advocate. Senator Huang, do you have any questions?
Thank you, Mr. Chair, and welcome, Representative Borer. Indeed, you've been a true champion of this issue for many years, and I know you also serve on the working group in regards to women's health. As the ranking member in public health, we have seen the good work of your working group. So thank you very, very much. And indeed, it will come up in the Senate first, and I will offer from my personal perspective that we simply did run out of time, that there was widespread bipartisan support. And indeed, there are many other legislators, Republican and Democrat, that deserves to be acknowledged. I wanted to also acknowledge that the debate has also been focused on the relative cost of such a mandate. It'd be important to address that, but I think from a standpoint of preventive care, diagnostic, this is worthy of an investment to look at preventive health, that it is a worthy endeavor to impose that mandate, but we must recognize that it is an additional cost, but it is worthwhile in my mind. But I think the other important part of it is that during this COVID, we have seen dramatic increases, either for a lack of following regular testing. If this may be a PSA, is to encourage people that despite these COVID times, that your preventive healthcare appointments need to be kept, that you need to take care of yourself on all of your healthcare needs. So the alarming data is another initiative or impetus for us to look to address this bill. So thank you for your tremendous leadership, and all of your members of the working group that have pushed for this, men and women that have advocated for this. So thank you, Mr. Chair, for allowing me to acknowledge the great work of Representative Borer. Any thoughts on that in regards to the diagnostic numbers and the mandate challenges?
Yeah, you make an excellent point. Unfortunately, when we pass bills, all we get is the cost, right? There's never a cost benefit analysis. It never talks about the return on investment. Preventive care, as you said so eloquently, when we cover preventive care, we actually save money in the long run, not to mention the ultimate goal is just to save lives. So we always have to look at, the flip side of what we're, saving, for lack of a better word, when we help cover preventive care. And as far as the public health working group, I just want to give a shout out to Jillian Gilchrist, because she really led that charge for that group. But thank you. And I know the Senate was, as I said, equally passionate. It was just a matter of timing. So I'm really confident this year that we're going to be able to get it over the finish line.
Thank you. And if I may, just an additional input or clarification for you. Many may not know about the dense breast ultrasound, which is an additional cost, but it obviously is another level of diagnostic for many women that you cited. The percentages are alarmingly high that do not get the normal mammography diagnostic. So could you, just for the edification of us in the public hearing, explain dense breast ultrasound, how that is a different procedure?
Yeah. So so again, the mammogram, it's a different detection tool. And if you have that dense breast, that particular tissue will mask abnormalities that a mammogram, the function of the mammogram does not pick up, may not pick up, may and may not. So the ultrasound can penetrate that dense tissue and look for those abnormalities that the mammogram may not. So if you're going for a breast cancer screening and you have dense breasts, you're only getting half the picture, right? So if you're going to make your appointment and get your mammogram, why walk away without getting a complete picture? Many have gotten mammograms that have missed abnormalities. And I saw in the public testimony, we heard from a lot of breast cancer survivors that if it wasn't for their ultrasound, their breast cancer would not have been detected, and they may not be here today.
Thank you. And indeed, our thoughts go out to many of those who have suffered, not only the patients, but also their family that support them. But ultimately, if we can leave with a note on this, regardless where this bill, and I hope we pass it, is early diagnostics and testing and diagnostics is absolutely critical. Early prevention and diagnostics is absolutely critical. So I thank you for your tremendous leadership on this, Representative Ward.
Thank you. And just want to also put out to the committee that I asked OLR, Office of Legislative Research, to put together like a little, like almost like a cheat sheet, because it's a complicated matter, what mammograms cover versus ultrasounds versus MRIs, and what the law covers and it doesn't. So I'm happy to share that with all of you so that you have it at a glance and you don't have to read through all the language of the laws to, catch that.
Thank you, Representative. I think that would be hugely helpful. Senator Wong, are you all set? Anything else? Okay, great. Representative Bora, I just had one other question. We've gotten some testimony today urging inclusion of some language that would address a different disease, ovarian cancer. And I would never ask us to pick between two different public health problems. Obviously, we're going to have to look at that language on its own, and it's going to, live or die on its own merits. But I wanted to just see if conceptually you had any opposition to potentially including it, if as long as it doesn't sink the bill that we have here that came so close to passing last night.
Absolutely, absolutely. Include anything that would help detect cancer. We should be. Ovarian cancer is called the silent cancer for a reason, because it's not until, it's kind of like pancreatic cancer, until you have symptoms that appear, you typically don't know you have it. So detection tools early on are critical to saving lives.
Great. Thank you so much, Representative. Look forward to working with you.
Thank you all.
Next up, we have Sarah Lemaster.
Good morning, distinguished leadership of the Insurance and Real Estate Committee. My name is Sarah Lemaster, and I am the Manager of Government Relations and Public Policy for the Community Health Center Association of Connecticut. I'm submitting testimony on Senate Bill 355, an act establishing the 340B Drug Pricing Non-Discrimination Act. Connecticut's health centers collectively serve over 380,000 residents every year and specialize in providing care for traditionally underserved communities. 20% of our patients identify as Black, 48% identify as Hispanic or Latino, and a majority receive Medicaid benefits. Our health centers serve residents in every legislative district. They operate over 100 locations throughout Connecticut and deploy over 3,000 people, and have an estimated economic impact of over $800 million. The 340B drug discount program has been in operation since 1992 and has helped hundreds of thousands of Connecticut residents manage their healthcare by giving them access to low-cost prescription drugs. The original purpose of this program was to address the issue of manufacturers reducing voluntary discounts to safety net providers in the wake of the Medicaid drug rebate statute. These safety net providers relied heavily on federal financial assistance as well as other sources of community support, and the loss of those voluntary discounts posed a real threat to their ability to continue offering services. Health centers also use revenues from this program to cover operational costs and invest in community health programs that improve patient outcomes. These investments include things like helping people access fresh fruits and vegetables at local farmers markets, helping uninsured patients purchase medications that they could not otherwise afford, integrating care and other services that greatly benefit health center patients in their communities. There have been two major threats to the 340B program in recent years, which I'll go into detail on a little bit. One of them is discriminatory contracting, which refers to the pattern or practice of third-party payers and pharmacy benefits managers establishing discriminatory contracting terms based solely on 340B eligibility or participation. This requires 340B claims identification, imposing additional fees and reporting requirements, prohibiting mail order services, and redirecting patients, which limits patient choice. As a result of this practice, pharmacy benefits managers are able to divert 340B savings away from health centers and directly to the for-profit corporations that they work for. Health centers often have a lack of options in this situation and are forced to sign discriminatory contracts at the risk of forfeiting their savings and the resources that they need to support essential primary care services. This practice limits the capacity of health centers and hinders their ability to reduce health disparities. Additionally, over the last 2 years, drug manufacturers have willfully refused to honor their statutorily required 340B price for covered entities, where this drug is being shipped to and dispensed by contract partners of health centers. Our health centers have over 100 locations throughout the state, and this geographic spread allows us to reach deep into the pockets of communities that have limited access to care. Due to the cost of running these locations, most health centers
Thank you. Your 3 minutes has concluded. Can you please summarize?
Thank you. And each of these sites and health centers use contracts with local pharmacies to secure access to prescription drugs. Recent actions by these 14 major drug manufacturers have threatened the integrity of the contract pharmacy model, which is vital to making sure that our patients can access drugs. This bill addresses many of these issues. Additionally, when we submit our testimony, we'll be proposing some language that will help to strengthen certain aspects of the bill. Thank you very much for giving me the opportunity to testify, and I'm happy to answer questions.
Yes, thank you, Sarah. And I want to just say that, I first learned about in detail about the 340B program when we looked at the insulin issue a few years ago and discovered that the 340B lifeline was a program was a lifeline for low-income residents of the state who were accessing affordable insulin through community health centers. You mentioned almost in passing that major drug companies have now violated federal law and by pulling out of the program or imposing restrictions of participation that are not authorized by law. Is that accurate? Are they now violating federal law on this?
So there's currently ongoing litigation at the national level. I don't have the details on the exact status of that lawsuit. It's sort of in a lot of different places. What I can tell you is that the program needs protection. It needs statutory legislative protection. If we protect it at the state level, we will be taking important action to ensure that patients can continue to access these drugs. I can get you more information on the status of where all of those different pieces of the violations are. But the language in this bill, and in addition to the language that we'll be proposing, will help to protect the integrity of this program and protect access to care.
So the language of this bill, and I think this is a NCOIL Model Act, and I know that there's a variety of bills around the country. I think Arkansas passed a law that addresses the issue, but this bill seems to target pharmacy benefit managers. My understanding is that the federal 340B program focuses on drug manufacturers. Do you have any thoughts about how we should, where we should look to as states that are sort of grappling this issue to sort of make sure that we're within our authorities as state, and making sure that low-income residents have access to the drugs that they need? Is there a specific place that you would encourage us to look at?
So there is currently legislation that's being proposed in the state of California to address some of the concerns that you've outlined. The language that is currently under consideration in California addresses some of the issues that were highlighted in the Arkansas bill, and we believe that it greatly strengthens the statute. That particular language actually strips out pharmacy benefits managers altogether and protects protects the entirety of the 340B program. So I realize that's somewhat ambiguous, but so like I said, we will be submitting that language as a proposed change with our testimony.
Thank you. I may have additional questions, but I see that Senator Anwar has his hand up, and I want to make sure that I know Senator Anwar has a lot of places to be, so I want to be sure he has the opportunity to go. Senator.
Thank you, Mr. Chair. Thank you so much, Ms. Lemaster, for your testimony. I wanted to talk a little bit about the federally qualified healthcare centers, the community centers. What percentage of the total population of the state of Connecticut are you providing care to?
We provide care to approximately 10 to 11% of the entire state population. I'll also add that we are a vital part of the healthcare safety net. We are where people turn when they need care. During the course of the COVID pandemic, our health centers have provided over almost 1 million COVID tests to patients. We've fully vaccinated over 395,000 people in the state. So not only that, but we also provide care to people who are the most vulnerable. So we provide care to people who have difficulty accessing it. That's part of why, like I said, we have over 100 locations throughout the state. Being in all of those places allows us to reach deep into those pockets of people where it's difficult to receive care. Additionally, a lot of, like, as I mentioned earlier, a lot of our patients come from communities of color. So in order to be a federally qualified health center, you have to serve a certain percentage of patients that are in what are called health professional shortage areas. What that means is that those are places around the state that have a low threat or a low number of health professionals able to offer primary care. So health centers set up there. We offer primary care, dental, and behavioral health services. I'll also mention that the model of care that we have, it centers around making it easy to access healthcare. What that means is we offer same-day medical, dental, and behavioral health services. We also center around removing as many barriers as possible. So figuring out if we can get patients to and from our health centers easily. So anything to support health centers supports our overall public health infrastructure. Thank you. Sorry, I realized that was more answer than we needed. But
No, this is important because again, you are providing, the centers are providing the comprehensive care to the most vulnerable in our state. And the most vulnerable in our state include majority of the population being Medicaid, also the remaining being without insurance. So your reimbursement is minimal and your margin of survival is very little. Is that a fair statement?
that is a fair statement. I ran some numbers a little while ago, and for the year of 2020, our health centers overall operated at a loss of $20 million, and that's partially due to a drop in revenues from the 340B program. So we're not asking. So, like I said, we support care for the most vulnerable. We also offer care to the uninsured. We served 70,000 patients last year that were uninsured, and that uninsurance rates. There is a wide range of people who are in that demographic, but it's people who are very vulnerable to, and offering care to those communities is vital to supporting not just our public health infrastructure, but all of the things that those people do to support our economy.
So and if what I'm trying to get to is that if we don't fix this 340B bill and the attack on your survivability or your sustainability, the 10% of our most vulnerable in our state would not be able to get healthcare. Because this is part of the sustainability of the federally qualified healthcare centers at this time.
Yes, it is a vital part of how we sustain ourselves. Our health centers have worked very hard to limit the interruptions in care that this drop in revenues has caused. But I will add that it's made it difficult to offer the additional services that really improve our ability to make healthcare better. So like I mentioned before, it's, helping people access one of the big things this program does actually is it helps people who do not have health insurance access prescription drugs.
And my final question is this assault that the PBMs have had on the healthcare centers across the country. I think we are not going to be the first state to look at this. Do you know the other states that are trying to address this issue to make sure that they continue to provide the care to the vulnerable in their states?
I know that a lot of my colleagues in other states have proposed legislation in their legislatures. As I mentioned earlier, Arkansas did pass a bill last year. There's currently a bill under consideration in the state of California. I have additional colleagues in other places that are taking a really hard look at this legislation. And I think the important thing is that this is something Connecticut can proactively do to protect this program.
Thank you. Thank you so much. Thank you, Mr. Chair, for allowing me these questions.
Thank you.
Yes, thank you, Senator. And we've heard from the industry that the pharmaceutical manufacturing industry concerns that the savings are not passed on to consumers, that they allege that it goes to the bottom line of health centers and safety net hospitals and family planning clinics that are able to access the program. That's not really what I'm hearing from my constituents. I know that we were, particularly the price of insulin is something, that is of major concern for uninsured residents of the state and for people who have high deductible plans. Can you just speak to, the real world impact you're hearing from people who access healthcare through health centers right now? If you have any specific information, that would be helpful. And I know that there are other folks who have questions.
So that's a really good question. I think that it's, as I mentioned earlier, that to sort of answer the question that the industry is asking, I did the math, and health centers operated at a $20 million loss in 2020 overall. So the revenues from this program have been absolutely vital to supporting the services that we offer. And not just that, but they also support the sort of wraparound care that health centers do. A lot of the work that the work that health centers invest in involves care coordination and enabling services. And those are things that are not necessarily covered under Medicaid, but those services enhance access to care and reduce overall healthcare costs by providing that extra level of support for patients that have these chronic health conditions. So that's one of the things that we do. And additionally, it's news to me that health centers are using this program to increase their own bottom lines. The numbers don't add up for that.
Yeah, no, I appreciate that. I guess I just was asking a slightly different question. Do patient, when the 340B program is working, right, and there are no hurdles that are outside of federal statute, my understanding is that provides the second cheapest set of prescription drugs to low-income residents. I think only the Federal Indian Health Service provides lower cost drugs. Is that savings provided to the actual?
Yes, yes. Thank you for asking the question. Thank you. So yes, that savings is absolutely passed on to patients. When I started working on this issue in 2020, I met with an advocate that told this amazing story about how they, it was heartbreaking, really. They were on their last vial of insulin, and their choices were to go to the emergency room or buy insulin. They found a federally qualified health center. That health center enabled them to get insulin that they could afford. Through this program, health centers are able to offer prescription drugs at a very, very low cost to people whose insurance does not cover the cost of their drugs, or when the cost of their medication goes up. The model of health centers is to enable everyone to access care regardless of the cost, essentially. So the savings are absolutely passed through to patients in every case that I have heard of, and the health centers designed this program to enable patients to access drugs at an affordable price. And an affordable price is different for everyone. If you cannot afford your drugs, they make it so that you can afford your drugs. I think that's the easiest way to explain it.
Thank you. When we talk to the industry, they often cite some extremely low prices that may be, in some cases, below their marginal rate of cost of production for the 340B program. But when I looked into detail into how the 340B pricing rules are set, the formula that's used by the federal government to set prices under this, my understanding is it actually kind of dovetails with one of the governor's bills that we heard this year. So the governor is proposing efforts to address price increases for drugs that are already on the market. There's always the question when you talk about prescription drug pricing about balancing the need to, for innovation and to create incentives for innovation, with the fact that our consumers are paying the highest prices in the world, and how do we sort of square that circle? But my understanding is that the 340B program works by requiring a larger discount the more the price of an already existing drug increases. So that companies have a disincentive to raise prices for drugs that are already on the market. And so some of the drugs that have the lowest prices, the biggest discounts under the 340B program are drugs that have seen huge recent price increases after the innovation, after they were already marketed. Is that your understanding? I'm not asking, I don't know if you're an expert on 340B pricing rules, but that's my understanding of how the 340B program works. Does that sound right? And I'll ask other folks who come after you as well.
I don't have enough knowledge at this moment to answer that question, yes or no. I can ask I have colleagues that have much more expertise in this program, and I can get that information to you.
Great, thank you so much. Representative Nuccio.
Thank you, Mr. Chair. And thank you, Ms. Lemaster. I have a question because I don't know if it's just not clicking in my head or not, but I'm trying to figure out. You mentioned that your revenues are down, and I'm wondering how 340B ties into that. So what is it about this legislation that's going to help balance that?
Thank you. That's a very good question. So the pandemic impacted health center budgets significantly, as it impacted many other entities in the health industry, in the healthcare industry. The 340B program had historically has had a significant. It has supported other programs within health centers. So briefly, part of the way that the program works is that health centers are able to get a reimbursement for the full cost of a drug. And I can go into more. I'm happy to meet after about this. It's not the easiest program to explain, but this at the begin when this started happening, when drug manufacturers started placing restrictions on shipments to contract pharmacies, and when these other issues started springing up, it had a significant impact on the revenues that health centers received from the 340B program. And the pricing structure is the 340B program is structured such that health centers are able to get some amount of revenue from the program while still being able to offer low-cost prescription drugs to their patients. And this had this had a significant impact on their ability to receive those revenues. This was coupled with a lot of other issues related to the pandemic, a lot of workforce issues and needing to purchase additional equipment and PPE and all of that. The 340B, the attacks on the 340B program limited their revenues from that program, which contributed to their overall budgetary issues. So it's not the only thing that has contributed. It is one of the things. I will add that the federal government has in 2021 they gave health centers a significant amount of ARPA dollars that helped to sort of make adjustments for those revenue deficits. But without that federal funding, health centers would have been financially compromised in many in some ways. So it's I will add that health centers use these resources to invest in other programs that promote community health. So that includes it includes care coordination. It includes a bunch of other sending mobile dental and medical vans out to communities. It's a lot of different things that health centers do to enhance their ability to offer their communities care.
Okay, so I just want to make sure, I think I'm hearing you. Basically, you're saying that you guys are able to apply for the rebates and you're getting more money back in the rebates. And then you're taking that money and you're socializing it over the cost of care. You're still providing the drugs at a lower cost, but you're using the differential between the rebates and what you're actually getting reimbursed for from the people to provide, like to kind of spread it over. So you're using all the rebates to lower the cost of care for your business and using the rebates to provide healthcare offerings to other people.
Yes, thank you. That's you put it much more clearly than I could. Thank you.
I think that's what I'm hearing. Okay, so the only thing that I'm hearing back from industry really is around the part of this legislation, and maybe Chairman Lesser, you can help kind of with this piece. But the only thing that I'm really hearing is around the modifier language and the ability to be able to have that modifier on there. I don't think anybody's really pushing back on the 340B per se for the federally qualified healthcare centers, but I just wanted to make sure I had it right in my head as I'm going forward. So I think I'm good. Thank you so much for your help.
Thank you.
Yes, thank you, Representative. And I'm sure we will, as we look more closely at the language, I think we're going to drill down into that question. Thank you, Representative Nuccio, and any other questions for Sarah LeMaster? If not, thanks so much for being with us today, and appreciate your testimony before the committee. Next up, we're going to return to number 13, Gina Calabro. Ms. Calabro, welcome.
Thank you. The co-chairs, Senator Lesser, Representative Wood, and esteemed members of the Insurance and Real Estate Committee, my name is Gina Calabro. I'm testifying today on behalf of my mother, who was a lifelong resident of Connecticut, because she can't. She died in 2017 from ovarian cancer at the very young age of 60. I am asking that the committee expand the pending bill SB 358 to explicitly require insurers to cover surveillance measures, screenings for women at heightened risk for ovarian cancer. I am one of those women, and your colleague, my sister, is one of those women. Ovarian cancer is a thief, and it's sneaky. More than 80% of cases are diagnosed late at stage 3 or 4. Their survival rates are terrible. The 5-year survival rate is less than 50% for all women and only 40% for Black women. The CIMICs mimic benign gastrointestinal issues. The cancer is the leading cause of death among all gynecological cancers, and there are minimal screening tools available, although there are some. Connecticut should endeavor to be a leader among the small number of states that require insurers to provide screenings for at-risk women, including testing for the genetic mutations that in some instances can increase your risk for ovarian cancer to as high as 60%, transvaginal ultrasounds, and CA-125 serum tumor marker testing. I was fortunate to receive testing for genetic mutations shortly after my mother died. I fortunately was in a financial position to pay for the testing had it not been covered by my insurance, but the vast majority of women are not in the position to do that. And there's a real equity issue here created if screenings are not covered by insurance. You have the power to take steps to make sure that they are. My mother was diagnosed with ovarian cancer in the emergency room at the hospital on a Sunday. She had been back and forth to her doctors several times in the weeks leading up to her death for a variety of symptoms. No one figured it out until that Sunday when she had a transvaginal ultrasound and a CAT scan in the emergency room. By then, the cancer was everywhere. It had metastasized to her abdomen, her lungs, and her liver. And the very next day, less than 24 hours after we learned of her diagnosis, she died from complications related to her cancer. They caught it too late. I can't adequately put into words the pain her death caused our family, her husband of more than 40 years, her 4 children, and her granddaughters, my daughters. I'm asking that you take this opportunity to expand SB 358 to include mandatory insurance provided screenings for ovarian cancer. And to my sister, Kara, Mom would be so proud of you. Thank you for your time today.
Thank you, Ms. Calabro, for your testimony, and I believe I did know that your sister is Representative Rochelle, who is on this committee, and I knew your mother not well, but I know that I can only imagine that she would be so proud of your advocacy for other women to keep them from going through the horrible tragedy that she did. And I had the opportunity to ask Representative Boer earlier if she would entertain adding this language to the bill. And obviously, we're going to have to look at it and crunch some numbers and make sure if we can stand behind it. There's some. Anytime we pass a requirement on insurance, we have to look at the cost of it under the federal law. But she indicated that she thought it was a good idea, and I'd be interested in working with you to see if we can do this. And I do know your mother's story, and it's heartbreaking. And I'm just so glad that you're advocating for other women to keep them from going through what she went through. So thank you. Are there any questions for Ms. Calabro? Yes, Representative Rochelle.
I just want to say thanks to my sister, Mom, and be proud of you too. Thanks for advocating for her today.
Thank you, Representative. Any other questions from members of the committee? Okay. If not, thank you so much for being with us here today. I know you're juggling a lot of things, so I'm glad we were able to hear from you.
Thank you.
Thank you. All right. Next up, we have a group of folks from Turo, led by James Bangasser, Sean Vick, and John Heath.
Well, thank you, Chair Lesser, Chair Wood, and distinguished members of the committee. My name is John Heath, and I am the Senior Manager of Government Relations and External Affairs for Turo, the world's peer-to-peer car sharing leader. I am joined by our distinguished and capable legislative counsels, Sean Vink and James Bassinger, who will certainly be available should members of the committee have any detailed questions. I am here to ask your respectful consideration and support of House Bill 5384. Quickly, the bill basically has four major objectives. It builds upon the work that members of the legislature did last year, establishes a peer-to-peer car framework that ensures safety of Connecticut residents and visitors. Additionally, it ensures that there are no gaps in insurance coverage during the car sharing period. Additionally, it obligates the platform to assume primary responsibility as it relates to insurance where it fails to maintain the necessary documentation. And then lastly, it reiterates and reinforces peer-to-peer car sharing as distinct and separate from other transportation businesses, including traditional car rental and transportation network companies. I'd like to say that I am a native of Connecticut, growing up in Hartford and graduating from South Windsor High School. My mother was the office manager for the State Elections Enforcement Commission, and I have fond memories of sitting in that boardroom, Mr. Chair and Madam Chair, looking at the Gold Dome, hoping and wishing one day I would be able to work in that incredible building. And while this is virtual, I believe my late mother would be proud of my time with you. And I thank you so much for the privilege to speak with you. And my colleagues and I are available for any questions that the committee has, Mr. Chair and Madam Chair.
Thank you so much. And yes, we would love to have you back in person one of these days if we ever get back to that.
Thank you, Mr. Chair.
And just quickly, I know last year, I think a lot of members of this committee are trying to get up to speed because last year, another committee, which won't be named, stepped on our toes and decided to legislate insurance matters. And so, I think we're looking to get our heads around this. And there's some competing interests and balancing consumer protections while also fostering innovation. Just on a high level basis, what are the big differences between what this model act that you're proposing here does and what the transportation, I said I wouldn't mention their name, the other committee did last year, and anything that seemed like the big areas of dispute between the two.
Sure.
The two ideas.
I'll let my colleagues dive in, James and Sean, but the most important thing, Mr. Chair, is that we wanted to ensure that the insurance portion related to peer-to-peer car sharing was much more solid, much more comprehensive. But James and Sean, please jump in.
Sure, I can start off. James, feel free to jump in if you'd like. So I think
I'm sorry. Can you please identify yourself for the record?
Oh yes, excuse me. My name is Sean Vink, and I'm Associate General Counsel at Turo. Thank you for the opportunity to be here today. Just briefly, the Transportation Committee, the committee that passed the bill last year was utilizing an earlier version of the NCOIL model, which was updated last year to version 2.0. So the changes that are reflected in this legislation are meant to align Connecticut's law with the most recent version of NCOIL. And there are a number of technical changes, but it would have to do with aspects of definitional clarity. So making sure that there's clear distinctions between the rental industry and peer-to-peer car sharing so that there is not ambiguity over which regulations apply or no duplication of regulatory structure. And then certain things that relate to clarity about the duration of the car sharing period. So that's very important because that tells us what insurance coverage is in place at any given time and make sure that the platform is able to meet its obligation to ensure that there is coverage for the driver and also for the owner during the entirety of the car sharing period.
Thank you. Mr. Bagasser, did you need to add anything, or is that?
Well, I'll introduce myself. My name is James Bangasser. I'm Senior Legislative Counsel for Turo. No, I think those hit the top line points. I would just say it's not oppositional to the bill that was passed last year, but rather clarifying it and cleaning up is the way I would put it.
Great, thank you. And I see there are two, Representative Meskers. I think you had your hand up first.
Thank you, Chair. Thank you, is it John, for your testimony. I think it's helpful for us to know that what I heard from your testimony, pretty rapid fire, was that you're clarifying the insurance liability and where there is that you're responsible for maintaining the documentation so that the user of the product or the in this peer-to-peer lending, that you have some liability or obligation to make sure that there's the appropriate insurance coverage. Am I correct in that?
Yeah.
Yes.
So, yeah, go ahead, John.
Yeah, yes, and I'll let Sean jump in. Good to see you again, Representative Mesker. Was great to meet you a couple of months ago. So the way our platform works, and we are very vigilant as it relates to the safety of our hosts, those that put their cars on the platform, and guests, folks who book those vehicles. When the car is shared on the platform, the guest and the host are required to have an insurance protection that is provided through our partnership with Travelers. So during that period, the individual's personal insurance is not in effect. It is the insurance package that the guest and the host, both of them have insurance packages that they select when they book the vehicle. Sean, would you like to add?
Just that, in addition to requiring the platform to make certain that there is coverage for the full duration of the car sharing period, there is also a requirement that the platform maintain documentation about things such as the car sharing start time, end time, what locations it was dropped off at, and it requires us to keep that and maintain it for a period equal to the personal injury statute of limitations, and to provide that information upon request to the shared vehicle owner, their insurer, the shared vehicle driver, to facilitate a claims coverage investigation. So if we do not have that information for whatever reason, the bill would also provide that we step in to provide coverage on a primary basis, beginning with the first dollar of a claim, where there is some dispute over whether the loss occurred during the car sharing period.
Okay, I think that answers more than enough of the insurance question I have for you. With the chair's permission, it's further than my purview on insurance, but I assume the negotiations with the state and with the Department of Revenue Service, DRS, are adequate. I thought there were some concerns related to use of the service at the airports, et cetera, in the peer-to-peer, and whether or not there was a capture of whatever revenue versus rentals versus some of the other platforms, the Uber and Lyft. And I don't know if you're prepared to speak to that or if that's been addressed.
Well, we will certainly, obviously the airport has the purview, a representative to negotiate and securing agreements. We have been very focused on getting the proper professionals to work with airports. So now we have actual airport professionals on staff that are securing agreements with airports around the country. So no longer is it myself as a GR manager, although I do have some experience working with airports. But those individuals are working with those airports, negotiating, and certainly we would look to have some discussions with the leadership at Bradley to execute a contract. What I'd like to also say, Representative Meskers, is that oftentimes we get conflated with other transportation entities. And what we've chosen to do is to not operate rogue. We've operated within the frame of the law. If we don't have agreements at the airports, we're not operating at the airports. I'll give you a prime example. The last time I saw you, I flew in, I booked a Turo. The fella did not meet me at the airport. He dropped it off at the hotel that I was staying at. So what we hope to do is negotiate a sensible agreement that brings revenue to the airport, provides this commodity. And I just like to say, just a point of personal privilege, we are experiencing inflation at a rate that none of us thought at this current juncture. Folks in their homes are tight. And one of the ways we hope to do, even as people are recovering from the pandemic, is to provide this economic opportunity to leverage your second largest asset in most people's homes. So to your point, Representative, we will at the appropriate time have those discussions with the airport to secure an agreement that is mutually beneficial for the state, for the airport, but most importantly for the folks that use Turo.
Perfect. You know, it's outside the purview of the committee, I think, so I'm happy with the insurance question. You know, as we bring new business models into the state and new ways of operating, I just want to make sure we have a relatively competitive and level playing field. So that you know, I'll be looking at that in my other roles, not here. So thank you very much. It was a pleasure, and you've satisfied my questions, which were principally the insurance, which is where I think I'm supposed to keep my eyeball on that alone in this committee. And so I really appreciate your commentary. It was very helpful.
Thank you so much.
Thank you, Representative Delnicki.
Thank you, Mr. Chair. And welcome to John, James, and Sean.
Thank you, sir.
You made a statement, and I was going to ask you this. You called it a platform, yet the language changes to program. Is it a platform or is it a program? And can you define the difference?
I'll defer to my distinguished legislative counsels who are much brighter than I.
So
I will.
Go ahead.
Sorry, go ahead. Oh, I was going to say, I think we see it as a distinction without merit. It's maybe this is a poor analogy, but it's sort of James versus James's brain. The legal liabilities associated or obligations or requirements of the bill, I believe as currently in statute, is a peer-to-peer car sharing company. And there is a different term for the platform, which is the software operated by the company. And in practice, I can tell you internally, we will use the term platform and program interchangeably. But more to your point, it's that the obligations fall on the operator of that software, which would be the peer-to-peer car sharing program. So the changes suggested here would be clearing up and cleaning up that definition, so there was no confusion as to whether or not a regulatory obligation fell on the software, the platform as defined in statute, or on the owner or operator of the program or company as it's currently written.
So my good colleague a moment ago drifted off of strictly insurance questions. So I think it's kind of fair game at this point to ask other additional questions. There was a ruling by the Department of Revenue Service pertaining to the taxation. Are you guys in agreement with that? Are you going to challenge it or what?
Well, we've had discussions with Department of Revenue. I think we're at a good place. Sean, would you like to jump in?
No, I don't think, sure, I'm happy to jump in. I don't think we disagree with it. I think we take it for what it is. It was a rather complicated document, and I don't think we disagree with it or plan to challenge it. I think it speaks for itself, and that's all.
So then you are in agreement with the ruling from the Department of Revenue Service?
Yeah.
I'm going to abide by that. Now, my good colleague a moment ago spoke to the issue pertaining to the airport, Bradley specifically, and I would guess probably Tweed New Haven also would be involved in this on the negotiations. Where are you exactly at this point, and when do you expect to have all negotiations there wrapped up?
Well, we don't fully control that process, Representative Delnicki, obviously. We plan to hopefully push this measure forward, and then once hopefully we achieve a successful passage this proposed measure, this proposed language, then we would then move on to engage the airport should you all and your colleagues pass this bill.
So you have no brick and mortar whatsoever when it comes to the actual sharing, renting, whatever we want to call it, of the vehicles. Is that correct?
Yes, we have no bricks and mortar. We don't own any of the vehicles. The vehicles are owned by your constituents and my many family members in Connecticut. And subsequently, we don't require that physical infrastructure that some of the other transportation entities require.
And I bring that issue up because at the airport, the car rental companies up there are actually going to pay for a transportation center through their income at the airport. And I don't know if you're aware of that, but I would suspect that that would be part of the negotiations with the airport. And I just say that as an aside here.
Mm-hmm.
I'm still having a very difficult time trying to wrap my arms around the concept of a car sharing agreement versus a rental car agreement, because in essence, if I engaged in a vehicle and I was paying somebody to use their vehicle, it would seemingly be a rental of some nature. And I'm trying to understand what the difference is.
Well, I'm sorry, did I cut you off, Representative Zelnicki? No. Okay. If I could give you this analogy, we have hotels, we have Airbnbs. It is now settled for everyone that an Airbnb is an Airbnb, not a hotel room. I'd also like to add that the fear that perhaps hotels had with this new novel form of business, hotels are still doing pretty good, even in the midst of a pandemic. And so while I understand perhaps this challenge of wrapping your arms around this, I think that's a clear analogy where we see there's a recognition of two separate entities. We often get conflated with the Lyfts and the Ubers. But I think it's also settled now that a cab is a cab and a Lyft and Uber is a Lyft and Uber.
So just to go on another concern pertaining to the safety of the vehicle.
Yes, sir.
When a person rents a vehicle, and I know this from my own experience, the vehicle that I would rent would have gone through safety checks. They would have made sure that the fluids were proper, that in essence, there was no damage to the vehicle. And if there was, that would be duly noted. A whole checklist. Mm-hmm. And literally, they're right on top of it. Mm-hmm. Now, if I were to utilize your program, platform, whatever you want to call it, how would I know that that vehicle, other than the individual that owns the vehicle saying, oh, there's no problem with it, and it turns out that there's a problem, you drive it down the street and then the engine seizes up because there's no oil in the engine. So what's the guarantee there?
Well, we do have annual safety inspections. For the most part, these are individuals' personal vehicles. So they're looking, obviously, to keep those vehicles running when they're operating them outside of peer-to-peer car sharing. We also have a robust recall mechanism. So as soon as recalls are issued as relates to a vehicle, we immediately contact that host, that person who has the car on the platform, and they are not able to share that car until that recall measure is satisfied. So there are these pieces that are baked in to ensure the safety. I have obviously rented traditional rental as well. and I've had vehicles that malfunctioned. There are some things that perhaps are unavoidable, but we are working with our hosts to make sure the guest experience is so robust. And we also have a measure system for our hosts, Representative Delnicki. So that 5-star host, that all-star host designation is very important to the folks that host their cars. So there are so many incentives in addition to requirements that we have that really encourages and our hosts just maintain their cars well.
John,
I
apologize, Representative.
Go ahead, James.
The only thing I was going to add to clarify, I think, John, you covered it very well in terms of our annual safety requirements. And to be clear, that's a safety requirement that has to be signed off by a certified mechanic, in addition to our general safety checklist that all vehicle hosts have to go through with regard to their vehicle, in addition to documentation as to the state of the vehicle when it's delivered and when it's returned. But I'd also like to clarify that in general, to use your analogy to car rental and your certainty as it relates to the maintenance of traditional car rental, that's actually not a statutory requirement in almost any state. What you're talking about as far as maintenance of rental vehicles, in general, rental car companies are only held to the general maintenance requirements to maintain their vehicles safely in accordance with all state laws. You may be renting from a place that is fully above board, does all the things they say, or you may not be. And the standard in statute is only the minimum that's required of all drivers in the state with regards to their vehicle.
I appreciate that. Anecdotally, I'll relay my own personal experiences. I needed to rent a large SUV, and I went to a brick and mortar. They walked me around the vehicle. They indicated to me that they had done a full check of the vehicle, fluids, etc. Prior to bringing the vehicle out. The vehicle, in essence, they were checking every vehicle before it went out. Once a year, though, and I hate to relay my own personal anecdotal experience, once a year versus on my own personal vehicle, I had a condition where tires suddenly needed to be replaced because my front end had gone out of alignment and had to have it taken care of. Now, quite frankly, it didn't indicate in the driving, but when I did a walk around, I went, oh boy, look at that. So I appreciate what you're saying, but I still have concerns pertaining to it. I'm going to listen to further testimony here. And you said you went to South Windsor High?
Yes, sir. Proud Bobcat.
What class?
87. I was the last team that Coach Charles Sherris, the great legend.
Yep.
He and I, our picture is in the Connecticut Sports Hall of Fame. So I'm a Hall of Famer, Representative Delnicki.
I'm a South Windsor class of 74 Hall of Fame.
Wow, outstanding. It's a pleasure.
I'll have to, at some point,
we will connect and share great stories.
Take care now. Thank you for your testimony.
Thank you, Representative. And sadly, I did not go to South Windsor High. But Senator Wong, I know you're next, followed by Representative Wood.
Thank you, Mr. Chair. I would gladly defer to the good chairwoman, Ms. Woods.
No, please go ahead. Go ahead.
Well, thank you. Mr. Heath, Mr. Bangizer, and Mr. Vennick, just take me through. The conversation it's a very unique concept, but how does this differ from your model from what Uber does to, I think one of you mentioned that it's clearly set between the taxi services and cab services versus Uber. And that line still, to me, is still very, very much a moving target. how does your business model differ from rental car services, in this case at airports? Talk to me and explain to the general public as a benefit of this public hearing, how does your model different? And is it like a Uber model?
Certainly, Senator Wong. So Wang, please forgive me. And I also butchered my colleague's name earlier in the introduction. It's Bangasser, not Bassinger. But thank you, Senator. So we on our platform provide this marketplace, if you will, for individuals to put their car on our platform. Individuals will come into Connecticut instead of going to perhaps traditional rental car. They will go on our app. They will book the vehicle. The big difference is we don't own the fleet. Individuals place their cars on the platform. There is no kind of brick and mortar necessary because individuals will be coming from their residences, or if they have their vehicles parked somewhere, they will then put those vehicles on the platform and individuals will book those cars. It is a sharing, if you will. While we get conflated with the Ubers and the Lyfts, we are much more akin to Airbnb in principle and in theory. We've also been given the moniker Airbnb for cars. And so that sharing model now moves from residences and condos and apartments to now vehicles that individuals share on our platform. And it's micro business enterprise at its best. But the opportunities, particularly for folks who are stressed during this pandemic season, maybe homes that have lost an income. We are finding anecdotally, and we are looking to get more hard data on how individuals are literally using Turo to keep their vehicles. I am not ashamed to say that there was a time in my life where, in the words of the North End of Hartford, the repo man came to get my vehicle. And it was certainly an unsettling and disappointing experience. But Turo is really becoming a lifeline for individuals. And as we know, Connecticut still remains one of the most expensive states to live in. And so I hope I was able to at least delineate, and certainly James and Sean can jump in terms of making that demarcation.
Sure.
I appreciate
the kind of quick. Oh,
sure,
so
go
I
ahead, Mr. Van Gasser.
Oh, yeah, I'll try and kind of add on in a slightly more technical way. Speaking about the TNCs first and foremost, in that context, you're talking about a driver for hire. The distinction I think the TNCs would make between traditional taxi cabs is that it is generally a personal vehicle that's being used. But in a TNC circumstance, which is why TNC statutes nationwide reflected, you'll have both be logged into the app or with a driver at the time. That's not the case in a peer-to-peer car sharing situation, even if the person is used, it involves a personal vehicle. So as it relates to the rental car industry, that's where we're really making the distinction, is that you're talking about a personal vehicle, whereas a rental car company is a fleet operator. They own their vehicles, they purchase them exclusively for the purpose of rental. They get a tax break so that they don't have to pay the sales tax on purchase because they are using it exclusively as a rental vehicle. And in the context, I believe you mentioned an airport, it really can depend on the airport and the airport agreement. As John mentioned, we now have a whole airports team. I don't know how many airports we now have agreements with, but in general, it could be anything as simple as delivery at the terminal, or it could be use of short-term parking or other parking facilities. As mentioned earlier, peer-to-peer doesn't necessitate the same infrastructure requirements. We have no employees on site. We don't have any of the same requirements of a rental car company for the long-term storage, maintenance, cleaning, things like that would not be done on site at an airport. So it's not really analogous to a traditional fleet-owned rental car business.
Mr. Vinnick, anything to offer?
No, sir. I think my colleagues handled it well. Thank you, though.
Thank you. And John, if I may, you kind of pointed out that it's a Airbnb concept. But when I look at Airbnbs, and this comes into the insurance, obviously that's why it's on this committee, is there's two parts. One, I saw there was testimony from the insurance industry that you've collaborated and reached a shareholder agreement in regards to the insurance of the car that's used available for Airbnb. Can you tell me a little bit about what kind of agreement? Does it add to higher insurance risks for those individuals that are kind of renting out their cars?
Well, it wasn't so much of an agreement as is many of your colleagues who serve on insurance committees, members of NCOIL, the National Council of Insurance Legislators, and they gathered together, collaborated with individuals in peer-to-peer car sharing, insurance folks, to develop what in your world is called a model bill. Now, we also understand I have 50 state responsibilities. Every state is different. But that model bill provides the basis for a regulatory framework that provides safety as relates to insurance coverage. And so what we've done in states around the country is taken that model, use that as a basis, and then we customize it depending on state requirements or statutes. Sean and James, did I express that adequately?
Yes.
Thank you. One of the feedbacks that we've gotten is from the airport authority and at Bradley, I believe Mr. Dillon. The huge difference that I'm thinking about is I'm thinking of the Uber model where the driver picks up the car, you get picked up right at the terminal. You mentioned parking at platforms. Where are you leaving the car?
So there is delivery of the vehicle, and it all depends on the airport agreement. And I can't obviously speak for the airport, but that is done in a variety of ways. There is immediate delivery, and in that delivery, you have to go around, inspect the vehicle, you have to take pictures, you have to upload them to the platform prior to securing that vehicle on your trip. And so it may be an individual delivering, or if there is an agreement, let's say, with using a parking structure, then that airport not only gets whatever the agreed percentage is in terms of the concession agreement, but they also get parking revenue as well.
Do you have current agreements with the Connecticut Airport Authority or any of the airports?
We don't have any agreements right now with Bradley or any of the airports. Subsequently, we're looking, obviously, hopefully after successful passage of this bill, to engage in meaningful discussions with those leaders and then to negotiate a mutually beneficial agreement.
Are you in operation anywhere in the state of Connecticut?
We operate in the state of Connecticut, but we do not deliver to airports because we don't have an agreement there.
So just give me an example of one operation. Where do you park the car? Where do you have that exchange?
Well, I'll again use my personal experience. The last time I flew to Connecticut to meet with some of your members of the committee, was able to meet co-chair Wood and had a great time at her event. I also laid to rest my sister that weekend of that week. When I came in, I booked a Turo car, was staying at one of the hotels near the airport, and the individual delivered the car to me at the airport. An individual may arrange for pickup or a meeting place to pick up that vehicle. But generally from the airport specific, the individual would deliver to wherever that person is, or that person would meet that individual to pick up that vehicle at a mutually agreed upon location.
Well, I thank you for that clarification, and I'm still very curious to see how the insurance coverage works. I'll delve a little bit further into that because it obviously significantly increases the risk of loaning your car out to different parties, and that's a personal property question and an insurance question that I'll follow up later on. Thank you, Mr. Heath. Thank you, Mr. Chair.
Thank you, Senator.
If I may.
Oh, sure.
I apologize. I just wanted to add on to what John had said and make it clear that I believe our airports team is in ongoing discussions with the airport authority about an agreement. So that's a process that we are engaged in and is ongoing.
Great. Thank you for that clarification. Representative Wood.
Thank you. I think a lot of the questions that we have been getting from the committee are really not really understanding what exactly a peer-to-peer car sharing platform is. So I'm glad we've had a lot of those explanations because, you know, that model of a Airbnb for cars, I think is the best way in layman's terms to look at this. If I, Carrie Wood, am using my car on Mondays to go to work, but then I work remotely Tuesday through Friday, I could join the platform and you know, essentially put my car on there. Is that correct? And then receive like a rental payment?
Yes, that would be correct. You could essentially you would set the terms of sharing if you wanted to make it available 1 day a week, if you wanted to make it available for multiple days of the week, and you set the price as well. You can also provide additional add-ons like things like a bike rack and things like that, depending on the location you're in. But yeah, it's essentially use it as you would like to use it.
So is it only, so say I own 2 cars and I'm able to use the platform for the 2 cars, would you allow me to participate if I had 10 cars?
Well, we don't want to stifle any individual's ability to obviously make money. So we don't have limits for an individual in terms of the amount of vehicles that they could put on the platform.
Could an LLC put multiple vehicles on a platform or any sort of corporation?
Sean and James?
Yeah, probably not, Representative, because the bill that we're talking about, current Connecticut law, contemplates personal automobile insurance policies. So cars that are individually owned and are insured under a personal policy of insurance. If a corporation of some kind were the owner, I don't know that they would be eligible for that classification of insurance. So if the upshot is, you know, is this a way for rental car companies that are small rental car companies to avoid some sort of requirement? I really don't think so. I think they're just dealing with 2 different universes of insurance products and hosts.
Yeah. Representative Wood, those individuals would have to comport or conform with statutes related to rental car, the rental car industry. And if I may, just the distinguished senator asked a question about airport negotiations. Just to clarify, we had been in airport discussions up until COVID, and then when COVID hit, we paused those negotiations. But we'll look forward to pick those up.
Great, thank you.
Thank you, Representative. Representative Nuccio.
Thank you, Mr. Chair. So I guess my question is, I don't know if it's 100% germane to this, but I think it is. So if I'm on this platform and I'm being guaranteed insurance through your platform, if mine doesn't cover and all of that, how is this reported as income for people? Is this rental income like any other kind of income?
Yeah, so individuals are given, and our lawyers can speak to the specifics, but this would be counted as income. And again, Representative Nuccio, when an individual books a vehicle on the platform, unlike with the rental car industry, you can kind of waive if you want coverage. You have to accept coverage on our platform as a person, a guest who's booking the car. But additionally, the host also selects an insurance package during that period of booking.
So is it double insured at that point then? Because if I'm renting out my car, I've got insurance on my car, right? And my car is a newer car, which means I've got full coverage on my car because I've got a loan on it. So my insurance doesn't necessarily, actually, I know my insurance pretty much does not cover commercial rental. I know of people who have gotten in trouble who are Uber drivers who are either logged on or not logged on, and their insurance wouldn't cover, et cetera, et cetera. So my insurance kind of becomes moot at that point, unless I've got this commercial coverage. Then they would have to, the person who's renting the car would have to accept your insurance.
So it
pay for
covers
that?
both. You know, obviously as an individual who's booking a car, you know, God forbid someone just slams into you. You want to have coverage to handle that. But then also the host coverage also covers the host in terms of their vehicle and coverage, so that if there's something that occurs, they have coverage separate and apart from their personal coverage that will cover any incidents related to the vehicle.
So in my case, if I have a newer car and I've got full collision and everything else on it, my accepting your coverage will cover the full replacement or paying off of my car should something happen. It's comparable to the insurance that I'm paying for personally.
Yeah, so we have 3 levels. I'll let the lawyers probably dive into that a little bit more, but there are 3 levels of coverage that the guest and the host has. James, Sean?
Yeah, I mean, the 3 levels correspond
Sean.
basically to different.
Sorry, you were both talking at the same time. I'm not sure I can understand.
Yeah, the 3 options just correspond to 3 different levels of deductible. So there's a 0 deductible, I think. There's a $500, and then I think it's $1,250 if memory serves. So yeah, it does cover the full replacement of the vehicle if you have a newer vehicle and require that.
So is that mandatory or is that optional? So can I say, you know, I've got a new car and I'm going to accept the
No,
cheapest plan you have?
You have to accept that's a requirement to be on the platform.
Well, I know you have to accept the plan, but do I have to accept the appropriate level of plan?
You choose that.
You choose. You can pick whichever one you want.
So I can choose a lesser one. I can say, no, I don't want my full coverage.
You would choose a higher deductible if that's what you wanted to do. So there's 3 different levels of deductible. So you have a choice among 3 different coverages subject to 3 different deductibles.
Okay, well, I guess I'm trying to get at is replacement cost, like is the whole thing, like I said, full collision, everything, is that your base plan, or is that like, and then 3 levels of deductible, or is there an ability for me to go on and be like, you know what, I just want the minimum plan, I don't care, and then leave it at that?
I guess what I would say is that there are 3 plans from which you have to pick, and the difference between them is just a difference in the level of deductible. All of them would include replacement cost.
Okay. And then the second, so I have to pick that as a host. And then the person who is renting my car can or has to get their own policy also.
They have
So-
to have coverage.
They have to have coverage. Yeah, with respect to third-party liability, right? It's non-declinable.
So the person renting also has to have coverage.
Cannot get up behind the wheel of a car without having third-party liability coverage.
Okay, and you are reporting every time somebody rents out their car, you're sending them what, a 1099 with the rental income that they're
No.
making throughout the year?
Not every time they do it. The IRS requires
At
that
the end
we
of the
show-
year, right?
Yes, at
Accumulative.
1099K, yes.
Okay, I think that's all that I have. Thank you.
Thank you, Representative. Other questions or comments for the gentleman from Turo? If not, thank you so much for being with us here today.
Thank you, chairs and members of the committee. Appreciate you all greatly.
Wonderful. All right. Next up, we will hear from Mr. Stephen Ranieri.
All right, honorable members of the Insurance Committee, on behalf of Enterprise Holdings, I have submitted written testimony in opposition to HB 5384, an act concerning peer-to-peer car sharing programs. Last year, the Connecticut General Assembly passed legislation regulating peer-to-peer car rental activity in Connecticut in SB 261, which was codified in Public Act 21-106 and became effective just a few months ago on January 1st, 2022. So we ask that you allow for the full implementation of this law and reject the changes in HB 5384, which would restore inequity in Connecticut's rental car market. My name is Steve Ranieri, and I'm the controller for Camrac LLC, which is the wholly owned subsidiary of Enterprise Holdings, which operates our brands National Car Rental, Enterprise Rent-A-Car, and Alamo Rent-A-Car across Connecticut. Our regional headquarters and my office is in Windsor Locks, Connecticut. On December 1st, 2021, the Commissioner of DRS issued guidance on how peer-to-peer car rentals should be treated. The Commissioner's guidance suggests that these rental transactions should be considered under the Marketplace Facilitator under Connecticut law, and as a result should be subject to the sales tax. HB 5384 alters the definition of a peer-to-peer car rental company to a program, essentially skirting the Connecticut Marketplace Facilitator law. It also removes the sections requiring agreements with the airport authorities. I saw Executive Director Dillon's testimony posted, and it states that the CAA is also opposed to this bill if it were to be passed as is. And I'm not seeing where the platforms would be required to enter into any agreement. So this poses the question very simply, will they make contact and enter into an agreement without the requirement that the previous bill had sort of ensured? House Bill 5384 includes a portion of agreed upon language from the NCOIL, the National Council of Insurance Legislators, but it does not include the most important component, and that's the intent of the agreement. The model bill includes scope language, which applies only to insurance coverage and does not impact state taxes or airport agreements. For more than 6 decades, Enterprise has been sharing our fleet of vehicles with consumers. Here in Connecticut, we accomplished that with 525 employees, operating a fleet of 10,000 vehicles through a network of 68 locations. So during the last testimony, I logged on and tried to book a rental at Bradley through one of the peer-to-peer apps, and 73 options were available to me. I did not go all the way through with booking it, but it certainly looked as though I'd be able to have a car delivered to me while on site at Bradley. So whether you brand it car rental, car sharing, in my opinion, it's the exact same service being provided to consumers, only the business model for providing the service is different. So I guess I'll leave you with this. I think of sharing in its simplest form, kids sharing toys with one another with really expecting nothing in return. When you start asking for compensation for something shared, in my opinion, it becomes more of a business transaction than true sharing. So we're not asking hosts to pay or even remit taxes set forth by the state, but rather we'd want the platform.
Thank you. Your 3 minutes has concluded. Can you please summarize?
We'd rather have the platform collect the tax from their customers and remit on the host's behalf. So thank you for your time and consideration on this very important issue. And I respectfully request that you reject HB 5384.
Thank you for your testimony. And just being clear, we heard a few different things from the Turo folks who just testified. One, obviously, I've heard you about the need to require an agreement with the airport. And I think that that's an important subject of consideration. But they also represented that the language adopted last year by the Transportation Committee referenced old NCOIL model language. Do you have any objection to updating the model act cited, or is that something that's a huge issue one way or the other?
Yeah, we agree with NCOIL in terms of the insurance component of it. Where we, I guess, disagree with the current bill as it's slated is that there's just nowhere where it has anything to do with tax or that airport agreement. But otherwise, yes, we fully agree with the NCOIL.
Got it. Thank you. That's super helpful. Representative Dunleavy.
Thank you, Mr. Chair, and thank you, Stephen, for your testimony. You said something that just piqued my interest. You said by changing to program that they could skirt the Department of Revenue Service ruling pertaining to taxation?
Yeah, I'm not going to pretend to be the expert on that, but I just think that the way that the new bill is introduced, it certainly leaves that open for interpretation. And yeah, in my opinion, it looks like that would be something that would be skirted. But again, I can't say that I'm the expert there. But as was the previous bill, sure. I mean, the commissioner made his ruling, and things seem to be moving forward.
So then it would be worthwhile to find out from DRS whether or not that change in terminology would trigger something that unintended consequence of a reduction in taxation. Because do you know how much you pay in sales tax and user tax to the state of Connecticut?
Yeah, sure. Yeah. So we are required to remit 9.35% in state sales tax. So, for us, that's not us, it's a pass through. We charge the customer and then in turn remit the tax on their behalf. So for us, I can speak for enterprise alone, it's just under 15 million per year that we're collecting and remitting. And that's just the sales tax. There's also a tourism charge as well.
So you said 15 million?
15 million for enterprise. Yeah.
What about property tax for your brick and mortar?
We have 68 locations. If the average is, $1,000, I mean, it depends on the location. We have some bigger, some smaller. But if you're talking property tax, I'd have to just ballpark and say, 68,000. And that's just I'm not quite sure off the top of my head there, but certainly, property tax on vehicles. Connecticut obviously has a pretty high property tax rate there, and we pay our fair share with that as well.
And that property tax gets remitted to the local municipalities where you're based?
Yeah, it was a little muffled, but it sounded like, do we pay to the local municipalities?
Let me repeat that.
Yeah.
Does that mean that the property tax that you pay is distributed to the local municipalities where you have your brick and mortar locations?
Correct. Yes. So property tax on vehicles goes directly to the cities and towns where we operate.
The transportation center that they're building up, that they're going to build in Bradley, what role are you playing in that?
So we, like many other or every other rent-a-car company, entered into an agreement with the CAA. We have been for a number of years. And with that, we are now in an agreement to operate at the new facility, the transportation facility. And in order to do that, we charge our customers a fee per day who fly into the airport and rent at Bradley. And that fee goes towards, the construction, maintenance, et cetera, of that facility. So yes, we pass that along to our customers as well.
And what's that equate to in dollars that it's going to cost to build that facility?
It's, I think, $210 million to build the facility.
Okay. Well, thank you for your testimony. I appreciate your information here. Thank you, Stephen.
Yep, you're welcome.
Thank you, Representative Delnicki. And, last year we had this issue where the Transportation Committee decided to write an insurance bill. And now it looks like the Insurance Committee may be writing a Finance Committee bill. And so I want to make sure that we're staying within our lane to the extent that we can, although I understand this is an issue that covers multiple areas of committees of cognizance. Just one point of clarification. I'm really interested in the tax argument. Just for my edification, do companies like yours, do you pay sales tax on the purchase of your fleet?
No, we do not pay sales tax when we purchase a vehicle. We purchase a vehicle wholesale, much like any other entity within the state whose sole purpose is to use this vehicle as a source of rental and rental income. Then when it's time to sell the vehicle, when it's done in our fleet, we sell the vehicles wholesale again to dealerships, and then those dealerships in turn sell it to the public, and that's where sales tax is then assessed. Now, throughout the length of the vehicle's life, we're collecting 9.35% sales tax and remitting that to the state. So that's where that, kind of comes into play. It's not like we're renting a vehicle and then just not paying sales tax at all throughout it. So.
Thank you. That's helpful. Senator Wong.
Thank you, Mr. Chair. And Mr. Ranieri, you're testifying on behalf of Enterprise, but the company you represent also has Alamo and what's the other one?
National.
A National. Do you represent all three then in this conversation?
Yes, I do. Yep.
Okay,
It's a
great,
family
great.
brand. Yep.
So take me through, do you see peer-to-peer as a direct competition to your business model? If so, please explain. If not, also please explain.
Yeah, sure. Yeah, definitely see them as a competitor. I'll give you a couple of examples as to why. First being, if I was to go on vacation and I'm going to go back in time and talk about my 23, 24, 25-year-old self, and I was going to book a car, I would go online, I would search for car rental at wherever I was flying into, and I would probably book the cheapest option. And in this case, if I was to fly into Bradley, the cheapest option would be Turo. And the reason for that, when you start boiling it down, is there's no sales tax being disclosed on the website. Whereas if you book through Enterprise, we have our disclosures and it's our rate, it's our tax, it's our, and so on. So if I was to book a 3-day rental for a Jeep, which is what I plugged in when I had some time, the rate for Turo was $100 less, but it was the all-in rate, so the rate per day was pretty close. It was $100 for Enterprise. It was $93 for Turo. But when you start going through, down the list of what's being disclosed, our airport surcharges and for the privilege to do business on site and our sales tax and fees came to about $100 more than what Turo was offering. So yeah, I definitely see them as a competitor, and certainly not looking to force any competition out. I just want to make sure that when a consumer is looking to rent a car and that 23, 24-year-old version of myself is looking, that I'm comparing apples to apples, that I know that the car is safe, because that $100 difference is going to probably force me to go to Turo, when myself now would look and say, okay, like, is it a safe vehicle? How many times has it been inspected? I would just take a few more things into consideration. So I guess that's who we're kind of trying to protect, is that consumer. But to answer your question, sorry, very long-winded. Yes, they are certainly a competitor of ours.
And in saying that, I think you bring up a very good point. You say about a 25-year-old, that would only be 3 years removed for you, probably. That being said,
I wish I could say that.
Yeah, we all wish. Obviously, one of the things we asked prior was that they needed to get to an agreement with the airport. And if let's just say that they did that with the airport authority and was able to put their cars in a platform, but they're able to do it with less overhead costs and a free market association. How does that differ than what you all do in having a contract relationship with the airport, have your card there and transact? it's just a different purveyor of cars and cost reduction. And this is why you're in the insurance committee, is the fact that we're making sure that they're properly insured and that the consumer are protected in the marketplace. But how do you argue against that if they do reach the agreement and they have to pay the airport fees and et cetera, and they're still able to produce a significantly lower cost to the consumer? How do you do that? I mean, I think one of the hardest challenges for people that may be renting cars now, for whatever the reason, COVID, cleaning, et cetera, rental car rates have increased significantly. And if there is an alternative marketplace that meets all the criteria, insurance, an agreement with the airport to be able to put the platform in the car, I don't see it that much different unless you can educate me where they are getting an unfair competitive advantage to significantly reduce the cost of car rentals in high access locations like airports.
Yeah, I mean, I'm not gonna sit here and say that, you know, businesses change all the time. Well, I mean, businesses do change all the time. And if they can find a way to operate under the same set of guidelines in terms of taxes and fees and regulatory requirements, but they found a way to reduce overhead, I mean, that's what business is, in my opinion. It's, you know, you've got to find a way to sort of overcome your overhead. And we, you know, we are a for-profit company, so we are trying to, you know, turn a profit. And if that means we have to get creative as a company to try to compete with a competitor who has found a way to do that, I think that's what, you know, good competition is. And if that drives our rates lower because we're able to now compete with them by reducing overhead in some way, then that's only good for the consumer. Again, that's my opinion. But you know, we need the brick and mortar locations. That's our business model. We're not trying to go on a platform. I think it was sort of brought up earlier where, you know, could an LLC go on a platform? That's not what we're looking to do here. We just want to make sure that if that's the way that business is going, or our industry is going, we just want to make sure that regulatory and from a tax standpoint, we just have a chance to compete. And if it means, you know, us having to change our model a little bit, then so be it.
It's interesting. I mean, we're in this committee looking at the cognizance of insurance, and that's an important to stay put in. As the good chair mentioned, we don't want to go into the taxation and revenue side. But I will share with you, when I heard the testimony, and my son just rented a car from Enterprise, and here's the interesting model. Your competitive advantage to the normal marketplace of Hertz and others is you are willing to drive the car to the renter's location of preference. And that is a interest and competitive advantage, right? You're going the extra step to say, I'm going to bring the car to you wherever you are, because maybe it's location cost that you don't need to be on high access airport locations and pay the extra charges. But look at that model. How does that differ from peer to peer, as they described it, that they have a car, they purvey it from other sources, but they're willing to drive it to you to be able to have you rent it. I mean, that's Enterprise's marketing and competitive advantage, right? You're willing to take the car, go anywhere that the client wants it, and you rent the car, reach an agreement with them. How does that differ from the peer-to-peer, except that they're kind of enterprising and they, I hate to use the word, I apologize, but they're lowering the cost from a marketplace of not buying wholesale fleets while meeting the insurance and safety requirements?
Yeah, I guess I'll answer that by saying, you know, the Turos of the world are taking a technology that they have that's privy to them, and they're connecting, it's supply and demand. They're connecting a supplier with someone who has demand, where Enterprise is kind of a all-encompassing. I mean, we have, you know, our own marketing team, and that's how we market. We are willing to go the extra mile. We'll pick you up, we will drop the car off, we'll do all these things, but we just don't have the technology that a Turo has, where they can connect two people who have a need and a want. So I guess that's the big difference, is we're kind of doing it sort of all in-house under one roof, whereas Turo is, and the other peer-to-peer companies, they're sort of, using their technology, I guess, in that space. So if that makes sense.
Well, that's interesting. And if they indeed do have a technology advantage to be able to free source customers and bring the goods and services to them, perhaps it's a readily available access point for every enterprising rental car agency. And indeed, as part of this process, they are following the rules, which I compliment Turo and the P2P concept in doing. That isn't always the case in the fast and furious changes of the technology world and innovation. So, but you bring up an interesting point. I appreciate your insight. It helped me understand a little bit more that their competitive advantage may be a lower cost production, and also the utilization of a technology of searching for consumers that may not be readily available to a normal enterprise or rental car process, where you need to travel, you need the airport, you connect with Expedia. They're looking for other channels through their software innovation. You clarified it for me, so I appreciate that, and thank you for your input and testimony. And I'd be remiss not to add the fact in reading your testimony that your organization's regional headquarters is based in Windsor Locks, Connecticut. And so that's a big shout out to you, and thank you for being a Connecticut-based business. Thank you, Mr. Chair.
Thank you, Senator. Other questions or comments from members of the committee? If not, thank you for your testimony today.
Thank you.
Next up, we've got James Yacobelis from the Connecticut Hospital Association.
Thank you, Senator Lesser, and distinguished members of the Public Health Committee. My name is Jim Yacobelis.
We're the Insurance Committee.
I'm sorry. I got
old habits die hard.
Yeah, so I just have spent so much time in front of the Public Health Committee. My name is Jim Yacobelis. I'm pleased to be before the Insurance and Real Estate Committee. Thank you so much. I'm here to testify in opposition to Senate Bill 354, an act concerning reimbursements for certain health care benefits. This is a bill that has been in various forms before this committee before. This does two things, really. It says for procedural E&M and A&M codes, for telehealth codes, and infusion drug codes. The bill last year was just about E&M codes and A&M codes. This year, telehealth codes was added to the proposal. And it requires the Department of Insurance to set rates for those codes in a geographically, for the same rate for all providers in the same geography. Senate Bill 354 begins a journey that we haven't been on state government rate setting outside of Medicaid and Medicare. As we know, hospital rates under Medicaid are set by the state. For Medicare, they're set by the federal government. In both of those instances, hospitals are reimbursed less than the cost of care. In Connecticut, under Medicaid and Medicare, is about a $2 billion underpayment. We do not support additional government setting of rates. Secondly, the bill requires site neutral payments. And what site neutral payments means, it is the same payment, notwithstanding what type of provider you are. This bill doesn't recognize the difference between a hospital setting and a clinic setting and a physician office setting and an ambulatory surgery setting. The Medicare program does. And I don't think we have to look far for an example of what the difference between a hospital setting is and an ambulatory surgery setting or physician office setting. Let's just go back 8 weeks when we were at the center of our fourth COVID peak, where hospitals expanded critical capacity, stood up countless testing sites and vaccination sites. Plainly stated, a hospital setting is different than a physician office, a clinic, or an ambulatory surgery center. And we should not enact a payment structure which doesn't recognize that difference. So for those two reasons, based on we don't support increased rate setting and rate setting into the commercial market as opposed to Medicare and Medicaid, and support of the difference that hospitals have. And I've been testifying in this bill for a number of years and goes back prior to the pandemic. And I used to struggle to come up with an example to really show the difference between a hospital setting and other settings. But unfortunately, since March 8th of 2020, this example is clear.
Thank you. That was 3 minutes. Please summarize.
Thank you. I look forward to answering any questions.
Thank you, Jim. And it's good to have the back and forth on this. And I don't think we will hold it too much against you that you mixed this up with that other committee. Just real quick on the issue of telehealth. I'm thinking about this from the consumer's perspective. A consumer doesn't necessarily know where a provider is. And so a provider could be located in the provider's office or in a hospital setting or in some sort of third location. Why should a consumer or a payer for that matter be charged different rates depending on where the provider is on any given moment? If I have a doctor, I'm going to try to, I'm not necessarily policing their movements.
Yeah, I think if we take the big picture here, is that if you are if it's provided in a hospital setting, the responsibility then is to fund the entire hospital and what the hospital needs to do. The hospital needs to be able to be prepared for any emergency or any crisis. At the same time, we care for individuals that are uninsured, that walk through our door every single day without insurance. There is a difference. I understand your point about the consumer, but if you are a hospital provider, there is the recognition that we need to make sure that the hospital and all of its responsibilities are appropriately funded. Without having strongly funded hospitals, we would not have come out of this pandemic the way we did in Connecticut. And I firmly believe a lot of it has to do with the work that we all did together in dealing with issues related to Medicaid funding and hospital settlement, but we worked to sustain hospitals. We shouldn't do anything to undermine that.
And, one of the things that I've talked about this offline, I'm struck by the fact that whenever we have a bill about site neutral payments, as we have looked at, numerous times in the past, this is one of the few areas where the providers, the Connecticut Hospital Association, and the insurers are in lockstep in opposition. And it seems that the insurers are convinced that site neutral payments would raise prices, and hospitals are convinced that they would lower reimbursements. You can't both be right. It's either one or the other. So I'm trying to help us. Maybe maybe our folks at our friends over at the Health Insurance Association are wrong here, and you're right. But I'm just struck by the fact that only one of you can possibly be right. Somebody's reading this bill wrong.
I also think that the concerns have been expressed by the Department of Insurance as well, as we don't have the structure in place to do this. I guess I would venture to say it's probably a sign, Senator Lesser, when we are on the same page, that we should really think hard about enacting this.
Okay. Well, I may have some more questions, but I see that Representative Nuccio and Representative Mascaris have their hands up, and so we'll go to them first. Representative Nuccio.
Thank you, Chairman. How are you, sir?
I'm well.
Good. I'm trying to understand exactly I think I understand what you're trying to say. And in some senses, I agree with you. I personally struggle with the mandating telehealth be paid at the same as a brick and mortar because the cost structure and everything else is different. So what you're saying is basically you don't think we should, and listen, I'm all for the government not setting rates 100%. I have a problem with when the government gets involved and rates are set. So what you're saying is this bill is going to mandate that site neutral, all rates be the same, regardless of the type of provider, whether it's ambulatory surgical or hospital, which we all know ambulatory surgical is less expensive. So I guess I'm trying to figure out exactly.
Yes, no, that's exactly what I'm saying. But there's another twist here too, right? It is a rate then that is differentiated whether you are in certain geography, whether you're east of the river, they'll set a rate. And then whether you're west of the river or north of Connecticut or Fairfield County, it's going to require the Department of Insurance to make those decisions and set up what has to be a full rate setting mechanism. The Department of Insurance can't simply say, okay, east of the river, we're going to pay $5 for telehealth, and in west of the river, we're going to pay $10 for telehealth. There needs to be a full process where they have to notify every single provider, then get into the whole administrative procedure requirements of rate setting. So it has a geographic twist to it as well. Not simply just the site, but there's a geographic factor in here as well that is, I think, concerning, and I'm not exactly sure how that would play out.
So again, I think I can agree with you there. As living on the side of the river that tends to get priced lower than the other side of the river. We've seen it with mental health. We're seeing it across a lot of facilities that providers east side of the river, especially northeast side of the river, are not receiving the same reimbursement rate as those on the west side of the river. So you've given me a lot to think about. Thank you very much.
Thank you for your question.
Thank you. Thank you, Representative. It looks like you're all set. Wanted to, just going back to the rate setting question. I know historically, I think it was OCA at the time, but now what's now the Office of Healthcare Strategy was in the rate setting business. That I think until the early 90s, and I think Maryland is now the only state that still has state rate setting. Would that, as opposed to if we were to go down that path, would you suggest that they would be a better home than the Connecticut Insurance Department?
I think if you look at and I read the Department of Insurance's testimony, they talked about not having the skill, the expertise, and the ability to do it. I don't think that skill, expertise is also in the Office of Health Strategy. Notwithstanding, I don't believe that we should begin this road. This is a significant step on a significantly different lane. This is not Medicaid. This is not Medicare. This is the beginning of rate setting in the commercial market. So could you create the rate setting structure in any particular agency? I guess you could. The question is whether you should. And it's not simply adding on one or two individuals, because this rate setting is for every provider. Every provider that does infusion, every provider that does telehealth. So they all have to be involved in this rate setting process. It's not simply the department issuing a rate bulletin. The Administrative Procedures Act requires significant administrative support and process behind it. So I think you could technically set it up anywhere. And to get back to your question, I think it was prior to my time. I was probably still working at the legislature when they were doing rate setting. So that was back in the 90s, maybe late 80s. So I don't know exactly how that process worked. It was before my time.
Well, Mr. Yacobelis, it was before my time too. I don't want to tell you what I was doing in the early 90s, but it certainly wasn't passing legislation. Appreciate that information. Representative Meskers.
Thank you, Chair. And thank you for your testimony. I'm trying to frame my argument and conversation along the lines of your testimony. I think I come at it from the opposite point of view, in that I think setting the rates is going to raise the overall price, and it's going to have a bad impact on competition and a bad impact on our insurance, the cost of healthcare. So I guess I come from the point of view of it seems to me that we have various providers on-site, off-site. There is some competition. If anything, I want to foster a higher level of competition. And that may not be by rewarding the hospital price to off-site care centers, but a way to foster further competition with those off-site centers becoming a benchmark for pricing, and then factoring in the pricing, the mandates that we throw on the hospital center in caring for our less fortunate residents. So I will be looking along those lines to see what we can do to better improve our healthcare services. But when you speak towards a mandated rate on-site, off-site, I guess that impacts also the overall cost you're going to see on-site and off-site for the hospitals, because you guys have bought networks. And so those costs off-site, you would have to essentially either equate the prices or raise the prices off-site to match the hospital rates. What is your interpretation, in addition to a flat rate across the state, which ultimately might lead to further regulation? What's your impact on or impression of what this does to the overall price of medical care?
I think Senator Lesser brought up the issue of our concern that it reduces the rates, and the health insurance thinking that it raises the rates. And we would only know what the answer to that is after you have the rate setting process. But I think the way we have seen rates set under the Medicaid and Medicare program makes us pretty cautious that it would be a reduction in rates. But let me sort of get at a little bit of what you're saying. Back in 2015, under, I believe it was the Balanced Budget Act in Washington, the federal government said, starting in 2015, hospitals can no longer purchase a ambulatory surgery center or physician office and be entitled under Medicare to the rates, to the hospital rates. They're required. Since that point, there's been a lot of litigation that I'm sure you've read about people that were in progress, and they had half an application in and half approval. So and how they actually dealt with it, but it was to get at what you're talking about. I'm not necessarily saying I agree with it, but Congress came in their wisdom and said, we need to look at this issue. So now if you acquire a physician office, it remains at the physician office rate. So that was in 2015. They haven't made any changes since then or expanded that yet. I haven't seen any proposals to do that, but they did not want the proliferation, they had their view of acquiring other physician offices and then using the hospital rate. But this bill here, it looks like something that is pretty simple and straightforward, but it is venturing down government rate setting in an area that we haven't done so in Connecticut, and in very few, if any, and Lesser may be right, it may be only Maryland that actually does that. And it's something that we need to be really, really cautious of, and something that we do not support.
And I guess my follow-up question would be, what I find in our medical care in our industry is a lack of adequate disclosure of pricing. And it seems to be proprietary in the negotiations with the individual insurance companies, which makes it a mystery to me as to where I go with my deductible. And how would you deal with the legislature's attempts to further the role of an increasing disclosure of medical costs?
Yeah, and I'll come at this with a couple of points off the top of my head. First, I think it's important that this, and for Senator Lesser, this Insurance and Real Estate Committee had a hearing on the Office of Health Strategy Cost Growth Benchmark. We have been supportive of that. we recognize that everybody has a responsibility in order to make healthcare more affordable. We are all in this. Whether we are a hospital, whether we are a physician, or whether we are policymakers deciding what mandates to add, we all have a responsibility in looking at this healthcare system. And one of the best ways that we have seen, and we followed Massachusetts very closely, is this cost growth benchmark, because I believe we can't begin to address it unless we start to measure it. Right? We have concerns about the way that bill is drafted because it doesn't take into account specifically items related to the pandemic, and we've testified on that and how the pandemic has dramatically changed the market and will dramatically change it going forward. So we support that measure. In terms of disclosure, I would venture that we can never do enough, right? Hospitals have on their websites ability to contact someone to determine costs. Some have ability to figure out what the cost is beforehand. Can we do more? Yes, I think we all can do more. Recently, the federal government just enacted that hospitals have to provide the discounted rate. And all across the country, hospitals are trying to implement what is an enormously complicated regulation. So there is some of that going on, but can we ever get to a point, or what I sit here or stand here today to say that we've gotten to the point where I think everybody has the information that they need? No, and I think we need to do better, but I don't think the way to sort of get at this is to create another rate setting mechanism to do that.
Okay, to that end, my concern is that I need to get to a disclosure, not necessarily rate setting. I think informed consumers need to know what they're doing with their insurance and deductibles. And if I spent 35 years on Wall Street, I've learned one thing. If I can't figure it out, somebody is designing a program that makes it impossible for me to figure it out. So I'm working on figuring on how we can create a clearer system. But I have no further questions.
No, and Representative, let me just sort of tag off here, is I think that when we're dealing with disclosure, we have to recognize that what is important to the patient, right? What is the information that is most important to the patient, and how do they get that? We have to figure out a role that works with health insurers, because my plan is going to be different than your plan, and what you pay is going to be different than what I pay, because of the plan that we are under. So it is a role that is simply can't be done by hospitals and providers without significant input and responsibility on health insurers to provide information that is relevant to the patient. As it goes back, started saying, we all have a responsibility here.
No, I'm appreciative of that. I just feel personally as a consumer, I'm not a doctor. I'm not a biologist, but 90% or 85% or 80% of the medical procedures and the people operate on their basic standards in the operating procedure, whether it be a hip replacement or a knee replacement or a shoulder replacement. There are better skilled and lesser skilled, but in general, the prices I don't think reflect that. And the fact is, I don't know what those prices are. And that's what I'm looking to get to. If I need to shop for a knee, I'd like to know where I can get it done and what it's going to cost me. And I think it's still a mystery wrapped in an enigma, and it shouldn't be. So, you know, that won't always make me beloved by everyone in the industry, but I'm trying to figure out to get price disclosure, because I think it's important to help us. But thank you much.
Thank you, Representative. Any other questions for Mr. Iacobellis? We got him. If not, thank you.
Thank you very much.
And it's been brought to my attention that Senator Looney is in the hearing. Senator Looney, it is good to see you once again before the Insurance and Real Estate Committee. It's been too long since we've had you before this committee, and it's wonderful to have you here again today.
Thank you, Senator. It's always good to appear before this committee, because the Insurance and Real Estate Committee grapples with some of the most important issues in state government, and is one of the more active and probing committees of this General Assembly. So it's always an honor to be before this committee. So good afternoon, Senator Lesser and Representative Wood and members of the Insurance and Real Estate Committee. I'm Martin Looney, Senator from the 11th District, and would like to testify on several bills on your agenda today. First, Senate Bill 354, an act concerning reimbursements for certain covered health benefits, would create a requirement for site-neutral payment for certain services and would eliminate the often huge and really unexplained and unexplainable differential for those services that currently exist between private physicians' offices and off-campus hospital-owned practices. For example, an infusion of the drug Tysabri is billed at $6,700 and reimbursed at $6,400 at one independent infusion center, while one Connecticut hospital bills at $33,000 and is paid $12,000, while another Connecticut hospital bills $37,000 and is paid $16,000. This is for the same infusion for the same drug, and there are a variety of ways to move towards site-neutral payment policies. I'd be pleased to work with the committee on them because there are potentially great savings involved here. Senate Bill 357, an act concerning copay accumulator programs and high deductible health plans, is a technical adjustment to Public Act 21-14 we passed last year, which will ensure that members of high deductible health plans don't suffer adverse federal income tax consequences. Senate Bill 356, an act requiring the insurance commissioner to consider affordability as a factor in reviewing individual and group health insurance policy premium rate filings, would add the concept of affordability to criteria that the insurance department would consider when approving or denying health insurance proposed rates. The affordability of the plan for policyholders is of extraordinary importance when analyzing this data and should be one of the criteria. Senate Bill 363, an act concerning health insurance reimbursement parity for podiatrists, would provide health insurers, would prohibit health insurers from paying a differential reduced rate for a licensed healthcare provider like a podiatrist who provides a covered health benefit within the provider's scope of practice solely because that provider is a podiatrist. This is an important matter of public policy because podiatrists in many cases treat a lower income population, treat many Medicaid patients. There are many cases that podiatrists take that orthopedists don't take within their practice, and this would be just a matter of equity for a group of physicians who are seeing a substantial number of low-income people. It's a matter of equity that should allow our state to retain a highly qualified podiatrist. Would also like to express some concerns regarding House Bill 5383, an act concerning association health plans. These allow small businesses to band together to buy insurance, which would on its face seem reasonable and good policy, but there's a history of using this arrangement to avoid complying with certain coverage requirements that would otherwise apply. According to the Center on Budget and Policy Priorities, quote, many are legitimate arrangements made by associations to offer health benefits to members, but some have defrauded enrollees or ended up insolvent, unable to pay members' claims. So the bill, as currently drafted, defines these association plans as, quote, fully insured plans, unquote, which may mean that they will be required to comply with Connecticut insurance mandates. And I would urge you just, if you move this bill forward, to include language that makes it clear that AHPs must comply with all state and federal insurance mandates and requirements. And thank you, Mr. Chairman. Thank you to the members of this committee for considering these important bills.
Thank you, Senator. And Senator, you testified on a zillion bills as you do, and I think it's a testament to your longstanding interest in consumer protection and coverage issues before this committee. So I want to thank you for that and for your leadership. I don't know if you had an opportunity to hear Jim Yacobellis just before you came on in the Hospital Association testifying against site neutral payments. And, I asked him the question, we rarely see health insurers and hospitals on the same side. But in this particular case, they are both opposed to site neutral payments. I assume because the insurers think it will raise costs, and the hospitals said already on the record that they think it would lower reimbursements. What Mr. Yacobellis told us was when insurers and hospitals agree, we should defer to them. How do you sort of think about that issue?
Well, frankly, I'm surprised a little bit. I'm not surprised that the hospitals are concerned about this, but But I am somewhat surprised at the insurance industry for not seeing it as an area of potential cost, that instead they are in agreement with the hospitals and are willing to recognize these very significant differentials and pass either pay these claims or pass significant amounts along to patients. But it just seems to me that where the disparities are so large, there ought to be some way of adjusting that, because it just seems to me that if you have a slight disparity, perhaps some disparity ought to be allowed within a certain range. But it seems to me that the fact that the disparities are so large, as what I mentioned some examples in my testimony, that they should be subject to at least some regulation.
And so we heard, I mean, the argument is sort of against, from the hospital perspective at least, is that hospitals have, additional costs, and that when we have a pandemic, it's important to have, a strong hospital system, so we're able to provide an acute level of care, and their costs are sort of necessarily higher than outpatient settings. Obviously, if the costs are higher, then we're paying more. So how do you sort those two competing interests?
Well, I think again, I think it goes back to the argument we had a number of years ago, where we successfully passed the legislation limiting or banning facility fees in some cases, where we had a circumstance where hospitals were going out and buying community-based facilities, and all of a sudden you had the same provider at the same location with the same equipment providing a service, and all of a sudden the hospital facility fee added onto it jacked up the price substantially from what it was before when it was independently owned. So we passed legislation, you'll recall, you were a leader on that, to indicate that if the service is one that normally would be provided on an outpatient basis in a clinic, you could not add on a hospital facility fee just because that entity had been purchased by a hospital when it was essentially the same service operating as had been before. So I think this is an analogous situation here, where I think we need to examine what actual costs are. And as I said, if not mandating absolute site neutrality, we ought to at least have some acceptable range that shouldn't be exceeded.
Thank you, Senator. Are there other questions from members of the committee for Senator Looney? Yes, Senator Huang.
Thank you, Mr. Chair, and welcome, Senator Looney. I first want to thank you for your length of service. It's hard to just kind of remark that you've been in the General Assembly for over 30 or 40 years, sir.
Over 40. Time passes when you're having fun.
God bless you. And even though we may not always agree on issues, you are the epitome of respecting for the institution of the Senate, and I greatly admire and respect you for that. And on a follow-up note, we'll have continual discussions on the proposals that you've articulated, and I hope that we will have an opportunity to be able to interact and be able to collaborate and try to make these bills better moving forward. But I also wanted to acknowledge that as we look to celebrating St. Patrick's Day, that you are one of the biggest champions of Irish pride and heritage. And I will still remark to you that it was 5 years ago that you and Senator Ted Kennedy joined us in Fairfield to celebrate and commemorate the 100th year of the Easter Uprising that signifies the independence of Ireland and the Irish Republic. And I have to tell you, people still at the Gaelic American Club still talk about you and Senator Kelly. Well, Senator Kelly came as well.
He was there.
You, Senator Kennedy, and Kelly attended the ceremony and really made it a very special one for the people there. So I want to acknowledge you as we celebrate St. Patrick's Day week, that you are a great source of pride and son of Ireland. So thank you very much, Mr. Chair, for the indulgence and recognizing St. Patrick's Day's own. Thank you.
Thank you, Senator. I'm sure there are more people who remember Senator Kennedy being there than remember me being there. But in any case, it was a great time and enjoyed it a great deal meeting your constituents there.
Well, thank you, Senator Wong, for that trip down memory lane. I was in the Seymour Town Hall last night, and they had a new tradition I was not familiar with. They had a St. Patrick's Day Christmas tree, and I had not seen one of those before. And not being Irish, maybe I'm just new to that tradition.
Senator Lesser, everybody is Irish this week.
Fair enough. Well, thank you, Senator Wong. Any other questions or comments for Senator Looney? If not, thank you once again for coming before the committee, and look forward to working with you on these bills.
Well, thank you, Mr. Chair, and thank you for all the good work that you do annually. This committee produces some of the most important work in protection of healthcare consumers in our state, and your work is vital to our success and for equity for our people. Thank you, Senator.
Thank you. Next up, we have number 13, Melissa Linden.
Hello, sorry, my internet's not that good. I'm here today testifying on Bill HB number 5389, and I would like you guys to add accountability to all your programs involving your real estate and insurance practices, because I think that there has been no accountability, which allowed fraud to corrupt them. I think that, you know, I can go and tell you, I think I've told a bunch of the committees extensively what happened. I think it's very flawed that I was made responsibility for a foreclosure in your court system under the foreclosure mediation program, under all your Connecticut Unite that I never even entered to. I never had a mortgage, so I could never be foreclosed. I was made responsible for a rental agreement that I never had, based on fraud, based on lawyers from American Title, allowing people to use bunk title insurance policies to convey fraudulent land, fraudulently in front of the courts using your programs like foreclosure mediation, Connecticut Unite, bunk insurance policies, bunk title insurance policies twice have been used on my mother's property. Now, what happens is, hold on, you go to the consumer affairs and they do nothing. They do absolutely nothing. They hang up on you. You direct all the complaints to your consumer affair department, who do absolutely nothing. And then you allow them to work with the Attorney General to collect settlements on behalf of Connecticut, like you did with HSBC. And you don't dish the settlements out to people. You keep them. I'm not saying you as legislators, employees within your government. I don't think you guys should be starting any new policies until you correct the ones that don't work within your staff. You as legislators are responsible. Then you guys deem it that, oh, that's federal or state. Well, you as state employees are responsible to go after our federal employees, like Richard Blumenthal, who's corrupted all our housing, and you've let him stay in power and take our homes. I've been responsible for something I didn't do, fraud.
Linden, are you testifying?
You guys need to look into it.
Thank you. I'm trying to follow, and I just wanted to clarify, are you testifying on any of the bills that we're hearing here today?
Absolutely. I told you 5389, adding accountability measures to your bill. You need to have employees accountability, because you don't make anybody employed. Like John Rubik from American Title, he passed a bunk, along with Josh, a bunk title insurance policy. Connecticut's a title state. So me as a person, even though I hold the deed to my parents' property, I don't matter, because lawyers commandeer real estate deals and legislators allow them to, that supersede constituents' words. So even if I'm telling the truth, lawyers, judges, their word means more than mine. And that's not how the Constitution's based. And you have allowed people, you know, we have a 14th Amendment, and you've allowed.
Thank you. Your
lawyers.
3 minutes has concluded.
Okay. Thank you.
Thank you.
So accountability is what I'm asking for.
I appreciate that. Representative Wood.
Sorry, I have to click all these buttons. Sorry about that. Melissa, thank you for being here today. I was wondering if you could just summarize your concern with the title insurance, just so that I can fully understand what.
American Title issued a title insurance policy to Congressman Anthony Aponte, at which he fraudulently conveyed my parents' title ownership to a Mohammed Islam, then went into a housing accord and ejected me. Now, why this is so odd is I live 6 months in the United States and 6 months in Canada. 1, I've never had a mortgage. 2, I've never had a rental agreement. So that's fraud. And judges allowed them to do it. They commandeered judges, they allowed them to do it. And all this fraud certainly sits in courts and nobody does anything. And what the worst of it, and why I say the title insurance, you guys got nabbed for doing this. HSBC and Household Realty with IRE processing was a bunk title insurance company that issued a bunch of, like, when I say bunk, that's fraudulent title policies that allow people to go and convert. So I can show you a title insurance policy from American Title on my parents' title, on my parents' house, that says Mr. Anthony Aponte has the warranty deed to my property, when really I have it. So they use those. The American Title didn't check. They didn't make Mr. Aponte prove that he had this deed. They just took his word. None of these documents, title documents, should be issued on word or affidavits by attorneys. So Mr. Aponte then, to certify the title insurance, went and said all my businesses are closed on his word. He's not on the business. He's not representing me, has no power of attorney. They also did this to my mother. They also, attorneys represented on foreclosure certificates with title insurances and all that, that my mom gave them stuff that she never did. But the attorney's word, not the government documents, matter. Not my deed matters, it's Mr. Aponte's word. So that's what I'm saying. You're allowing American Title to issue title insurance policies that aren't real. These guys go move houses on them, and then nothing's ever said. They don't have to pay out because the title insurance was only, you know, something printed out. It was a quote. And they went and moved something on a quote, not a real instrument. Does that make sense?
Thank you, Mr. Chair.
So it's gaslighting the whole situation. Attorneys gaslighting things with affidavits.
Thank you, Representative Wood. Thank you, Ms. Linden, for your testimony.
About 700 to 1,000 houses have gone down like that. And Household Realty, about 1,000 back in 2016.
Thank you, Ms. Linden. I think we've heard your testimony, and I will say that we have a cognizance here over the insurance industry. The foreclosure mediation program is usually overseen by the Judiciary Committee or by the Banking Committee. It's certainly another important program that's provided resources to a lot of folks, but we could always do better. Thank you very much. And now I'd like to go to number 20, Jill Ricard, followed by Jan Kritzman.
Thank you, Mr. Chair. Madam Chair, distinguished members of the Insurance and Real Estate Committee. My name is Jill Rickard, and I'm here on behalf of the American Council of Life Insurers. ACLI represents 280 member companies that are dedicated to protecting consumers' financial well-being through life insurance, annuities, retirement plans, long-term care insurance, disability income insurance, as well as reinsurance and supplemental benefits like dental and vision insurance. We have submitted letters in support of 2 of the insurance department's bills, House Bill 5382, which would enact into law recent changes to the NAIC Model Holding Company Act regarding group capital calculation, and Senate Bill 359, which would update Connecticut's standard non-forfeiture law for individual deferred annuities, also in line with recent NAIC revisions. But I'm here specifically to speak to Senate Bill 356, which would require the insurance commissioner to consider affordability as a factor in reviewing individual and group health insurance rate filings. While we can appreciate the sponsors' concerns about the affordability of health insurance, Senate Bill 356 is not, in our view, the solution. The bill is problematic for a number of reasons. First off, I'll just point out that the bill would impact not only major medical health insurance policies, but also voluntary benefit products such as dental and vision insurance, short-term disability insurance, hospital indemnity coverage, and long-term care insurance. We question whether this was the intent of the sponsor. It's unclear why the additional level of scrutiny is necessary for dental plans, for example, since these products are typically considered by most people to be affordable. More broadly, the bill is unnecessary and imposes an ill-defined regulatory burden on the insurance department as well as on insurers. The insurance department, as has been mentioned, reviews and approves insurance product rate filings that are actuarially sound. This means that premiums are expected to cover claims and operating expenses. As Commissioner Mays mentioned, Connecticut law also directs the department to ensure that rates are not excessive, unreasonable, or unfairly discriminatory. We agree with Mr. George and the IAC that the additional vague, undefined, and very subjective affordability criterion is not necessary. The bill does not define affordability, so it's unclear how the commissioner would make such determinations. And in any case, it would be very difficult to place parameters around affordability because the concept is so highly subjective and stems from an individual or family's willingness to pay for a product. Thank you for the opportunity to testify. I've also submitted written testimony along with the AHIP, the NADP, APCIA, and the IIC on this issue. So again, thank you, and I'm available to take questions as well.
Yes, thank you, Ms. Ricard, and I appreciate your testimony. Just, I think the obvious question is, do your members write policies in the state of Rhode Island? We heard testimony that Rhode Island was a model that the proponent is hoping to follow. If so, how does that work? And you know, what kind of lessons can we learn from Rhode Island's example?
We do write, our members do write in Rhode Island. I'm not prepared to answer that question, although I did hear the testimony on Rhode Island. I'm happy to follow up. I do know that that is a very different concept. It's not part of the insurance department's review of rates. It's a different department, the Office of the Health Insurance Commissioner, I believe. And I believe they have a much broader target of sort of reform of the entire industry. So it's not just affordability. I'm happy to check into that if you'd like more information, but I'm not prepared to answer right now.
Yeah, I think that would be really helpful. I mean, if the idea is that Connecticut should do more to copy Rhode Island, you know, it's not too far from here to there, and so it'd be helpful for us to, you know, get more information about how, you know, what's working well, what isn't there, and use that to evaluate whether or not this concept is feasible and how it would impact the rate making, rate approval process. Representative Wood.
Thank you, Mr. Chairman, and I would second what Chairman Lester said, that I would love to see that information based on Rhode Island. And is the affordability criteria used in any other insurance lines?
Not in terms of the industries that we represent. Not life insurance, supplemental, disability. We're not aware of other states that require affordability in those lines. I think there may be some states that institute this concept in terms of major medical healthcare policies, but not in the lines that our members write.
Thank you very, very much for your time.
Thank you.
Thank you, Representative. Other questions for Mr. Carr? If not, thank you very much.
Thank you.
Next up, an old friend, not so old, a good friend, Representative Jan Kritzman, who represents herself always very well. Hello, Jan. Jan, are you there? I think you're on mute.
Yes.
Oh, there you are.
Yes,
okay.
I am. Hi, greetings.
Hi, Jan.
Hi, everybody. Greetings, Chairpersons Lesser and Wood, Baby Sam, and esteemed members of the Insurance Committee. I am Jan Kurtzman. I live in Newington. I'm a 9.5-year breast cancer survivor. I support Senate Bill 358, an act concerning required health insurance coverage for breast health benefits. There are so many life-changing problems in today's world that we as individuals really can do little about. Ukraine and Russia, COVID, outrageous inflation, the southern border, homelessness, crime. I could go on, but I won't. But in the midst of all of this, we must never forget about the epidemic of breast cancer. I certainly have not. It's the only nightmare that we can actually do something about, especially here in Connecticut, where we suffer from the second highest incidence per capita in the nation of breast cancer diagnoses. 3,600 newly diagnosed cases annually in women and approximately 250 in men. No, we can't prevent breast cancer because there's no vaccine and there's no warp speed. But there is one tool in the toolbox, and that's the earliest possible early detection of breast cancer. We have to eliminate any financial barriers to receiving essential diagnostic follow-up testing, like mammograms, ultrasounds, and MRIs, following an inconclusive screening mammogram, especially for the approximately 40% of women with dense breast tissue. That would be me. Diagnostic testing, it's a callback for further studies. It's that scary letter that you get in the mail and you leave it on the counter and you don't open it up for hours, trying to gather up the courage to open it up. It means that the radiologist saw something on the screening mammogram that looked either suspicious or inconclusive. You can't walk away from this letter because of the cost. Senate Bill 358 will provide for no out-of-pocket costs, no having to meet outrageous deductibles, copays, co-insurance, or cost sharing. No financial barriers for anyone to go back and get essential follow-up diagnostic testing for a definitive answer. In 2019, with the successful force of Senator Lesser, Representatives Kerry Wood, Gary Turco, and Dorinda Borer, my dedicated and courageous team of legislators, I campaigned to mandate insurance coverage for screening mammograms, essential follow-up ultrasounds, MRIs with no out-of-pocket costs. Today, we need Senate Bill 358, which will expand this coverage to diagnostic breast cancer testing, as well as other important related coverages for those insured by either individual or group health insurance plans. You, our legislators, are the only ones that can make this happen. You're my heroes. We came so close last session. I don't know how many women in Connecticut missed their annual mammograms in the past year and a half because of COVID, but dozens of them have admitted to me that they were either delinquent or negligent and are now paying the price of a later stage breast cancer diagnosis. The later the stage, the harsher, the costlier the treatment, and the poorer the prognosis. Early stage detection involves maybe a lumpectomy and radiation. The cost is about $40,000 to $50,000. Late stage detection, probably mastectomy, chemotherapy, radiation, reconstruction, expensive clinical trials, then more trials, and a diminished quality of life. The cost, about $250,000. We have a lot of catching up to do. We are way behind the 8 ball on this. COVID has been a massive disruptor.
Thank you.
Of the
You've reached your 3 minutes. Can you please summarize?
I can. COVID has been a massive disruptor of the earliest possible early detection of breast cancer. Let's not waste any more time and lives. Please pass Senate Bill 358 this legislative session. Make Connecticut not only the gold standard in the nation for being the first state to legislate dense breast tissue notification in 2010, but also right now for the earliest possible early detection of breast cancer with diagnostic testing and no out-of-pocket costs. And people, no more procrastinating. Give a damn, get a mammogram. Don't just do it for yourself. Do it for all the people who depend on you. March is National Women's History Month. Let's make some history here in Connecticut. All breasts matter.
Thank you, Jan. You never disappoint. You are always a force of nature before this committee. And, I think there are a lot of paid lobbyists who would do well to learn how to do it from you. And you've been just such an advocate for saving lives. And it's you made it. You were instrumental behind that law that we passed in 2019. And if all goes well, we may pass another landmark bill this year. So I just want to thank you for your tireless advocacy, and you give me energy, and I know you do for the other members of this committee. So thank you. The only thing I can say is I'm a little disappointed we don't have your boxing gloves here today, but I'm sure you'll bring them back. Never mind. You have your boxing gloves. Okay.
I have one more prop I have to share with you. This is my COVID mask. Breast cancer ribbons. And I also want to show you here. Wherever I go out, anywhere, grocery store, restaurant, I don't care where I'm going, I carry these little business-sized cards with me. And when I see women of color enjoying themselves, I walked up to them and I kind of ruined their fun by saying, women of color, breast cancer is colorblind. All breasts matter, give a damn, get a mammogram. And my name and contact on the back. And I've probably given out 200 or 300 of these since October.
I believe you. You are tireless, and you're saving lives. Representative Wood.
Thank you, Chairman Lesser. Hi, Jan. How's everything going today?
Oh, like I'm doing always, I'm talking about breast cancer. I hate to talk about breast cancer, but I do it all night and day for years. And I hate pink. It's just not my color, but I'll wear pink until we pass SB 358, and then I'll still wear pink.
I was wondering if you could just educate our committee a little bit on what this bill does in terms of what happened in 2019. We did see some loopholes in what dense breast ultrasound coverage would be covering. And I was wondering if you could just explain some of the other technologies that are used for early detection for women with dense breasts.
Well, the first line of action is to get your mammogram. You don't know if you have dense breast tissue because you can't feel it, you can't see it. Your breasts don't look any different than somebody that doesn't have dense breast tissue. And since so many women do have dense breast tissue, and it's a precursor. It's a precursor, as well as family history and many, many benign findings from biopsies. There's a lot of precursors to getting breast cancer, and dense breast tissue is certainly one of them. Your first step, get the mammogram. You can get either 2D or 3D at the choice of the woman. Whichever you get. It must be, if you have dense breast tissue and it's you're notified, you have to follow up this mammogram with an essential breast ultrasound. For example, or an MRI, if the ultrasound is still inconclusive, but you just know something's amiss. You have a funny sensation or huge family history, or whatever, something's telling you, I've got something and it needs to be discovered, and then you'd need the MRI. All of these tests from 2019 are considered screening tests. Let's just say you get that letter in the mail and you get a call back for a diagnostic test. The mammogram, screening mammogram, is covered federally. It doesn't cost you anything. You can, any mammogram center, and you can get their mammogram for free. It's when they find something that screening is covered for the ultrasound and the MRI. Now you need diagnostic. That costs you money out of pocket. Perhaps you're a single mother and you've got 2 or 3 kids and you've got 1 or 2 or 3 jobs, and you have a very high deductible, $7,000, $8,000, $9,000 deductible, and you have to have diagnostic testing now, and that could cost a diagnostic mammogram, I don't know, $500, $800. You can't afford it. You haven't met your humongous deductible, so you put it off. You say, well, they saw something and they don't know what it was inconclusive, and I'm going to walk away from this because I can't afford it. Now there's a financial cost barrier between you and finding out what could possibly be a big problem. You come back for a mammogram the next year or even earlier because now you feel a lump and now you feel something, and now you've gone from maybe early stage diagnosis to late stage diagnosis. And like I said, the cost, the differential in the cost between early and late is humongous. And I would think that the insurance companies would be very interested in you receiving the earliest possible early detection of breast cancer, because it certainly saves them a ton of money, and it saves you. It'll save you your quality of life, and it will save your life.
Yeah, that's a really great point upon, on the cost to the entire healthcare system, Jan. Thank you for your comments. Thank you for your testimony and all your hard work on this.
Thank you, Representative. Any other questions for Jan? If not, it's great to see you, and I'm sure we will see you soon. And
A&R members be included in actual DRS.
Representative Metzger, you have your hand up?
Study.
Yes.
Including these frontline workers will help.
Hold on, sorry.
Besides,
Just had to cut off. Jan, I just wanted to thank you for your testimony. This is, I've only been sitting in the legislature for 3 years, and I think your testimony has been inspirational. And I am a penny pincher, and I do look at things, but I think I've never had an issue with the bills you proposed, the bills you supported, and what we're trying to do. And I think your mission to protect and save people from this horrible disease is so important. So I want to just, as a word of support and salute to all your efforts, let you know that your voice is heard and it matters. Thank you much.
Thank you,
You're very,
Representative.
very welcome. You're very welcome.
All right. Well, thank you, Jan. Good to see you once more. Next up, we have Rebecca Rito, followed by, I'm not sure who is followed by. Perhaps Roy Rampton.
Thank you. Chairman Lesser, Chairwoman Wood, Ranking Members Huang and Pavelak-Diamato, and members of the Insurance and Real Estate Committee. My name is Rebecca Rito. I'm a licensed marriage and family therapist, and I'm the chair for the Connecticut Association for Marriage and Family Therapy, or CTAMFT. I'm a resident of Portland and own a private mental health practice in West Hartford, and I'm speaking today regarding SB 360 and HB 5391 on behalf of CTAMFT. CTAMFT currently represents over 1,500 licensed marriage and family therapists, or MFTs, throughout Connecticut. MFTs are employed in various clinical settings throughout the state, serving diverse mental health needs. Additionally, many MFTs are in network with the various private insurance carriers that operate in our states. As you know, Connecticut is faced with a mental health crisis. Mental health providers are doing all they can to address this crisis while continuing to face many insurance-related barriers overburdening their systems. These barriers, which are more specifically outlined in our written testimony, include ever-changing claim submission procedures, including frequent claim submission protocol changes for insurance processing systems resulting in frequent processing errors, lengthy waits for service reimbursements, frequently weeks, sometimes months, frequent audits, including justification for session duration and frequency despite the provider's clinical recommendations of diagnosis and treatment modality, and clawbacks of previous payments and erroneous claim denials despite not being paid for current sessions. These ongoing issues are driving mental health providers to remove themselves from provider networks. Those providers that choose to stay in network are discouraged with the poor reimbursement rates and bogged down by time-consuming paperwork and phone calls from frequent errors and audits. Simply put, they're seeing their time as better valued and more clinically focused as an out-of-network provider. Many have lost trust in the system working for insurance companies. We request that the study referenced in HB 5391 be carried out by an independent task force that has representation from the Department of Insurance, but not conducted solely by the department itself. We request the task force consider the following areas of focus to increase insurance provider collaboration: improve communication between providers and insurance representatives through regular updates to insurance panel lists of in-network providers, as well as updated provider relations contacts. The development of systems and protocols that decrease claim processing times and reduce errors and inaccurate denials of payment of claims. Creating clear guidelines for claim processing code adjustments with advance notice to providers and implementation of code changes after insurance systems are updated. And requiring standardized and regulated claim auditing protocols to reduce provider audits and monetary clawbacks from providers. We urge you to support SB 360 and HB 5391 with the aforementioned changes to better serve Connecticut residents in desperate need of mental health treatment. Thank you.
Thank you so much for your testimony, and certainly we've been hearing a lot of those concerns for some time, and I think there's a bipartisan interest in this committee in figuring out how we can get as many mental health providers, including LMFTs, into provider networks. So appreciate your thoughts on suggestions on those two bills. Are there questions for members of the committee? If not, thank you very much.
Thank you.
Next, we have Roy Rampton, followed by Dr. David Emmel.
Thank you. Chairs Lesser and Woods, Ranking Members Huang and Pavelak-Diamato, and members of the committee, thank you for this opportunity to testify before you today. My testimony is related to Agenda Item 1, Senate Bill 357, an act concerning copay accumulator programs and high deductible health plans. My name is Roy Rampton. I am testifying on behalf of the Connecticut Bankers Association and the American Bankers Association Health Savings Account Council. I am a consultant and subject matter expert on health savings accounts, having led the implementation of the HSA program after its enactment in 2003 while serving at the U.S. Treasury Department. We support the passage of Senate Bill 357 because it would prevent Connecticut residents that own and contribute to health savings accounts from needing to refile their income tax returns because of the unintended consequences from a law passed by Connecticut last year, Senate Bill 1003, which became Public Act 21-14. Since this law has already gone into effect, health savings account owners in this state are at risk unless the law is amended retroactively to the beginning of this year. It is also important that the law be amended as soon as possible so that account owners, employers, and financial institutions have the certainty they need to manage their health savings accounts during the balance of 2022. Senate Bill 357 accomplishes three important things. First, the bill allows the existing law to be applied to high deductible health plans to the maximum extent permitted by federal law. Second, the bill provides an exception for certain high deductible health plans, which will allow enrollees in these plans to continue to make tax deductible contributions to their health savings accounts. Finally, the bill makes the necessary changes retroactive to January 1, 2022, the effective date of the existing law. So there is no confusion or negative impact on health savings account owners, such as needing to prorate contributions or refile income tax returns. Likewise, confusion will be minimized for employers that offer and contribute to health savings accounts for their employees. Unfortunately, Connecticut is not alone in facing these challenges. Other states have passed similar laws, some as early as 2019, and most have only recently learned about their impact. My colleagues and I continue to discuss these issues with state legislators and regulators, including the National Council of Insurance Legislators, the National Conference of State Legislatures, and the National Association of Insurance Commissioners, among others. We are making progress, but still have more work to do. In conclusion, we support Senate Bill 357 as drafted, and we urge immediate consideration and enactment of this important legislation. Thank you for the opportunity to provide this testimony today. I would be pleased to answer any questions that you may have.
Yes, thank you, Mr. Rantham. And we were warned by Mr. Mangello, who spoke earlier, that you were the subject matter expert, and we should direct all the hard questions at you, and we may do that. First, I'm going to ask the same question I asked him earlier. We got a letter this morning from 13 patient advocacy groups led by the New England Hemophilia Association, and they suggested alternate language that they claim will address this issue. And I know it's short, so I'll just read it quickly if I can. If under federal law, application of subsection A would result in health savings account ineligibility under section 223 of the Federal Internal Revenue Code, this requirement shall apply only for health savings account qualified high deductible health plans with respect to the deductible of such a plan after the enrollee has satisfied the minimum deductible under section 223, except for with respect to items or services that are preventative care pursuant to section 223 C2C of the Federal Internal Revenue Code, in which case the requirements of subsection A shall apply regardless of whether the minimum deductible under section 223 has been satisfied. I'm not going to ask you to practice law over Zoom, but I was curious if that language seems like it might be on the right track of being able to sort of get to what we were trying to do without violating health savings account. And obviously, if you need to look at the language or have further conversation, I think that's totally reasonable.
No, we are familiar with the language. This language has been discussed as part of a model act amendment at the National Council of Insurance Legislators meeting last November. We don't have any opposition to the language. Personally, we prefer the language that is in the current bill because it is taking language that is existing in Connecticut statute and thought that that would be better for the actual bill itself.
Okay, great, thank you. And I have one other question, and it's not actually about a bill that's before us today, but about one we're going to be hearing on Thursday, which is House Bill 5410. And we've had, for a number of years, we have had a group of stakeholders looking at the issue of high deductible health plans and what pro-consumer reforms we can implement without breaking HSAs. And the real question is, well, where are we going to find a subject matter expert who can tell us how to do that? And unfortunately, you stumbled into this committee And so what I would be curious about, and I don't know if the CBA would make you available, was if we could sort of, put our heads together, perhaps on that bill, assuming they're willing to make you available, to really figure out what we can do, because the bet noir is always, hey, this is gonna, people are gonna lose their tax deductibility, but we would really like to figure out ways to make those HDHPs work better for consumers if we can.
I would be happy to engage in that discussion with you.
Wonderful. Thank you so much. And I see we've got a bunch of people with hands up. Representative Meskers, followed by Representative Wood.
Thank you very much for your testimony. I guess I got familiar with this at one of the NCOIL meetings and the drafting of the language. I tend to agree with Senator Lesser. If the wording, the comprehensive wording from NCOIL, we'll have to reconcile that with state statute, but I kind of like the most comprehensive view of that, so we can maximize the benefit, the tax deductibility of our high deductible plans. I think the wording that he's suggesting may do that, although granted, I never saw the inside of a legal office in my life, so I can't certify that. So there are two things. I'll ask you, for your input on that, and I will check, I guess, with legislative office about reconciling it with existing statutes in the state. And going forward, I would like us to have continued contact as we draft legislation as it relates to either the existing tax code or anticipation of what tax code may impact the taxability or tax exempt nature of our deductible healthcare plans. So I want to thank you for your testimony in advocacy, and I look forward to a resolution on this issue. Thank you.
All right, I will call on myself next to ask questions. Thanks for being here, Roy. My question is, what happens if we don't pass this bill? What are the implications onto those with HSAs?
So as we understand the IRS guidance, the plans that are currently available in the state of Connecticut that have to comply with the law that was passed year would lose their tax deductible status for health savings accounts. So all of those individuals who are in those state regulated plans would no longer be able to contribute to their health savings accounts, many of whom are relying on those to pay for their out-of-pocket costs as they meet their deductibles and other out-of-pocket expenses. So we would want to tell them that as soon as possible. I'm sure they're not going to be happy when they hear about that either, because I believe most of them were under the understanding that the plans that they enrolled in would in fact make them eligible to contribute to those health savings accounts. So that also goes for their employers who may be offering these plans as a benefit to small businesses and self-employed individuals. Many of those employers also make contributions to those employees' health savings accounts. They would no longer be able to do that because their employees will not be eligible.
And I did just want to follow up on something we're working on just with the high deductible health plans and trying to encourage people to start HSAs. I'll ask you this stuff offline because it's not relevant to the bills that we're looking at today.
Okay.
So basically, what I'm hearing is that there's an urgent need for a fix, and if not, we are leaving people exposed to losing their tax deductibility on those plans. And have other states passed this fix? I believe I heard one state, Virginia has. Have other states plan on passing a fix?
So there are about a dozen states who are in the same situation as Connecticut, having passed a law, some of which were in 2019. So they're really behind the curve. Virginia just passed a law that is waiting the governor's signature that would fix their law as you are proposing to do. Illinois has a bill that has passed their House, but is currently in the Senate. We're confident that that one will pass the legislature and be signed. There's a bill in Oklahoma that is also moving through their legislature, although it's still in the original House. But again, confident that bill will make it through the legislature. Louisiana just went into session yesterday and has some pending bills to fix their law. All the others, though, we've been waiting to hear from and may not fully yet understand that they have a problem in their states.
Great. Thank you for your testimony. I look forward to catching up with you offline as well.
Thank you.
Thank you, Representative, and apologies, had to step away for a second. Representative Nuccia.
Thank you. I think the good chairwoman just stole all my questions. So I just want to make sure I am making sure everybody fully understands. If we do not pass this, then what is that? It means basically that the money that has been put into people's HSAs are now taxable, correct?
They actually have to take the money back out because they were not eligible to put it in. So that's how the tax impact works for them. You know, any employer money, you know, could end up becoming taxable to them because they were not an eligible individual.
Okay, and I'm going back and forth between, I haven't seen the language that Senator Lesser has right now to kind of look at it, but from what you are aware of, what is the differences between the existing language that we have in this bill and the language that you say you may have seen that Senator Lesser has?
I would say that it's a level of specificity, the alternative language being much more specific about which sections of the HSA statute would be modified, how the limitation for these high deductible plans would apply to those plans. So, you know, the intent is the same, I believe. It's just there's a lot more detail in that model language that was read by Chairman Lesser earlier.
Do you see it as I hate to ask this, but do you see it as a better language or not? Is it going to open us up to more things? Because I think when we start to look at specificity, you might be eliminating other areas that you want to make sure that you don't know that you're doing it, the unintended consequences of it. So I'm trying to understand what's your professional opinion between the two pieces of verbiage.
So my professional opinion, I am not an attorney, is I certainly understand the specificity in the alternative language. I do not understand Connecticut statute well enough to really comment on how good, if you will, the current language is. Personally, having worked on Capitol Hill myself in the past and written many laws, I prefer that language always reference existing statute because everybody in the state seems to understand what that means. When you bring in a bunch of new concepts and language, sometimes that raises more questions than it answers. Would I have drafted the alternative language the way it was drafted? No, but technically it, you know, does not raise any issues that I'm aware of, with the exception of not fully understanding existing Connecticut law.
Okay, all right. I think that helps. Thank you very much.
You're welcome.
Thank you, Representative. Other questions for Mr. Anthem? If not, thank you for being here today, and thank you for your expertise in this area.
My pleasure.
Next up, we have Dr. David Emmel, and I believe after him, we will hear from Dr. Farquhar.
Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee, on behalf of the physicians and physicians in training of the Connecticut State Medical Society, thank you for the opportunity to testify today on Senate Bill 5391. My name is David Emmel. I'm a practicing ophthalmologist in Wethersfield. Most of you know me. I'm the chair also of the Connecticut State Medical Association Committee on Legislation. The mental and behavioral health of our patient population is of great importance to the physicians of Connecticut. We're also deeply concerned about the mental and behavioral health of our own member physicians and other healthcare providers who have endured rather horrific conditions through the COVID-19 pandemic, on top of additional burdens that we've been facing continuously from both federal regulations and insurance company burdens like prior authorizations and the difficulties with high deductible health plans. But I would like to concentrate on 5391 and specifically comment that we think that the focus of this legislation, which seeks to create a task force to encourage healthcare providers to participate in networks, is misplaced. That we're really putting the cart before the horse when we adopt this approach. What's really needed in Connecticut is some sort of strengthening of the network adequacy statutes. We have an understanding in place that networks need to be adequate in order to provide the quality of care that the people who subscribe to these plans deserve and need. Clearly, this is not being met in Connecticut with regard to mental health. The reimbursement is not sufficient to attract both psychiatrists and other mental health care providers. And there are also the issues of the burdens placed on us by things like prior authorizations, clawbacks, and downcoding. I would like to conclude my formal testimony with that and be open to questions if there are any from the legislators.
Thank you so much, Dr. Emmel. It's good to see you again. I may have some questions, but I know that Dr. Anwar, Senator Anwar, does as well. So I'll turn it over to him first.
Thank you, Mr. Chair. Thank you, Dr. Emmel, for your testimony. You're touching on something very important. We have seen physicians leave our state. We are training the best physicians in the country, and as soon as they have an opportunity, they leave our state. Could you help us understand why that's happening and what can be done to address that, and then how is that linked with our conversation this afternoon?
Well, it's certainly very linked because you're exactly right, Senator. We train some of the best physicians in Connecticut at our training institutions, and most of them leave the state. It's not been a good environment for people to start physician practices because of a lot of the regulations that make it harder. Connecticut is a more expensive state to live in. That's certainly part of it. And we have some of the highest malpractice awards in the country here in Connecticut. And young doctors setting out are very aware of these things. They're published online in reports. There are a lot of things. I think we're ranked number 47th in the country with regard to retaining physicians. So it is a deep problem, and it certainly affects our mental health care providers, the psychiatrists in the state. So anything we can do to help that problem would be a good thing.
And the challenge that we do not have enough psychiatrists, and then we are looking for all other options to provide care to our children and adults. Is this because of the pay scales and the lack of appropriate payments for the services? Is that part of the challenge, you think?
I think the pay scale has been a huge part of the problem. And just the failure of the state to address network adequacy in general. I think, we need to look at other models for determining what defines an adequate network. And I would suggest that if we form a task force, it would be designed to do something along those lines. I'm personally a fan in favor of economic plans that would penalize the insurance industry economically if they didn't create a plan that was adequate. Similar in some ways to, for example, the surprise billing statute that we passed some years ago in Connecticut, which provides a mechanism to protect patients from the surprise bill, but ensure that providers are not punished if the insurance plans do not provide networks that compensate them adequately to cover their services.
So again, for somebody in the community who's listening, and tell me what you think about the network adequacy. What do you mean by that?
Well, we've seen the trend towards narrower and narrower networks. And this clearly, you can see that it benefits the insurers as they can kind of clamp down on what they're paying out and limiting services by making it more difficult for patients to see the providers that they need to see. So whatever the mechanism is, it needs significant improvement to ensure that the networks are adequate. You know, when you subscribe to a plan, when you sign up for one, as I had to do this year, it's very, very hard to tell what you're buying. It's not like any other commodity that any of us are used to purchasing. I remember just being totally bewildered by the variety of options and the shifting scales in terms of how I would be covered for inpatient, outpatient, deductibles that vary all over the place. And not to mention that you really don't have a lot of insight into who is in this panel of providers that I'm signing up for. And I think a lot of people fall victim to that.
Mr. Chair, thank you for indulging me. I just have a couple more questions. So Dr. Amel, again, on the, I'm going to try to give you a scenario, and then maybe that's what you're trying to explain. So you're an ophthalmologist. So if you're going to do a cataract surgery, with the patient, the insurance company will have about 3 doctors who can do the procedure, as opposed to there are 30 doctors in the region. So as soon as the person goes to the 4th doctor, who is not a part of that network, the physician doesn't get paid, the patient gets a surprise bill, and they of course are unable to pay. So that's the way they are narrowing down the network and trying to restrict care. Is that what you're suggesting?
That's certainly part of the picture. Yes, absolutely.
Okay. And you're in a private practice. How are the expenses when you have 1 or 2 people dedicated to prior authorization, and what is the status of deductibles? How is that impacting your sustainability of your practice?
Well, I'm not precisely in private practice anymore. I guess I am, because I'm now part of a large multi-specialty group. But just a year ago, Senator, I was self-employed, all by myself, a solo ophthalmologist, one of the few left in the country, and certainly in the state. And I really, truly enjoyed being my own boss and having control of everything in my office. The thing I couldn't control was the behavior of the insurance industry and the burden of prior authorization. When I started on my own back in 1989, I could run my entire practice with 1 employee. She was my wife, and she was pretty amazing. But we could do all the work we had to do with the business side of the practice with just 1 person. By the time I was forced to give that up, I had to have 6 people, including 1 person who was pretty much full-time doing just prior authorization.
Thank you. Thank you so much for your testimony. Thank you, Mr. Chair. Thank you, Dr. Amel, for your work.
Thank you for this opportunity.
Thank you, Dr. Amel. And I think that last example speaks volumes about the inefficiencies, the administrative inefficiencies of this whole system. Representative Nuccio.
Thank you, Mr. Chair. Hi, Dr. Amel. How are you?
I'm good.
Good. I have a couple of questions for you on the network adequacy thing. Are you aware that network adequacy is derived from the federal, from the PIA law?
I do not know the details of that law, I confess. So, but certainly there must be things we could do in Connecticut, working with federal law to improve the adequacy of our networks.
So in the state of Connecticut, there are 8 counties, 7 of which are found to have adequate networks. The 1 county that does not have an adequate network, it has adequate network with the exception of child mental health and substance use disability. So the state of Connecticut, when we audit the mental health area, Connecticut is found to have an adequate network. Now, that's by the federal standards. So my concern here is, I've said frequently, the problem is we don't have enough providers in network, and we can't make providers be in network. So, and I would think you would agree with that as a doctor, an insurance company should not be able to, nor should the state of Connecticut mandate that you take insurance. Would you agree with that?
I'm not sure I understand your question.
So as a doctor, right, from what you're saying here, are you basically saying that the state of Connecticut should mandate that all providers have to be in an insurance network?
No, I absolutely am not saying that. I'm saying that insurers that create a network need to take steps to be sure it is truly adequate. If you basically exclude one category of healthcare provider entirely, and whatever the feds are saying about whether each county has an adequate network or not, we know in Connecticut that we don't have adequate networks when it comes to mental health care.
But see, I guess I'm challenging that, sir, because the state of Connecticut Department of Insurance says we do. They say that our networks are adequate. Now, from the perspective of creating more availability, then we would have to have more providers be in network. And I do think there is a massive bridge that needs to be gapped there, because you have a lot of insurers, especially in the one county that is not adequate. They're not adequate because the supply and demand is that people are paying $200-300 an hour for a visit. So there's no incentive for those providers to come in network. And from a network adequacy perspective, I just want to clarify a piece of misinformation there. If your network is found to be inadequate, what that means then, per the Department of Insurance, not me, is that all claims have to be paid at the in-network cost share. So it is not a higher impact to the insurer at that point. If your network is inadequate, that means you pay the same exact cost share as an in-network provider, regardless of the cost. So again, that's not necessarily an incentive for providers to jump in network if they know they can continue to charge $300 an hour and the insurer is only going to have to pay their cost share. So I'm all for mental health, progressing with the mental health stuff here, but I want to make sure that we're not saying things that aren't necessarily accurate. 7 out of 8 of Connecticut's mental health networks are found to be adequate. One county has one subsection that is found to be not adequate, and that is children, mental health, and substance use disability in Fairfield County. So I think we need to have the conversations that we can't mandate something on the insurance companies. You can't say you have to have X amount of providers if providers don't want to be in network. So to me, the issue is how we get them there. Just like you can't mandate an insurance company to have X amount without mandating said doctors to say that you have to be in network. So I just want to make sure we're using the right things here.
I think that the industry could provide the inducement. I think they have just decided they don't need to, or they have found a way around it. I hope this committee will have the opportunity to hear my colleague, Dr. Hakam Zagar, who is, I think, number 40, but unfortunately was on call this weekend and has emergency surgery. Right now, she's operating on 2 individuals. But depending on when her number is called, she may be able to testify to her own personal experience, which is very compelling. She has a lot of knowledge of the statute on this issue, and I sincerely hope she'll have the opportunity to address it more. I think more can be done. I think that Senator Anwar made some excellent points. There has been an erosion in Connecticut in terms of physicians. And it's not been something that happened overnight, but it is something that can be fixed. And I think we need to put our collective minds to it to fix it.
I would agree. I think we definitely do. We need to get the people at the table to figure out how they can come up with a workable plan. I just don't think the state of Connecticut mandating that insurance companies, and by the way, network adequacy, if you're found to be an inadequate network, you have to go into monthly remediation to show exactly what you're doing to try to get more providers in network. So it's monitored by the Department of Insurance on a monthly basis. So I absolutely agree that we have a lot more that we have to do. I just don't think the state of Connecticut mandating insurance companies have to have X amount of providers, or conversely, like I said, X amount of providers, you have to be part of insurance. So I think you can't mandate one without mandating the other. That's my take on that one there. But thank you for answering my questions. I appreciate it.
Thank you, Representative Nuccio. I would just say that although I think it's important to talk about quantitative impacts on decisions whether to enroll a network or not, we've certainly heard even just today about non-quantitative impacts, including burdensome restrictions on things like prior authorization. Earlier, we had to deal with specific requirements that the payers were implementing around telehealth that we've since restricted. But I would just say that I think it's important looking at what we can do to make sure that there are robust provider networks, that we're looking at those non-quantitative restrictions that Dr. Amel mentioned, having to have 6 employees on staff just to handle paperwork issues. And that to me seems like a huge disincentive to participate in a plan if you can get around that. So,
sir, I agree with you on that. I think, part of our legislation there, we need to look at pre-authorization and what's changed over the years, and we need to make industry justify for why they're pre-authorizing 80 things instead of when they were 30 before. So I absolutely agree. We should be looking at that. I take that as outside of network adequacy, though. It's that's not network adequacy or mental health availability. That's procedure on pre-authorization. And I agree with you on that. We should be looking at that. We should do a study to figure out exactly what's being pre-auth now, what was pre-auth before, and what's the cost benefit. And that's kind of hard because every insurance company does that a little bit differently. So I think there's definitely work that we can do there, sir.
Representative Meskowitz.
Yes, thank you very much, Chair. Doctor, I appreciate your testimony and I understand your concerns. One of the issues I didn't think was addressed, or we didn't delve into, was you briefly touched on, I guess, I don't know if it's malpractice or liability insurance. Do you have anything there? There are aspects to all of our business that hit into our insurance and our insurance premiums. And I'm wondering where we sit, if you're talking about attracting the young medical students to the state, you're talking about compensation levels, and you're ultimately talking about approval of the insurance and the coverage and the reimbursement rates of insurance. And I'm wondering where we stand on liability insurance and the cost in this state, as far as you're aware.
The costs are high in Connecticut because we have some of the highest awards of any state in the country, and that has driven the prices up. We had a task force on this issue quite a few years ago. It made a number of recommendations. Only 1 or 2 of those were adopted and passed into law. We're probably overdue for a fresh look at malpractice reform. It is a significant factor. It's something that's published on the internet where young physicians who are looking to practice here or there can see where states rank, and Connecticut doesn't rank high. So it is a very real factor. We even have a bill this session that would extend the period for the interest rates that apply if a defendant does not settle from where it is currently at the point at which the lawsuit is filed to where the injury occurred, which would put an enormous burden on a practice to settle even when they know they are in the right, because the cost could be so high just from interest rates that are already extraordinarily high relative to what we pay on anything else in Connecticut with regard to interest.
Thank you very much for that. I think the session, unfortunately, is going to be an abbreviated session. But you've highlighted another concern, within the components of doing business in Connecticut and within the components of doing something about healthcare costs. I need to make sure that the settlements are adequate. Obviously, damages are reasonable. But if I'm pricing myself outside of the market in the United States with liability insurance, I'm driving physicians out of the state as well. So I'd love to see your prior recommendations that the group made. And I would recommend to our committee that we undertake that in the next legislative session, that we look at the liability costs of malpractice.
Thank you.
Thank you very much.
Thank you, Representative. Other questions from members of the committee? If not, thank you so much for being with us, Doctor.
Thank you.
I will just say that we've had some pretty wide latitude on the topics of conversation today, but because we're only about halfway through the list of speakers, I just would encourage members to try to limit our conversation to bills before the committee. Next up, we have Richard Pizzillo, followed by Dr. Farquhar. Let's go. We announced Dr. Farquhar first, so we'll do Dr. Farquhar and then go back to Richard Pizzillo. Good to see you, Doctor.
Hi, thank you. Senator Lesser, Representative Wood, Senator Wong, Representative Pavlak-D'Amato, and members of the committee. My name is Dr. Thomas Farquhar. I'm the legislative co-chair of the Radiological Society of Connecticut and a practicing physician in Central Connecticut. And today, on behalf of the society, I wanted to offer brief comments on Senate Bill 358, an act concerning required health insurance coverage for breast health benefits. We commend you for raising this important issue once again. It's always a positive development when legislation is considered with the goal of improving breast cancer screening for the women in the state of Connecticut. And we all know that early detection saves lives. The Radiological Society of Connecticut was fortunate to be involved in the working group on breast health and breast screenings that was created last session and was chaired by Representative Jillian Gilchrist with participation by Representative Kathy Kennedy. So one result of their work was the introduction of Senate Bill 249 that contains a number of clauses, but one that specifically addressed language to increase use of breast tomosynthesis, which is informally known as a 3D mammogram. And that proposal, Senate Bill 249, is pending in the Public Health Committee. So just for some background, the research studies have shown that breast tomosynthesis improves cancer detection rates, but at the same time decreases false positives, and with that, patient anxiety compared to conventional 2D mammography. And for these reasons, breast tomosynthesis has rapidly been adopted across Connecticut and is basically on its way to becoming the new standard of care. So the current statute on dense breast tissue and breast cancer screenings contains an explicit reference that makes breast tomosynthesis a covered benefit as an option for women undergoing mammography. And many stakeholders, including the RSC, specifically worked to gain passage of this. And this change was needed to overcome issues with insurance coverage for breast tomosynthesis. So we're concerned with the language in Senate Bill 358 that it deletes that specific language. And we're concerned that with that might go the guarantee that tomosynthesis would be an option. There's been some discussion that this guarantee may be in other statutes, but I'm not a lawyer or a legislator, and we would just want to make sure that if this bill was enacted, either there was explicit language about this or that it was guaranteed through existing legislation. And we look forward to continuing to work with you on this important piece of legislation, and thank you for considering our concerns.
Thank you, Doctor. And I imagine, and I don't want to speak for LCO, but I imagine that the deletion was inadvertent, but we can sort of huddle offline and find that out. So thank you for your testimony here today, and look forward to working with the association on this legislation to make sure that we get the language right. Are there questions or comments from members of the committee? If not, it's good to see you, Doctor.
Thank you. You as well. Take care, everyone.
Next up, Richard Pizzillo, followed by Margaret Watts.
Great, good afternoon. My name is Rich Pizzillo. I'm the Executive Director of the New England Hemophilia Association. For over 6 days, NEHA has assisted and advocated for patients with all types of bleeding disorders in Connecticut. and throughout the other 5 New England states. First, I just want to thank this committee, and especially the chairs, for their leadership in passing SB 1003. Last session, NEHA joined 21 other patient advocacy groups and submitted a letter in support of this legislation, which, like others across the country, is an effective way to help patients better afford their treatments. I'm testifying today to provide and echo some of the comments already discussed on the proposed legislation before you, SB 357. The language in the bill as it stands now appears to be a boilerplate saving clause that Connecticut uses in a number of circumstances, and it does not appear to truly hit the issue at hand. While we as patient advocates prefer that exception language not be needed at all, we think it's important to address the IRS issue, which has been addressed already, as narrowly as possible, and the general language in this bill does not do that. As previously mentioned, I applaud this committee's work to ensure that every patient has access to their affordable prescription drugs. However, we strongly suggest that the current language in SB 357 be amended to reflect language that is currently being proposed in several states with similar statutes. This will ensure that the accumulator ban statutes across the country prevent any confusion among stakeholders and patient groups. The exact preferred language that the chairman read or that has is also in a group letter that was submitted and is online on behalf of 13 patient advocacy groups to support this modification in its current state. I just want to thank you for this opportunity, and we urge you to consider this model language, as we're happy to work with legislators to ensure that patients have access to the treatments. With that said, I'll turn it back over to you, Chairman.
Yes, thank you, Mr. Pizzillo, and I think we are well on our way, and I appreciate your thoughtful commentary on the language, and I think we've had a pretty good discussion about that already today, so thank you. Are there other comments or questions from members of the committee? If not, thanks so much for being up. Is there somebody jump in? No. If not, thank you so much for being here today. Next up, we have Margaret Watt, followed by Bruce Adams.
Hi, good afternoon, Senator Lesser, Rep. Wood, and distinguished members of the committee. I'm Margaret Watt. I'm a resident of Norwalk, and I've worked as a leader in behavioral health advocacy for over 10 years, and also here as a board member of NAMI, Connecticut. I just want to talk briefly about the potential task force proposed by 5391 to encourage healthcare providers to participate in provider networks. As you've already heard today, there are many, many barriers that get in the way of mental health providers participating in provider networks. There's been a lot of testimony submitted that I've seen online about the many administrative challenges, claim submission, delays in reimbursements, reimbursement rates, audits, clawbacks, and more. It would not be hard to pull together an expert group to summarize those issues and make recommendations. And I know the provider networks have recommendations ready at hand already for you. One thing I want to say is that if you move forward with this task force, it will be critical to hear from the consumers and families that are affected by these issues, such as the many NAMI members who regularly bring these things forward to us. It is definitely clear from both the provider and the consumer side that it is needed, it is necessary to streamline and simplify the systems and the protocols that we have with the clear end of providing access to care. However, at the same time, we have seen task forces get enacted in the past without leading to, without even always meeting, let alone leading to change. So it is a valid question, as others have raised, whether we really need this right now. And so my main purpose today is to draw your attention to a task force that was created by this committee last year, 6588, and to ask you to follow up on that. That was a task force that it was created to make recommendations about making peer support in behavioral health a reimbursable service. Peer support refers to a non-clinical support that is provided by a person with lived experience with mental health or substance misuse who has completed training to be a peer support specialist. In Connecticut, we have 2 types of peer supporters. One is called recovery support specialists, or RSSs. They provide more mental health peer support. The other are recovery coaches who provide more substance use peer support. As HB 6588 passed last year, the task force was supposed to begin in its work in July, and its report was supposed to be due this past January. However, as of last month, appointments were still being made, as I well know, because one of them was a staff member that I supervise. And that only happened after considerable urging from the advocacy community to move on this issue. So we've been asking for quite some time for clarity as to whether all the appointments have now been made, whether a chair or co-chairs of this task force have been appointed, and whether they are the ones to actually get this committee or this task force meeting. One thing you should know is that while this task force is still not in place to look at the reimbursements for peer support, there is a lot of movement in the behavioral
Thank
health
you. Your 3
community.
minutes has expired. Please summarize.
Okay. There are at least 3 different initiatives underway right now in the state around peer support, including in the governor's bill. And so it's really important for the work to be happening. My ask is that you apply some pressure to get this task force moving, because we can't get answers, and that you extend the reporting deadline for its recommendations, since that deadline already went by. Thank you.
Thank you so much, Margaret, for that. And I just want to highlight the important work of Representative Dathan and so many others in terms of getting it up and running. And I'm frustrated, as you are, that appointments were made slower than we would have liked. So I'm going to be working to try to get some answers about where that is, and I appreciate you raising that issue. And it is an important issue that's been of longstanding concern to members of this committee. I see Representative Nuccio has her hand up, and also Representative Dathan. So Representative Nuccio, I think you had yours up first.
Thank you, sir. And thank you, Margaret, for testifying. The task force that we're talking about in this specific bill is a task force that I proposed last session. It did get passed, but we had only got a few people were actually assigned to the task force. So I'm with you. Being new, I'm totally frustrated with the fact that it was passed and the deadline came and went. We couldn't get people on the task force, and still I'm here batting my head against the wall saying, we need to have all of these people at the same table so we can figure out the barriers and we can remove them. So I've talked to NAMI quite a bit with the mental health bill that I've been working on, the speaker's mental health bill. So I'm hoping that maybe you guys can help me keep pressure on people to actually get all of the members of this committee appointed and have meetings on it, because I will be the very first person raising my hand to say, let's have a meeting. This task force is important to me, and I think it's important to the desires and the needs that we have for the mental health community going forward, because the more providers we get in network, we increase accessibility and affordability. So if you would like to reach out to me, I will work with you to go knock on the doors of the people who are supposed to be appointing these people and stand there until they actually appoint someone. So I'm eager to work with you. Let me know what I can do, and please contact me so we can start yelling at people.
Thank you. We will do that. But we have not been able to figure out who knows what at the assembly. So
yeah.
Yes.
Well, I can't say that I'm the best at that, because but listen, I'm loud and I'm Irish, so I can definitely get notice if nothing else.
Thank you, Rep. Nuccio.
Thank you.
Thank you, Representative. And I know one person who has been beating down a lot of doors is Representative Dathan, and she's got her hand up. Representative, it's good to see you.
Thank you, Mr. Chairman, and thank you, Margaret. It's very great that you come up here so much and really advocate for the people that need help, and particularly peer support services. I know we have been working in a work group before even trying to get this peer support task force started. So it's been a little frustrating, to say the least. And I think there's one person still left to make a point we're still waiting on. And apologies that we haven't gotten there. I will say, with a shorter legislative session, it is hard to get some of these final initiatives, but hopefully we can come up with some legislation that we can put through in the longer session next year, because it is so important. And, every time that we waste in not pushing forward this initiative, people's lives are in crisis and we have things at stake. And the peer support services is really, truly an investment in individuals. And it really, in my opinion, is extremely well money spent that prevents crises, not only costly for dollars and taxpayers, but costly for human lives, for families, and other things. So I am supporting this. One thing, and apologies, I'm bouncing between 3 different appropriations meetings, and that I didn't get a chance to look at your testimony. And included in your testimony, did you highlight who you think would be an important part of this task force.
So as you know, Rep. Dathan, we've
not the peer support services one, but the one that we're speaking about today.
Oh, right, other task force. I think if that task force does, I guess I'm questioning, do we need a task force for that? But I think what's important is that there be consumers, end users of services involved in some way. So there are folks from NAMI, there are folks from our NAMI affiliates who would be able to be on that.
Yes.
I think the provider networks have a pretty clear picture of what some of the administrative and reimbursement challenges are, but just to hear from people who just can't get treatment as a result of people not accepting their insurance. It's the middle class that gets left out, right? It's the middle class that is affected by this issue.
Definitely. I know in human services, I ended up putting together a working group because we decided not to go down the route of a task force. Is this something that you would be open to if we can't get this task force over the finish line? Maybe potentially going in a informal work group that would come up with recommendations to put together legislation for the fiscal 23 legislative year. Would that be something that you'd be open to?
Absolutely. I think, informal work groups sounds so good because people know what's needed. And I think anything that avoids what we're seeing with the peer support task force, just bring the experts together from making sure that all the different stakeholders are there. Yes.
That is the most important. And just for the avoidance of doubts, the public knows this, just because it's, we use the term informal working group, that doesn't mean that the meetings aren't public. These are publicly held meetings. With my one that I did for human services on community ombudsman, we did met 5 or 6 times from July to beginning of January, and all of those meetings, I think it was 6 times, and each of those meetings was either broadcast on CTN or on YouTube. And so folks were able to kind of come and go. We made sure that people were able to sign up, and you didn't have to be a formal appointed member to join in and be a part of this. So any member of the public that is interested in such a working group, it is all included in on the CGA website. So I just wanted to highlight that if that's something you'd like to think about. So thank you again for your advocacy, and I look forward to many more years of working together with you, Margaret. You're amazing. Thanks.
Thanks, Lizzie. All right.
Thank you all.
Thank you, Mr. Chairman.
Thank you, Representative. Other questions or comments from members of the committee? If not, thank you so much. Next up, we have Bruce Adams and Kim Daigle.
Hello, Chairman Lesser. I always like
Adams?
seeing you in a different committee. We worked together closely on the banking committee before. Senator Lesser, Representative Wood, Senator Huang, Representative Pavlak D'Amato, and distinguished members of the Insurance and Real Estate Committee. My name is Bruce Adams, and I'm the president and CEO of the Credit Union League of Connecticut. And we represent Connecticut's credit unions, and there are roughly 1 million members here in Connecticut. And we're here today in support of House Bill 5383, an act concerning association health plans. I always start my testimony with a short synopsis of what credit unions do. And really, we offer a unique advantage to the consumer of financial services. And while credit unions offer the typical banking products, such as checking accounts and savings accounts and home mortgages and car loans, we're not-for-profit financial cooperatives. And that means we return profits made, if any, back into our membership and back into our local communities. So dollars that are diverted to operational costs or otherwise do not make it back into the hands of your constituents, of my friends and neighbors, et cetera. So with respect to association health plans, no insurance product was perfect at its inception, and association health plans are no exception. The time has come, however, to refine this product one step further in order to leverage association health plans to their greatest benefit in Connecticut. To maintain the status quo in Connecticut would be akin to like a regressive tax on small businesses and their employees, who would be squeezed further as they continue to bear the burden created by large group health plans who have greater bargaining power and flexibility in plan design and underwriting. So to put it more plainly, small employers such as not-for-profit credit unions who can least afford it should not be forced to subsidize the savings enjoyed by larger employers. Now, the testimony opposing this bill raises real concerns based on real experience. And we share the concerns also voiced by Senator Looney in his testimony. These advocates are concerned chiefly about ensuring coverage for essential health benefits, avoiding discriminatory plan design, ensuring access to quality and affordable healthcare for consumers, financial transparency and stability. But Connecticut's credit unions really respect those concerns. And what we propose is that we work with those stakeholders together to craft acceptable language that will alleviate those concerns. We support mandates to ensure that financial transparency and stability, coverage for essential health benefits, and protections against discrimination. We do ask, however, that this bill amend the definition of association health plans to include self-insured plans housed within an insurance trust. The state of Maine enacted sensible AHP legislation, and the Maine Insurance Trust has executed a successful self-insured model that should alleviate most, if not all, of the concerns addressed by today's opposing testimony.
Thank you. Your time has expired. Please summarize.
And I'm done. I commend you to the testimony of Kim Daigle, who appears before you at our request today. We're happy to answer any of your questions or concerns.
Thank you, Bruce. And, this is a trip down memory lane. I think half of all the people who used to testify in front of the banking committee when I was chair are playing hooky in insurance today. So just I was following along up until that last point regarding self-insured plans and was it health insurance trust that you were mentioning?
Yes.
And so I just wanted to make sure I understood that. Normally we're not able to regulate self-insured plans because we're preempted by ERISA. So what would be our hook to have any sort of tie into self-insured plans?
I can leave that to Kim, who's on the line. I think her camera is not on. But yes, we would support putting language in the bill that would allow Connecticut to maintain. I don't think Connecticut is precluded from regulating in the self-insured space, if I'm not mistaken.
I think we normally are. I don't know if we're, but there may be some sort of reason why ERISA would not preempt us here.
In any event, Senator Lesser, I think if that is in fact the case, that there is a full field preemption that the state cannot regulate in the self-insured space, we would drop that ask of this committee.
Okay, great. Well, thank you very much. And Kim, if you know more, please feel free to pop in. Just make sure you identify yourself with the committee.
Or I'm hoping you can hear me.
Yeah.
You can.
For some reason, I can't get my video to work, so I apologize for that. Good afternoon. I appreciate the opportunity to present to you, Senator Lesser and Representative Wood and the distinguished members of the Insurance and Real Estate Committee. As Bruce mentioned, I started 3 years ago an self-insured association plan in Maine. I run an insurance trust for all the credit unions located in Maine. I've had over 20 years of experience working on association health plans in my career. And one thing I will say is that if association plans are set up correctly, they do help businesses and employers. 3 years ago, when we started our plan, we started with 19 credit unions, protecting 19 credit unions. That's grown to over 30 of the 53 credit unions in the state. We protect 775 credit union employees and approximately 1,100, including their dependents. I know Bruce had mentioned that there's a lot of concerns that association health plans don't comply with state and federal mandates and essential health benefits. That would be a big concern, but we certainly do comply with that. In fact, we actually enhanced our preventative prescription benefit just recently to make sure that our members with chronic conditions can afford their medications. So we're actually able to make enhancements to our plan to help our members. We also offer financial incentive for our members to make sure that they get their preventative care services. I actually had a colonoscopy done 2 years ago when I turned 50, and my plan incented me with $150 to get that colonoscopy done. That was the only good part of the colonoscopy. I will also say that I hear that association health plans actually, people are concerned they'll pull the good risk out of the marketplace. And I'm here to say that when you have an association plan like ours, many of our groups were community rated, and therefore there was no claims experience. So the risk that we brought onto our plan, we didn't know whether it was a good risk or a bad risk. So that whole thought that it pulls good risk out of the marketplace really doesn't happen because you don't know what you're pulling out into your association plan. The other concern I've heard from folks is that these plans will be insolvent and not have the ability to pay claims. And I'll say that on our plan, we actually collected on our self-insured plan 3 months of reserves to put in premium that was required by the Bureau of Insurance in our state. We also secured stop loss coverage to make sure that no one large claim would sink our plan. I'm proud to say that this past year, our plan has run so well that we were able to give our credit unions and their employees a premium holiday, which means they didn't have to pay health insurance for 1 month, and that was approved by the Bureau of Insurance. I would also like to say that we have a great relationship with the Bureau of Insurance. This is not meant to be a heavy lift for the Bureau of Insurance. We have a very efficient relationship with them where we submit our claims reports, our premium collected. They see our bank statements and financial statements. We have an outside firm that comes in to do an audit, which we pay for, the association plan pays for. They submit a report to the Bureau of Insurance, and we also have a risk-based capital ratio report from an actuary every year. So I just wanted to share that experience with you because I'm seeing how this program has benefited our credit unions and employees in Maine. And I'm happy to answer any questions that you folks may have. And thank you for your time today.
Thank you so much, Representative Meskers.
Yeah, thank you so much for the testimony. I'm fascinated by the possibilities and potentiality for the plans. I'm hoping that we can talk with our small business owners and with the insurance commissioner. I understand the concerns about regulated versus self-insured and the concerns that we want to look at through the trust function. And I have an additional concern or question, right? As you go through this type of a plan, which would seem to be a great alternative for group plans, if you will, or creating a larger group plan and pooling risk. How do you view that vis-a-vis the increments in Obamacare or Biden care? Because most of the subsidies that I'm looking at and the things I'm hearing about are dealing with subsidies for individual purchasers versus group plans. So I'm wondering, in the competitive environment we're in, does that is it solving a problem that is being kind of knocked on through direct purchase of insurance policies? And I'd just love your thoughts on that as well.
So let me just make sure that I understand your question. When we're talking about Obamacare and Affordable Care Act and subsidies, that's the individual marketplace. So
exactly.
And the group that we're pulling from is the small groups primarily. So these credit unions had insurance on the marketplace, whether it be with our carriers in the state, Aetna, Anthem, Harvard, Community Health Options. So we're not pulling from that individual marketplace.
Well, I'm not worried about you undermining the marketplace. I'm wondering, as you begin to pitch a group plan for the credit unions,
yes,
there'll be the alternative of either staying individually in their small plans, which are getting more and more expensive, right?
Mm-hmm.
Or getting into a plan you're creating, which would pool the risk and therefore lower premiums. And the alternative then is to subsidize the individual purchase of plans. Follow what I'm saying?
I guess, and Bruce, you might want to tag team here with me. I guess I see what you're saying, but typically we have these small businesses were purchasing benefits for their employees through the small business. So they were much better off to be in the small groups, even though the rates have gone higher, than being out on the individual marketplace, if that makes sense.
I don't know how, I'm not challenging you. It's an intellectual conversation.
Sure.
I think it'll be worth exploring, given the immense subsidies that were increased this past 6 months, right? If that still holds versus the group plans. But I certainly like the idea. I'm not against it at all. And, I want to explore it more in terms of that the coverage is both adequate and comprehensive, but it sounds like a great solution.
Thank you.
Yeah, thank you, Representative. I think that the subsidies conversation is one that we can certainly take up anytime you'd like.
Yeah, I think it's important for you to look at it from your individual basis versus a group plan. And then what do you think the savings are in going into a super group, if you will, of all the credit unions? And how do we form the trust? What are the implications of that trust in terms of self-insured, not fully complying with the regulatory and framework, so that we can figure out that we're doing the right thing for the employees?
Certainly. And as a MIWA, that this would be a multi-employer welfare arrangement, that is still subject to state regulation. And so we can ensure the coverages and access that you're concerned about. But yes, I'm happy to explore the depths with you at a more efficient forum.
Great, perfect. Count on it. I will be hunting you down. Thank you very much.
Thank you.
Thank you,
Chair.
Thank you, Representative Delnicki.
Yeah, thank you, Mr. Chair, and it's good to see you here again, Bruce. I want to say this is like deja vu all over again.
Indeed it is, Representative.
I'll ask the same question I asked the last time. How much money, providing, of course, comparable care, would you save the members in the credit union that are employed by the credit union?
So this time I have an able associate who can give you actual data, and I think that may help get you and the committee a better insight, because Kim runs an insurance trust that actually has experience in this space.
Yeah, so thank you. So this past year, to give you an example, in the state of Maine, our medical trend runs about 8%, our pharmacy trend runs about 10%. For the last 3 years, we've seen an increase on our plan, about 6%. So that's lower than the trends that we're seeing out in the marketplace. I've had one credit union client that actually, before coming into our program, received a 30% increase in their rates because they were a large group and had one large cancer claim. This past year, because of our premium holiday, we actually had a 2% reduction in our rates overall. So again, it depends on each group within the plan. But our premium holiday, to give you an example, for all of our 30 credit unions and the 775 employees, the premium credit that we gave back to the credit unions in the form of not making a premium payment was $650,000 for 1 month. So that's substantial.
So just from a standpoint of how this compares with what municipalities have done, would it be a comparable type of situation?
I know that our plan in Maine, there is a municipality that does have a MIWA. So without knowing, if you could give me a little bit of details about your municipality's plan, I could tell you a little bit, but it's the purpose of it certainly is to achieve savings as a larger group by negotiating. You have better negotiating power the larger group that you have.
And how many credit unions would actually have to come on board to ensure that you could get that large enough economy of scale to make this work?
That's an excellent question. So for the for the self-insured plan, our actuary was very clear that you needed 500 participants. Because that really spreads out the risk adequately. I do have an association that I've worked with in the past in Maine that has about 350 employees enrolled on the plan, and they're doing just fine. But from a comfort level to actually spread out that risk adequately, we say 500 employees. So that could be one large credit union and many small credit unions, but just 500 employees total.
And to scope you, Representative, in Connecticut, there's roughly 2,000 eligible employees. So when you add in sort of the families and dependents factor, you're scratching at 5,000 total people in Connecticut.
So unless I missed my mark here, it sounds like it's a very doable situation at this point, and you've provided significant information as to how it could work. And for the record, I was a board member on a credit union, Metropolitan District Employees Credit Union, for I think something like 15 years, and served as vice president for 4 years. And I can attest to the fact that credit unions do the right things, not just for their depositors or their shareholders, I should say, but also for the employees. And I'm glad you have brought this forward and that you have somebody backing you up with effective and informative data. Thank you,
Representative.
Thank you.
Thank you, Representative Delnicki. Other questions or comments? If not, thank you very much for this conversation about MUAS. Good to see you. And next up, we have, I think, Debbie Osborne, followed by, I believe, Ken Orsaki. But again, we are periodically being joined by people behind in the queue.
So sorry, Senator, am I up?
You are, Debbie.
Okay, great. So good afternoon. I started writing this testimony good morning because we started at 9 a.m. and we have now gotten into the longer part of the day. So, but it's so good to see all of you. I've missed you. And this is my first time getting back to testifying in front of this committee. Those of you who don't know me, my name is Debbie Osborne. I am the executive director for 4 medical specialties. And those are the Connecticut Society of Eye Physicians, Connecticut Dermatology, Connecticut ENT, and Connecticut Urology. I represent about 800 physicians in these specialties of dermatology, otolaryngology, ophthalmology, and urology. And I'm here today to voice concern on SB 354. And it is disturbing for me because I heard Senator Looney, who is supporting this bill, but he's speaking about another part of the bill. I'm going to speak about the provider section of this bill. I want to share with you some of the ironies and the unintended consequences I think this bill will have if it was allowed to pass. I've also included in my testimony a brief history on the medical billing and some relative background surrounding CPT coding for medical services for a richer understanding. It's very complex medical billing. There's a lot of jargon in it. And it was a system that was designed in the 1960s and has had upgrades, but has not taken into effect the mid-level providers that have come to the table and started providing some of these services. So I'd like to talk about the ironies first. The proponents of this bill, which appear to be non-MD providers, are seeking to get equal pay for equal service. Yet the hallmark of their efforts to expand scope of practice year after year has been, we can provide lower cost to healthcare. Now, I have sat through public hearings in public health for over 20 years, and one of their banners has been, we can have more access and we can provide lower cost of care. So how is it possible to provide a lower cost of healthcare if you pay the same reimbursement to mid-level providers that you would pay for a medical doctor? One must ask the question, is that the intention of allied health providers to blur the lines in training and qualifications, gain scope under the veil of providing lower cost, and then seeking parity in pay legislation under the veil of equal pay for equal service? And is this service equal? What we must not forget is that every person in medical care is not equal or the same. The training, education, and clinical residency is vastly different for an MD and versus an APRN or PA.
Thank you. Your 3 minutes has concluded. Can you please summarize?
Wow, that was quick. So I'm so glad I presented written testimony. So I just want to talk about the unintended consequences and how do we incentivize those medical prospects for going into a medical school if they're going to be paid equal for the same service. If they do an exam, they're going to get the same reimbursement as a mid-level. And the other question I have to ask is, how are insurers going to incentivize those specialists and providers into their plans if all they have to offer them is the same fee schedule that every PA or APRN will receive? So I hope you'll take the time to do two things. On March 30th, we have Doctors Appreciation Day. It is a Zoom just like this. We've sent you all invitations, and we hope that you will say hello to these doctors. We have had 2 years of very difficult times. We have the high deductible bill, which thankfully you have raised and is the bane of every physician's practice right now. And it is causing an exodus, and I mean exodus, of physicians leaving the medical delivery system because of the administrative burden that's placed on them. They are not bill collectors, and yet they are forced to spend a huge amount of time trying to figure out how they're going to get paid. So I welcome any questions. I hope you'll read the testimony about the history of CPT billing and coding. And I'd love to have you all join us on March 30th. Thank you.
Thank you, Debbie. It's really great to see you, and appreciate you and your members weighing, your associations weighing in on these bills. I see that Dr. Anwar, Senator Anwar, has his hand up. Senator, good to see you.
Thank you so much, Mr. Chair. Debbie, good to see you, and thank you for your testimony. I love the background. It's pretty cool. I probably should get something like that too. I wanted to ask you a couple of things. I think you alluded to something that's important, because we are seeing I teach medical students and residents as well, and I'm seeing a slow death of medical education. Because the average debt that a medical student has is about $350,000. And the way the situation is, they're unable to pay their debt. And that's part of the challenge, is that it's they will be 60 before they'll be able to pay the debt. And everybody else has a much less debt. So we have a major challenge on that. Can you speak to the slow death of medical schools in our country right now? And then what we can do to save medical education and excellence in medical education?
Thank you, Senator Anwar, for that very important question. You know, I used to say it's a slow death. Now I think it's a fast death. And I'm seeing fewer and fewer younger people going into the MD field versus a PA or an APRN. It's the investment of time, the investment of resources. The cost is enormous. And then we forget about the responsibility that these physicians have. Let's just take as an example of Dr. Emmel, who, you know, bless his heart for getting on and testifying. Here's a physician who, after 30 years of practicing, is having difficulty making his payroll. How can that even possibly be? When you're on a fixed income, because, you know, the contracts that they're handed are not negotiable. The insurers say, guess what? You're going to make X amount of dollars for these procedures, and you have no way to negotiate that. Okay. Then you have all of these escalating costs that everybody is feeling right now, but you have no way of making more money because you can't work any harder. So he is forced to join another large group practice because he can no longer, of which none of his staff are part of that network now, or the facility that he just joined. And they can't attract any new physicians to that practice. So they're buying some of the older doctor practices to kind of huddle up together. but they're not attracting anybody new to filling in those spots. I think every single person on this committee and everybody across the country should be concerned about this, because we want to incentivize these folks to gain that high quality of education, you know, especially in times like these. So how do we do that? You have to pay them more. There's no question about it. You have to incentivize them by saying, you know what, we're going to help you pay your bills. You know, we understand the responsibilities. And on the flip side of that, you got to contain some of the costs for them. You know, and some of those costs are involved in tort reform. But the bigger issues, the issues that are the worst across the board, I mean, I get 10 or 15 calls a day about not being able to reach an insurer, to get prior authorization, to get paid for a procedure that they've received prior authorization, or to get, you know, a reasonable contract. And unfortunately, this all falls on your committee. And I look at each and every one of you and I feel your pain, because you have an enormous job, you know, and you ask really great questions. I was listening to, you know, Representative Comey and Representative Wood asking some really tough questions, especially about, you know, medical practices that bill in ways that are so foreign to all of you. You know, it's not like, you know, a restaurant can raise their prices on food. Physicians can't do that. And so they can't get anybody in to get help. So all my two-man practices and solo practitioners are becoming obsolete. You know, they're retiring saying, Debbie, I don't want to retire. I don't have any choice. And that's very, very sad for me to hear. So thank you, Senator, for asking that question. So it comes down to making it easier for them to practice and to pay them what we feel they deserve to be paid.
Can you also talk, you touched on the high deductible. I know we had a conversation, Representative Wood had done a meeting around that issue as well. Could you speak to that, and what do you think are the solutions to address that?
You know, I've developed a new philosophy. I don't like to point fingers, and I try not to, and it's so incredibly hard. But you have to ask the question, what is the benefit of a high deductible? Have we been able to control costs, or has it prevented people from going to a doctor, getting early detection on things, and preventing larger healthcare bills down the road? And who is it benefiting? You know, there are times when I want to go work for the insurers because, you know, they're very clever. And, you know, I say to myself that here's the doctors chasing all of this money. If you do a procedure, say a tonsillectomy, and your deductible is $4,000, guess who's trying to collect that $3,000 for that operation from that patient? The physicians are. So now all of a sudden I see these receivables that used to be, you know, for a single practice at $50,000. They were maintaining about that because there were small little copays of $10 or $20. Now I'm seeing a solo guy has $200,000 in receivables. And guess what? He doesn't have the money to pay for his payroll. So if we think about insurers and what they're really good at, they're good at administration. So why is it that they don't collect a reasonable deductible from the patient instead of the physician? And let the physician spend their time where they're an expert in taking care of sick patients. It's inexcusable that a physician should spend 20, 30, or 40% of their time meeting with their staff, trying to figure out ways on how to get paid the receivables that they're owed. And, you know, why is it that a physician has to wait 2 hours on the phone to get a prior authorization for a surgery? I mean, is it a delay tactic from the insurers, or are they incompetent? I mean, what is the reason for that? And why can't they get an electronic prior authorization that guarantees that physician he will get paid? Why is, 3 months later, this physician trying to get paid from a prior authorization? So, Senator, to sum up, I would say high deductibles should be the burden of the insurer, not the physicians. And they obviously get the premiums paid. And, and let consumers know that it's their plans that they've designed with these high deductibles, not the physicians. They come in there angry at a physician because now he's asking to be paid. So it creates a very tense situation. And that's not how medicine should be. Patients should come into a physician's office and be treated, and he shouldn't have to be concerned on whether he's going to get paid or not. So they've created the mess. They need to get us out of this mess, and they need to take responsibility for administrating these high deductibles.
Thank you so much for your testimony. Thank you for sharing your experience and perspective of the organizations you represent. Thank you, Mr. Chair. Thank you.
Yeah, thank you.
Thank you, Senator Anwar. Representative Nuccio.
Thank you, Mr. Chair. So thank you for your testimony. I do have a couple of questions, though, because I think there's a fundamental difference here in what people assume insurance does and what it actually does. An insurance contract is a contract with your employer. The insurance company just administers it. So from an insurance perspective, if you're talking about a deductible, if you have a car insurance with a deductible, you get into an accident, you take your car in to get fixed, you have to pay your deductible to the person who's doing the work. That's part of the policy. So I guess I just don't understand why doctors, why the assumption that of all of the insurance policies that we have for all of the different things that we have for insurance, why this is the one area where doctors feel like they should not be responsible for collecting the dollars for the services that they are singularly providing.
That's a great question, Representative Nuccio. And I think you're right, there is misunderstanding, because who designs the plans for the employers?
The majority of them are designed by the employers. Most ASL contracts, there are 80% of the contracts in the United States of America are administrative services contracts, and the employer is the one who decides what their benefit plans will look like, what options are available, and what they want to offer. So
I disagree. I agree and disagree on that, and I'll tell you why. Because it has to start with the insurer. They have to offer, they go to their actuaries and say, what can we offer? What add-ons can we bring to the table? How can we solicit that employer to sign on to a plan? And then they administer it. So their creativity starts the conversation. And they bring that to the employer, and the employer gets a list of, okay, plan A, B, C, or D. And these are the ones I'm going to offer to my employees because they're going to cost X amount of dollars. And look, everybody's trying to save money here, right? The employers are trying to save money. The insurers are trying to make money for their stockholders. But what I'm saying is we are creating a situation out there where doctors are small administrators who can no longer afford these high receivables and these collections, because we're living in a time when, it's just extremely difficult to practice. And if we continue down this road, Representative, we are going to find fewer and fewer doctors willing to do independent practice. And I can tell you about 30% of my physicians now have gone into venture capitalist models. Do we want that? Do we want venture capitalists who, again, have cost containment and profitability in mind versus, medical decision-making and what's best for the patient? So I'm saying to you that it starts with that insurer proposing those benefit plans to an employer to try and sell and entice them. And they're looking at it from a perspective of what can we afford? What can this business afford? But it starts with insurers. So make no mistake about that.
Oh, I don't. Trust me, I understand how it works better than most. So, but I will push back on the fact that an employer creates the plan. There is a base plan, and then they decide going forward what they want to offer. You can't basically link it to based on what they want to pay, because then they're deciding. They're deciding which options they want to have. If they want to have a high deductible, if they want to have a copay plan, it all comes down to their cost, how they want to structure it. So I don't understand how that then becomes the insurance company's responsibility to administer a plan that an employer has decided they want to offer to their employees, and a doctor who is providing a service. An administrative service plan, as you said yourself, the insurance company administers the plan. They have absolutely no financial obligation. They are not collecting the deductible. They are not receiving that money. They get paid directly from the employer to strictly administer, and all claims, 100% of claims are paid by the employer. So the contract is with the employer. The administrative services, who pays the claims, who has the network, who answers the calls, is handled by the insurance company. There's absolutely no financial incentive for, there's no financial liability in an administrative services plan from an insurance company at all.
So I'm going to respectfully disagree again. I don't mean to be controversial here, but the fact is that let's look at the profitability of the insurers, the Anthems of the world, and how they're making money. How are they making money? And if they are not the administrators and they're not collecting the premiums, what is their role? Is it just
they are the administrators? They are an administrator.
Right.
But that is, in an administrative services contract, they do not collect a premium. Ma'am, I can assure you 110% that they do not. They get paid an administrative fee based off of paid claims for administering those claims. They do not collect a premium for an administrative plan. I will put my house on the fact. I've been in the industry for 25 years. I'm extremely aware of how administrative contracts are structured. It is, the insurance company has no financial liability for an administrative plan, not a single one.
So can I ask a question then of you? How do you propose we stop physicians from going out of business because of these high deductibles?
I don't know how you would propose that, because, and this is the case, if they are providing a service, they are responsible for collecting the money for that service, just like a car repair or a homeowner's insurance policy or any other insurance policy that's out there. When you go to the grocery store and you buy groceries, you have to pay the person who you're getting that service from. So I agree with you. It is an administrative nightmare. I'm the very first person at the table to say I absolutely cannot stand high deductible health plans. But I understand how they work and how they function and why people chose them, because they're less money out of their pocket at the time of the paycheck, with the hopes and prayers that they don't have something that happens. But that is a choice, ma'am. That is a choice that they are making, to not pay a higher premium out of their pocket, with reassurance that if something happens, it's covered, or if they want to take the lower out of pocket and assume the responsibility of paying for that other amount. Like I said, I hate high deductible health plans. I think they incent terrible behavior. But I think if you want to have the conversation, you have to put the onus where the onus is. In an insurance company's perspective, there is no financial responsibility to cover this. And from the doctor's perspective, it's an administrative nightmare, but they are the ones who are providing the service. So how we find a way to work around that, I think there's a possibility to do it. But I think the words that we're throwing around, like trying to make an insurance company collect money for something that they're not paying claims on, they have no financial responsibility for, is not the answer. So you want to have a conversation offline, I would absolutely have that conversation. I'm interested in finding ways to do that. But I've talked to Senator Anwar about this too. It's, if you look at every other single type of insurance policy that's out there, every single one, any deductible is payable by the person who has the policy, not the insurance company. So I don't think we should create a new process to try to shift. And actually, I don't even think I don't even think legally you can, because an ASO plan is an ERISA plan. And ERISA is better, it is legislated and ruled by the federal government and not the state. But I'm interested in any other way we can look to do this. We're looking at pre-authorizations and everything else, but it is misinformation to say that the insurance companies are making money off of people not paying their deductible or anything of that sort. So I just wanted to clarify that.
So
thank you.
Thank you. I'm going to respectfully disagree again, but we can have these conversations, and I welcome it because I think that any discourse is informative and it adds to the conversation. And you need all parties. You need the insurers to come in. But I can tell you this: that's not working, and we are forcing the hand of providers. And if we have enough of them exit the state and retire early, we are going to have a very difficult situation in Connecticut. And all I can speak for is the climate out there. And, we have got to incentivize physicians to stay in the delivery system, to provide this care, and to ease their suffering right now. So if you can come up with creative solutions on how to do that. But I will tell you that before these high deductibles were in place, when they were collecting small nominal amounts like $10 copays, the system was working. It's now not working, and it's broken. And things like even the add-on benefits, like for a hearing aid, not being applied to your deductible, that makes no sense. And you'll hear more about that from some of the other doctors that will be testifying. But make no mistake, there is a crisis out there, and it is brewing, and we're going to be in serious trouble if we don't fix it and fix it soon. So thank you.
The last thing that I'll say on that is you're right, the copay payment did work, but then the cost of care was so exasperated and it kept climbing so high because, once again, we're talking about the cost of insurance without recognizing the cost of care. So yeah, you could go back to a $10 copay, but you're going to be paying $700, $800 to cover the cost of care. So it's that balance. Do you want to pay a copay and pay higher premium, or do you want to pay lower premium and assume the risk on yourself? So that's the difference between the two. And you can't have one without the other. So I'm
hoping we can do something. So we've got to put our minds together and create something that works.
I'm all for that table. Thank you very much. I don't know if you're back in charge now, Madam Chair or whoever. Thank you.
I think I'm in charge, but
I don't know who's in charge. You disappeared. She was on. I didn't know.
I would gladly cede control of this hearing to anybody. Representative, not comment on anybody's questions. Representative Meskers.
I trust you're not ceding control, but just recognizing you, Mr. Chair. I was going to ask the question in a poorly framed way, and I don't want to do that. So I can't think of anything I've done for the last year or 2 years that's more important than wrestle with healthcare costs. And Joe, I want to be sincere about my observation is we're facing a healthcare problem based on your analysis. And you're telling me the solution is more money. I mean, that's what I'm hearing. Well, I heard more compensation to the individual healthcare providers, the private practices, or that they're suffering with the current structure, and we need to figure a way to solve that. Here is my overarching concern. On the plans that I regulate in the state, I moved insulin into the insurance market with a $40 payment. I will go to my grave celebrating that, but I didn't get the $40 out of the producer. I got the $40 out of the rest of the insured market. So I socialized the cost of insulin, which raised the premiums. Everything I do to socialize another cost without attacking the cost structure ends up in the premiums. So I'm concerned about that. I'm concerned about how I can get a hold of the pharmaceutical costs, how I can get a hold of hospital care costs, and how I can make it easier for the doctors who, based on your testimony, are the ones who are squeezed in the center of this process. But easing the difficulties of any of the players in the medical stream by increasing the payouts is going to hit me in the premiums, and I'm going to collapse the healthcare market again. And that's my concern. So I'm willing to have a conversation, dialogue, or anxious to, but I need to figure out where cost containments are. Today in the conversations we've had, the only thing I've heard is the potential of cost containment on liability insurance for malpractice, which is not under our purview, and the chair has reminded me of that. So, or we're not conversing on that now. So I need solutions that don't ultimately raise prices because I'm squeezing a balloon, and I've got to figure out where it's going to show up. And so far, I mean, I've just heard that the self-insured, the municipal plans are up 8% this year, and we had a funnel in $40 million from the state, from the OPM. So the costs are rising exponentially across the system. And what I'm hearing from you is that some of the people aren't being adequately compensated. I won't argue, I won't dispute whether they're being adequately compensated. I hear the pain, I hear the testimony. The question is, where do I get that from? And
So-
ultimately, I'm getting it from the ratepayers.
So Representative Meskowitz, you have asked great questions, and I, have a lot of sleepless nights thinking about these same things, because on my end, I hear, I get call after call from physicians saying that, they're not able to keep their doors open. And when I say, paying them more, I'm saying that you have to pay for the specialization and the training, but not everybody is at that level of training. So, mid-levels and folks that are in the allied health professions, to elevate them to the same level of parity in pay doesn't make sense. It takes away incentives from the insurers to pay to get those folks to stay in the plans. And it also increases healthcare costs across the board, because the insurers are going to say, wait a minute, if I'm paying everybody the same, I use this as a tool to attract, those specialists into these plans. So they're
okay, hold on. So you and I are on the same page then. I have no issue on the parity issue. Parity issue for me is raising the base rates to an unaffordable level. So I understand that.
Right.
So I'll withdraw the other questions. I literally am trying to figure out how to rationalize the system and make it affordable.
And I think that there's a lot of pieces in healthcare, like the drug costs and stuff, that you guys you're trying to be creative. I think we have to find creative solutions, but I think we have to bring all the players to the table with equal voices. Physicians have long been dismissed in conversations with the insurers, saying, oh, we can't afford this, we can't afford that. But it's driving us to a single payer system, and it's driving us to concierge medicine. And I don't know if anyone sitting on this committee would support that or think that's the best for public health. Maybe it is, but we have to have some serious discussions on how we're going to keep, quality and contain costs. So, it's always been a Republican versus Democratic issue versus tort reform versus going after the insurers, but everybody's going to have to give up something. And we have to, we started a long time ago with the medical loss ratios. And then, once we gain a little bit of ground against the insurers, like in the Affordable Health Care Act, then we have the trial bar. Now we have a bill in judiciary that they want to raise the interest on prejudgment, which will be compounded to like 50%. Who makes 50% on their money? I mean, and so what does that do? It elevates the cost of medical liability insurance. So we have, our OBGYNs with these, astronomical medical practice liability premiums. So you can't just pick on one part of this industry, healthcare, and not do something with the other. Everybody's got to give and take here. And we have to do it for better care for all. So thank you for that question. And I am always here to come to the table. You know, many of you know me. I've been around for 25 years. I've been doing this far too long, and I'm certainly very passionate about healthcare. I'm passionate about the, you know, the breast care and all of these things and the infertility. So, you know, I respect all of you tremendously. I've got great relationships. The new folks on here, I welcome the chance to have these dialogues with you.
Thank you so much, Representative Meskers, and thank you, Debbie. I know that you're serious about that, and you've worked with many of us for a long time. So it's a good back and forth. Are there other questions from members of the committee? If not, thank you very much for your testimony.
Don't forget, March 30th, please be on to say thank you to the doctors who got us through this pandemic, and hopefully it's the end of it. I just want to add that we procured 40,000 masks to keep them up and running. And we also helped the state to get masks. So God bless you all. Thank you all, and keep doing the tremendous work you do.
Thank you so much. Next up, we have Sue Lagarde, who we've not heard from in hours, followed by Ken Wysocki. Good to see you, Sue.
Hi, Senator Lesser. So Senator Lesser, Representative Wood, members of the Insurance and Real Estate Committee. My name is Dr. Suzanne Lagarde. I'm the CEO at Fairhaven Community Healthcare, a safety net provider, and I speak today in support of SB 355, an act establishing the 340B Drug Pricing Non-Discrimination Act. So a little history here. Congress established the 340B program in 1992, creating statutory regulations which allowed safety net providers, such as community health centers, to purchase medications at affordable prices and hence to pass those prices on to their low-income, uninsured, and underinsured patients. As noted in the 1992 House report, which accompanied passage of this statute, the program was intended to, quote, enabled covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services, end quote. In other words, the intent of this program was not only to provide low-income patients with pharmaceuticals at affordable prices, the intent was also to allow safety net providers the ability to acquire funds which would be used to, quote, stretch scarce federal resources as far as possible. In recent years, the 340B program has been under attack by large pharmaceutical companies. No fewer than 14 major pharmaceutical companies have placed restrictions on how the 340B program can be administered, impacting health center patients by lowering 340B reimbursement. Without the language in SB 355, PBMs or third-party payers have the ability to practice so-called discriminatory contracting, essentially forcing 340B providers, like health centers, to be reimbursed at a lower rate than non-340B providers. The impact of such action is a transfer of profits from the safety net providers to the for-profit PBMs and third-party payers. At my health center, we use revenues from 340B for a variety of much needed services. Funds from 340B are used to help pay for dental services for our uninsured and our underinsured patients. We use some of these revenues to underwrite housing and utility support for our low-income patients living with HIV/AIDS. We use some of the funds to supplement our WIC program, a food program for low-income women, infant, and children. And the list goes on. Without legislation such as SB 355, we will see continued diversion of funds from covered entities such as community health centers to the giant for-profit PBMs and third-party payers. Without question, some of the programs that I just listed will have to be cut back or reduced in scope due to this loss in revenue.
Thank you. Your 3 minutes has expired.
In summary, I applaud the committee for raising this bill. Please let the 340B program continue to function as was originally intended, namely to serve our most vulnerable patients. Thank you for your time.
Thank you, Dr. Lagarde. It's good to see you. And I appreciate your advocacy on this issue and on many others. When we're looking at the industry, and as I understand it, they made the business decision to just flout federal law in this area. I know that your testimony focuses on the financial impact on health centers. I am certainly interested in that, but I'm perhaps more interested in the financial impact on your patients. And I was wondering if you had any firsthand comments that, I know that, patients who need access to insulin, for example, are now paying more.
Yes.
And can you maybe just speak to that and how this has impacted them?
So again, the impact is dual, right? It's on the patients who can't get the drugs at an affordable price, but it's also in our inability to provide them with other services such as dental for the uninsured, et cetera, et cetera. So it really is a two-faceted impact on patients. So yeah, I mean, I can tell you personally, very early on when Lilly, which is one of the leaders in this effort, cut back on our ability to buy Lilly products, and many of the brand insulin products are made by Lilly. We had patients who literally, were calling us in panic because the prescriptions, which had been costing them $16 a month, were now several $100s a month because Lilly would not let us sell to them except at one pharmacy out of literally 30 or so that we work with. Patients had to be switched. I mean, providers were scrambling to find patients who had been stable for years on a dose of a particular formulation of insulin were now being switched to a different, similar, but not identical formulation, and had to be their doses had to be readjusted. They had to be, so there's no question that the impact on patients in terms of the drugs availability to them is significant. But I do want to stress to the committee that the impact comes at them in two different ways. When HRSA mandates that we let them know how we use these resources that we get from 340B to benefit our patients. So any health center can provide you with a list of the services that these funds pay for. And as these funds shrink, those services have to get paid for in some other way, or they have to go away. So it impacts patients, but it impacts them not just in the cost of their drugs, but in the global sense in terms of all of the programs that we're able to provide them.
Thank you. And I know that a lot of the discussion when you speak to the pharmaceutical industry is focused on alleged abuses by safety net hospitals, but we're hearing today from FQHCs, and it may be that you're caught up in the crossfire between these two industries, but it seems like the impact on you all is pretty severe, and you're the front line.
We are caught up. I mean, there's no question that hospitals are bearing the brunt of it, even more than we are. But make no mistake, we are impacted by it as well. And I think this legislation is a great step for the state of Connecticut to adopt.
Great, thank you very much. Other questions or comments from members of the committee? If not, thank you so much for being here.
Thank you. Have a good day.
You too. Next up, we have Kenneth Orsaki, followed by Dr. Jeffrey Kahn.
Yes, good afternoon, Senator Lesser, Representative Wood, Senator Wong, Representative Pavlak D'Amato, and members of the Insurance and Real Estate Committee. My name is Ken Orsaki. I'm a licensed public adjuster practicing here in Connecticut. I also serve as legislative chair for the Connecticut Association of Public Insurance Adjusters and representing them today in support of House Bill 5387, an act concerning continuing education requirements for public adjusters. We very much appreciate that you have raised this legislation for a public hearing. It is straightforward and designed to have regulations promulgated that establish the contours of continuing education program for licensed members of our profession. The property and casualty sector of the insurance industry is complex and constantly changing. Continuing education should be required for public adjusters to stay current with the latest developments and policy changes, contract and legal developments, technology, and importantly, ethics. We believe continuing education will ultimately benefit Connecticut consumers. New York and Massachusetts requires 15 hours of continuing education for public adjusters every 2-year license term. In Massachusetts, the requirement is self-monitored with no fiscal burden to the Department of Insurance. Every year, CAPIA meets with the Department of Insurance in Hartford. We hear from them the major complaint they receive from consumers on public adjusters is they sign an insured, but they do not follow through on a claim in a timely manner. We believe ethics training, along with continuing education requirement, will improve their performance on this and other issues. We would appreciate your support for House Bill 5387. Thank you, and if you have any questions, I'll be glad to answer them.
Thank you so much. It's good to hear about a new bill that we haven't talked about before. Representative Wood, I see, has some questions.
Yeah, exactly. Thank you, Mr. Chairman. And Kenneth, thank you for being here. We did pass this in the House last year, and it is coming up again. Is there's no continuing ed training for public adjusters in the state, correct?
That is correct.
And the way the bill's written there, would there be any cost to the state?
No, there would not. We would propose that it be done. Well, the bill is written that they're requiring the Department of Insurance to have continuing education. I think the details we would suggest to be like Massachusetts, where there is no burden to the Department of Insurance.
Great. I appreciate your answers. Thank you.
You're welcome.
Thank you, Representative. Other questions or comments from members of the committee? Terrific. Thank you very much.
Thank you.
Dr. Khan, followed by Lance Lozano. Dr. Khan, are you there?
Okay, I think I'm live now.
Now you are.
Okay, that's much better. Okay, we'll start all over again. All right, Representative Wood, Senator Lesser, and members of the committee. My name is Dr. Jeffrey Kahn. I'm a past president of the Connecticut Podiatric Medical Association, and I'm here to speak on Senate Bill 363. I've been a practicing podiatrist in Connecticut for over 42 years and have seen many changes in healthcare. The one constant that has not changed over the year is that there's a fee differential between podiatrists and other specialists doing the same procedures. There's been discussion by some people that this is a falsehood, insinuating that there's no proof of this allegation. But in actuality, Duke University recently did a study which confirmed that there is free discrimination. Although I can't discuss actual fees, I know from personal experience that I'm aware of that one insured pays a podiatrist approximately 26% less for office visits and as much as 61% less for a standard bunionectomy. We perform the same procedures. And in fact, podiatrists perform the majority of foot care in the state and in the USA. All we're asking for is equal pay for equal work. And we'd like you to help us with all end free discrimination against podiatrists. So we're asking for the support on Senate Bill 363 as it stands. And I'd be happy to answer any questions.
Yes, thank you, Dr. Khan. Dr. Khan, were you here earlier for some of the testimony that we received against this, or specifically from the orthopedists? They were one, they were worried that this would lead to a slippery slope where we would, come in and say that this would apply to, all sorts of other types of procedures, and two, they outlined a couple other concerns. I don't know if you heard the.
I wasn't here for that presentation, but I've heard it before, so I'm familiar with the line of thought. I can tell you that a number of years ago, Anthem did sit down with our group and made an accommodation, and what they actually did was simply modify your fee schedule by a couple of cents by procedure, and change the rates so that podiatrists were paid the same as other specialists, and there was never any other further repercussions with it. So I think it's just I think it's more of a talking point than an actuality.
Got it. Okay, thank you. Other questions or comments from members of the committee? If not, thank you very much for being here.
Thank you very much for your time, everybody. Have a good day.
Take care.
Bye.
Next up, Lance Lozano. And after Lance, I believe we will be hearing from Martin Pressman.
Well, good afternoon, Senator Lesser and Representative Wood and members of the Insurance and Real Estate Committee. Your constituents will be very proud of you today. You've been at this for over 6 hours now. And I think you all deserve a small raise. I've been listening since 9 o'clock this morning. And I'm happy to finally get an opportunity to speak. So thank you for your time. I'm here to provide testimony in support of House Bill 5385. My name again is Lance Lozano. I represent the Guaranteed Asset Protection Alliance, as well as the Motor Vehicle Protection Products Association. GAPA, which we're commonly called, is comprised of companies that offer guaranteed asset protection waivers across the country. The Motor Vehicle Protection Products Association, or BIPA, is a national trade association with member companies that include providers, retailers, administrators, and ensure that vehicle extended warranty and protection programs. GAPA's mission is to preserve the viability of this industry and promote fair and equitable legislation and regulation of its members and their products so that its members may continue to offer meaningful options to consumers who choose to purchase these optional protections. And to that end, GAPA has developed a Model Act, which is encompassed partially in House Bill 5385. The Model Act has been the basis for laws in over 24 states, including Alabama, Texas, Tennessee, Georgia, Washington, Michigan, and Nebraska. Additionally, GAPA has recently updated its Model Act to incorporate other types of motor vehicle financial protection products. Motor vehicle financial protection products are optional agreements that protect the consumer's financial interest in the current or future motor vehicle. They include debt waivers, such as gap waivers or excess wear and use waivers, and also include vehicle value protection agreements like trade-in agreements, diminished value agreements, and appreciation benefit agreements. Connecticut House Bill 5385 places financial requirements on companies that offer these motor vehicle financial protection products and requires certain written disclosures to be provided to consumers purchasing these products. The bill also contains enforcement provisions and potential fines for violations by the appropriate state agency. Passage of these improvements to current law will clarify that motor vehicle financial protection products are not insurance and will put in place an appropriate consumer protection, including a 30-day look period, a requirement that the products be optional for the borrower, and that the terms of the financing and the terms of the purchase are not conditioned upon the purchase of the product, cancellation and refund provisions, definition of key terms, and various other disclosure requirements, as well as financial solvency provisions for the companies that offer these products. We support Connecticut House Bill 5385 that creates a uniform set of laws applicable to this product that contains important consumer protections. Similar laws have passed, as I mentioned before, in 24 other states. The Motor Vehicle Protection Products Association's primary goal is to establish a uniform and balanced regulatory landscape that minimizes confusion or dispute about the regulatory status of these products. BIPA's member companies offer over 80% of the protected products available in the marketplace today, including Ally Insurance, Trust Financial Service, Insurance Solutions, Toyota Motor Insurance.
Thank you. Your 3 minutes are up.
All right. I guess I'll just close out in respect of the folks behind me. I know I waited a long time and they're going to wait even longer. So we appreciate your support today, your time today, especially, and hope that you can support the passage of House Bill 5385. Thank you very much, Mr. Chairman. And, Madam Co-Chairman, appreciate your time.
Thank you, Mr. Lozano. Representative Wood.
Thank you, Mr. Chairman. Lance, can you just explain to the committee what the difference between these extended warranty products and insurance products are?
Sure. Specifically, gap waiver is a gap waiver product. It's not an insurance product. You can purchase it for a traditional insurance policy that might provide gap benefits, but these products do not provide a cash payout to a consumer. They simply waive an existing debt. So that's the difference between the two products. One is a debt waiver, and one is an actual cash payout to a consumer in the form of an insurance product.
And where this is passed in other states, was it passed under the jurisdiction of those states' insurance departments?
In most states, the insurance department is the regulator of choice. There are some states that the Attorney General is the regulator in those states, and there's a couple that a banking and finance agency is the regulator. But for the most part, the Department of Insurance is the regulator. Under this particular bill, I think the Commissioner of Consumer Protection is where this will end up being. although the insurance department does have ultimate say over service contracts in the state of Connecticut. So both agencies will have a part in the regulation.
Yeah, I think that probably has been one of the reasonings for, this not passing in the past. It's just what type of product it is and where jurisdiction falls. I do want to say that I like the idea of the consumer protection benefits of this legislation, but I understand the confusion, with it. And I look forward to the discussion on it. Thank you.
Thank you, Representative Wood, and thank you for your time earlier this year when we talked about this issue.
Thank you, Representative Wood, and thank you, Mr. Lozano, and appreciate you reaching out to this. All right. Next up, we have, I believe, actually, do we have? We don't have Mr. Pressman yet, so I guess it's Mr. Thomas Burr.
Yes, good afternoon.
Hold on, Mr. Burr, if you hold on for 1 second. Is the clerk trying to? I see that Mr. Pressman is next listed, but he's still not in the panel.
Yes, I've tried promoting him, but he needs to select approve on his end. That hasn't happened.
Well, Mr. Pressman, if you're listening, please do that. While we're waiting for him to do that, Thomas Burr, it's good to see you again.
Yes, thank you. And good afternoon, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Thomas Burr, and I'm the Community and Affiliate Relations Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. And I am testifying today regarding HB 5391, an act concerning mental health. The stated purpose of HB 5391 is to establish a task force to study methods available to the state and health carriers doing business in the state, and to encourage healthcare providers providing mental health service to participate in provider networks. We all too often hear from our members that when faced with a mental health issue, they often turn to a healthcare insurance company's list of providers, and after hours of fruitless phone calls, end up no closer to obtaining an appointment than when before they started. Many calls go unanswered or unreturned, and when someone is actually able to connect to a provider, are told things like, the individual provider is retired, not in the provider's network anymore, not taking new patients, or only have appointments that are months and months out. This response is hugely frustrating and depressing and calls into complete question the actual value of the insurance product and the commitment of the healthcare industry to adhere to the mental health parity laws currently in place at both the state and federal level. We believe that our own Connecticut Office of the Healthcare Advocate could provide you with the hard data about how long-standing and pervasive this problem is. And I was a little disappointed that Ted Doolittle didn't touch upon that in his testimony this morning. We recently launched a survey that asks our members, quote, in your search for a mental health practitioner, have you had difficulty with the accuracy of the providers listed on your private health insurance providers list? Now, I didn't include this in my written testimony as the results are still preliminary and we're still gathering responses. However, the responses to date are just jaw-dropping. For the people who selected no longer accepting patients, 79%. No longer accepting your specific health insurance plan, 61%. No longer accepting private insurance from any company, 44%. No longer in business, coming in behind at 23%. So again, these people are calling the providers that were listed on their health insurance company's provider list. In what world is this even remotely acceptable? And this isn't a new problem. I have literally been hearing this from our members for years. I had this same problem literally over 20 years ago when my son was sick and we were trying to get him help. We would much rather see a bill that penalizes any healthcare insurance provider for having an inadequate network, as this isn't a new problem. In our humble opinion, doesn't need to be studied. It simply needs to be fixed. And the fix is simply having the industry be willing to pay providers at a level that would incent them to be a part of these networks. As you heard earlier from Margaret Watt, our NAMI Connecticut Board Public Policy Chair, last session there was a bill passed, HB 6588, that was to create a peer
Thank you. Your
reimbursement
3 minutes
task force.
has passed. Can you please summarize?
Yes, I will. So, again, when we hear task forces, I cringe because it seems like they often don't even meet, let alone do anything. I think the mental crisis we're seeing here in Connecticut, it's here now. And honestly, the time to study the problem is over. We need to take firm, decisive action now. So thank you for your time and attention. I'd be happy to answer any questions the committee may have. And from one fellow Irish person to another, a happy early St. Paddy's Day to you, Representative Nuccio.
Thank you, Mr. Burr. Are there comments or questions from members of the committee? Yes, Representative Nuccio.
Thank you, Mr. Chair. Thank you, Mr. Burr. Happy St. Patrick's Day to you too, or St. Patrick's Month, as I like to say.
There you go. I'm already wearing a shirt that has green in it. So
see, I am too. You know, and I don't know about you, when they say everybody's Irish at St. Patrick's Day, I'm a little like, wait, but you're not. I am. So, you know, I get it. You can be part of our party though. We invite everybody to the party. So you brought up a really good point there, and something that I've started to kind of push back and try to talk to industry about is the lists, right? So same thing. My daughter was looking for a therapist to go to, got a list of 80 people, 3 of which were even taking providers anymore, and 2 of them would only do telehealth, would not meet in person at all, which eliminated it for her because she has absolutely positively no interest in doing telehealth for what she wants. So that's something I think that we absolutely agree on, that we need to try to find a way to look at, whether, I don't know how we do that legislatively, because a provider can still be in network but not taking new patients, and that's the same with a PCP also. So it's definitely something that I've heard quite a few times now that I'm interested in trying to find a way to work around. And I've been talking to a lot of people at NAMI for the last month or so. So absolutely, I'd love to sit down and talk about it. And it is something I think that we can hopefully get at with the task force, or if it gets turned into a working group, whichever one that it is, because I think these are the things that we need to bring to the table to say, here's the problem, how do we fix it? So thank you again for your shout out there. And I look forward to talking to you and working with you when we get the task force or work group up. I would definitely like to have NAMI at the table.
well, yeah, and I appreciate that. And certainly if that's the way this breaks, we would be happy to participate and lend our perspective to any task force or work group. So thank you for that.
Well, I just think that we'll have a better, stronger alliance if we can get everybody to the table and recognize the issues that are there and find a way to kind of do it, to try to find a way to have that communication back and forth to fix the issue. So I look forward to working with you.
All right, thank you. Appreciate that.
Thank you, Representative. Any other questions for Mr. Burr? If not, it's good to see you and look forward to working with NAMI going forward.
Appreciate that. Thank you.
Next up, we have Dr. Jonathan Stein, followed by Dr. Mahesh Baya.
So I want to thank the Insurance and Real Estate Committee for this opportunity to provide testimony in strong support of House Bill number 5383. My name is Jonathan Stein. I'm a pediatrician in private practice in Guilford, Connecticut, and a medical director at Community Medical Group. Community Medical Group is an independent practice association of which my practice is a member. Since 1954, Guilford Pediatrics has been an independent practice providing care for children on the shoreline. As an independent practice, we continue to offer the kind of care that most parents want: unfettered access to their doctors, on-site after-hours care, a human being they know well to speak with when there's an issue. We do not share call with other practices. We do not use nursing call lines run from outside the state. We encourage our families to call us day or night rather than heading to urgent care centers or emergency departments. By doing this, we keep the cost of healthcare down. Although this kind of practice is labor intensive, the value, both to patients and to the community, is indisputable. We love our work, yet it's increasingly difficult to manage in the present business climate. Every year, our overhead increases at an alarming rate, while generated revenues are fixed or falling. The most significant contributor to our overhead is health insurance for ourselves and our employees. For years, we have investigated alternatives only to find that there was no escaping this truth. We are stuck with high cost, low quality insurance for our employees. Moreover, these plans tend to absorb many additional hours due to their complexities of administration. Many practices like mine have decided to sacrifice independence, joining large healthcare delivery organizations for this reason alone. Every independent practice loss is another domino inching us ever closer towards monolithic mega care that is neither community nor patient-centered and results in increased healthcare cost. House Bill number 5383 offers a window of opportunity to support practices like ours. Independent practices that maintain a meaningful relationship with groups like CMG would be able to obtain higher quality health insurance at much more competitive rates. I urge you to support House Bill number 5383 and help small independent practices become sustainable. Thank you.
Thank you, Dr. Stein. I don't have any questions for you. I just think it is, one of those absurd contradictions of our country that we have not found a way for medical practices to provide medical insurance to people who work in medical practices. I think it's a bit of a national embarrassment, something that just about every developed country in the world has figured out long ago. So appreciate your testimony and look forward to working with you on that proposal and others before the committee. Any other questions for members of the committee? And if not, thank you very much.
Very welcome. Thank you.
Next up, we have Dr. Mahesh Bhaya, followed by Dr. Richard Gill.
Hello, good afternoon, co-chairs Lesser and Wood, vice chairs Anwar and Comey, and members of the Insurance and Real Estate Committee. I'm Mahesh Bhaya, practicing otolaryngologist, right now seeing patients in Southbury. My main office is in Waterbury. I'm a board member of the Connecticut ENT Society, and I'm representing physicians and physicians in training, Connecticut Eye Physicians, ENT, Urology, and Dermatology Societies. And I'm here to support the State Bill number 357. I'm a small business employer and a provider and a patient. Every year we review our options with my insurance broker, and all that I see is increased premiums and increased deductibles. As a physician, we are constantly chasing patients for payments towards the high deductible. As a patient, I understand the challenges that we all face. I get shell-shocked when I see, bills from friends who are physicians. And, I know the deductibles have to be paid. I'm pretty forthright and forthcoming in doing that because I understand the plight of my fellow physicians. Waterbury, as you all know, is a distressed inner city with a predominantly blue-collar workforce. Patients are not able to meet their deductibles because they haven't accounted for these high copays and the high deductibles in their monthly expenses. As a result, it is not uncommon for them to defer elective and essential procedures and suffer the consequences of the chronicity of their medical condition. This is tragic, unnecessary, and is actually a burden on the healthcare system. Insurance carriers also add on benefits to entice patients. For example, patients are given hearing aid benefits, and this is a fixed add-on. We know that hearing aids will actually slow down your cognition. They lead to faster cognitive decline. And when the hearing aids are deemed medically necessary by the provider, they still cannot be applied to the deductibles. So the patients are really in a catch-22 situation. And we all know from studies that patient satisfaction is really related to cost containment and improved health outcomes. High deductible policies seem to make both goals difficult to obtain. The new environment where the burden of high deductibles falls on small business owners, small practices like ours, is untenable and at a critical juncture. Due to my practice's geographical location, my reimbursement fee schedule is lower than a county like Fairfield County. We not only see a lot of patients who cannot afford to pay a $10 or $20 copay, let alone a deductible that is as high as $2,000 to $5,000. We cannot negotiate changes in spite of inflation.
Thank you. Your 3 minutes has ended.
And I just want to summarize. Our ask is simple. I understand there is no easy solution. One solution is for insurers to reimburse independent providers and to collect deductibles directly from patients. The other might be to limit deductibles and turn back the clock if we could. Thank you once again for your attention.
Thank you so much, Dr. Bhaya, for your testimony. Are there any comments or questions from members of the committee?
It's not happening.
If not, thank you so much.
Yeah.
Thank you much.
Next up, we have Dr. Richard Ely. And apologies for everyone if I butcher your name.
Okay. Is this working?
Yes, it is.
Okay. All right. At any rate, I'm Dr. Richard Ely, and I would like to thank the chair and the the members of the Insurance and Real Estate Committee for this opportunity to speak with you today. I've practiced podiatric medicine for over 37 years in Bristol, and I've served many, many patients. I'm here today to ask that you support Senate Bill number 363, which is an act concerning health insurance reimbursement parity for podiatrists. The premise of the bill is that a podiatrist who provides the same covered benefits within their scope of practice as another licensed healthcare provider should be reimbursed at the same rate. Our specialty should be fairly reimbursed for the work that we do. As licensed and credentialed podiatric physicians and surgeons in the state, it is unfair trade practice not to be paid the same as the physicians, our physician colleagues who are performing the same procedures in the same office or hospital setting. I've seen a number of podiatrists leave Connecticut because of the unfair way that we're treated by the insurance reimbursements. Earlier testimony from Dr. Emmel and also Debbie Osborne kind of reinforced that. If the MDs are having problems keeping their own offices open at fair equity, fair parity, how do you expect us to do that with substantial cuts in reimbursement fees? It's very difficult to expect a person just coming out of training to go into specialty where they're paid substantially less than physicians performing the same services in the same environment. Connecticut simply can't compete on that level. It's sad because we're producing very highly trained podiatric physicians and surgeons who take their talents elsewhere. So again, to close, I appreciate the opportunity to present our point of view, and I appreciate the different competing interests that you need to balance in making healthcare policy. However, this change is long overdue, and we urge you to support Senate Bill 363. Thank you very much for this opportunity.
Thank you, Doctor. I appreciate your testimony here. Are there questions or comments from members of the committee?
May I add one other thing?
Absolutely, sure.
Have some numbers. Dr. Aronow kind of implied that this is nonsense. But when we're getting paid by the insurance companies to do a bunion procedure at less than 50% of what the orthopedic surgeons are being paid for, that to me is just totally improper. Office visit rates are 25 to 40% below the physicians, the orthopedic surgeons, or whoever is performing these procedures. But it stands to reason that a fair and equitable reimbursement rate, which is across the board, is the appropriate thing. Again,
Thank you very much, Doctor. And last chance, any questions or comments from members of the committee? If not, thank you so much for being with us today and making time for us in your schedule.
Thank you for the opportunity.
Next up, we have Kathy Flaherty.
Good afternoon, Senator Lesser and members of the Insurance and Real Estate Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project. We provide legal services to clients who receive mental health services from the Department of Mental Health and Addiction Services. And I'm here with just some comments regarding HB 5391. You've heard the testimony from Margaret and Tom. I like hearing very much that the idea is that this is going to be more a working group than a task force, because I'm fairly certain we kind of know what the barriers are and what the issues are in terms of inadequate provider networks. I think what we need to do is work towards a solution. So I'd encourage this committee to do everything they can to do that, because we need a system of mental health care that's able to meet people where they're at, offer voluntary services and supports in a timely fashion. Having people wait months for intake appointments serves no one, and having people struggle while they're waiting to get connected to somebody within that system of care is really problematic. Please make sure, if you do have a working group and or a task force, appoint people who are patients to it, not just one, multiple family members and frontline providers. I think there is a little bit of a worry from my part, is that the people who serve on task forces are the ones who can and have the flexibility and the time to be able to serve on something like that. So there's got to be a way to make sure that we get the proper voices at the table. I'm just totally distracted by that little person on your left. But thank you for the time to testify. Hello.
Thank you so much, Kathy. It's good to see you. Yeah, and really appreciate your thoughtful commentary on that point. So thank you. Yeah, for those folks who are waiting to testify, just a reminder from the clerk that you have to accept your promotion to the panel. Next up, we're going to have Wyatt Bosworth. Good to see you, Wyatt. Oh, I'm sorry. Were there any questions for Kathy? Yeah. Too late. So but next up we have Wyatt Bosworth.
Hi, Senator. How are you?
Great. How are you?
Wonderful. Thanks so much. Chairs Lesser and Wood, ranking members Pavlak, D'Amato, and Wong, and distinguished members of the Insurance Committee. My name is Wyatt Bosworth. I'm assistant counsel with CBIA, Connecticut's largest business organization. You have my full testimony, which is about 7 pages. I'm going to be covering 4 bills today, so please refer to that for my full comments, but I'll be summarizing starting now. So first bill, Senate Bill 357. This is the copay accumulator fix bill. We're supportive of this bill. You've heard from members from HSA and banks. Last year, Governor Lamont signed into law Public Act number 2114. This was the copay accumulator bill. The bill required every individual or group health insurance policy in the state to credit third-party discounts toward an individual or family's deductible and out-of-pocket limits. But given recent guidance from HHS and the IRS, the Public Act is really problematic for large businesses with HSA compliant high deductible health plans. So what we've seen is we've seen a number of states address this problem, some through regulatory action, some through amending state statute. Kentucky, for example, their Department of Insurance issued a bulletin that provisions of a similar accumulator bill would not apply to high deductible health plans. Illinois did as well. Oklahoma is working with the legislature right now to work on a fix. So we would just suggest getting this bill out as quickly as possible to avoid any negative tax implications for large businesses that have high deductible health plans. On the 2 mandate bills, 358 and 5386, my message is the same. We would love to see these mandate bills go through a cost benefit analysis like you've already done with all of the other previous mandates through the Department of Insurance. They will increase the cost to small businesses, but I think the legislature can make a more informed choice on whether the 2 mandate bills are actually provide that benefit and outweigh the costs. The last bill enacted concerning association health plans, 5383. This bill would allow small businesses to band together to buy insurance, giving small employers economies of scale and large group status for rating and plan design purposes. This is really important because large group health plans currently enjoy greater savings due to design and underwriting flexibilities that small group plans simply cannot achieve. Further, large group plans possess greater bargaining power with insurance carriers, can obtain administrative efficiencies, and are also subject to a higher medical loss ratio, 85% versus 80% in the small group market, which means more premium dollars are going to care rather than insurance profit. So because association health plans are a form of a MIWA, the state has significant regulatory authority over both fully insured and self-insured MIWAs. We totally understand.
Thank you. Your 3 minutes has expired.
Yep, thank you. Just in summary, we understand the concerns, surrounding essential health benefits and financial stability, but we're ready and willing to work with this committee and the legislature and the governor's office to come through a compromise because really association health plans are working really, really well in other states, as you heard Kim Daigle talk about in Maine. They're plans that are saving small employers money and they're plans that are financially sound. So with that, I'd be happy to take any questions, but thank you for the time.
Thank you, Wyatt. Appreciate your testimony here this afternoon. Any questions for Mr. Bosworth, members of the committee?
If not, thanks again. Appreciate you being back before us.
Thank you.
Okay, we're moving swiftly towards the end of our list of speakers. We do have a couple other people who still need to accept their promotion if they do want to speak. Otherwise, we'll go on to Susan Halpin. Good to see you, Susan. It's been way too long.
Thank you, Senator. Thank you, all the esteemed members of the Insurance Committee. It's a pleasure to be before you. For the record, I'm Susan Halpin. I'm here on behalf of the Connecticut Association of Health Plans. You've heard a lot of testimony already today, so I just want to highlight for the record a couple things. We too support Senate Bill 357, what we like to call the HSA fix that relates to the Public Act passed last year, Public Act 21-14. Want to express our appreciation to the members of this committee and those other stakeholders that recognized this problem and the unintended consequences it has and have worked to put this bill forward. By way of background, we talk a lot about high deductible health plans. We don't talk a lot about HSAs. So I just wanted to make clear for folks what the benefits of HSAs are, because we talk a lot about being able to pay a deductible. But the benefit of having an HSA compatible health plan is you have dollars available to you to pay that deductible and to pay other cost sharing and to pay for benefits, frankly, that may not be covered by your health insurer. And those contributions to an HSA, they're tax-free on the way in, they're tax-free growth, and they're tax-free on the way out. So unlike your 401k, if you went to withdraw from that, you would pay a tax. You're not paying a tax on an HSA plan. So we hope that the language will pass, frankly, as is, because it mirrors other pieces of statute that has the exact same language that references other similar mandates. Number two, just wanted to urge our opposition to Senate Bill 354. Senator, you are absolutely right. It is one of the few times that you see a number of us ally on a particular bill. We too oppose it. We appreciate the sentiments and the goal, which we believe is laudable, but we respectfully disagree about what the outcome will likely be. The carriers believe that all boats will rise as a result under that site neutral policy, and that premiums will be adversely impacted. Third, I wanted to touch on the affordability as a rating factor in rate review by the department. As you all know, rates are already subject to significant review. They can't be too much, they can't be too little, and they can't be discriminatory. And we often focus on the too high, but the too low is very important too, because what you don't want to have happen is a carrier come into the market and offer very, very low premiums and not be able to pay the doctors and providers for the medical claims incurred. So solvency is really the key here, and that's what we're trying to assure, because affordability can be a very subjective term. And it really depends on the situation that the person finds themselves in. We agree affordability is a really important—
Thank you. Your 3 minutes has expired.
Okay. We agree it's a really important concept, or not concept, but conversation. And we are at the table on those conversations in the benchmarking initiative. And then the last one I just wanted to touch upon was the 340B legislation. And in short, we really hope the committee will await the outcome of the NCOIL conversations that are happening around this legislation before acting. It was even Sarah, I mean, all of us, I think it's a complex process, and I think it warrants a deeper dive than a short session allows for. So we're hoping that at least with the PBM sections that you will await that action. Thank you.
Great, thank you, Susan. And just I have questions on two of the bills that you testified on. One on the affordability and rate review. This is sort of following on some of the questions that Representative Wood and I had earlier. My understanding from listening to Ted Doolittle and others was that this is currently the law of the land in Rhode Island. I imagine you're in touch with your national folks. Do you have a sense of how that, I know that there's a Connecticut insurer that's owned by a Rhode Island-based drugstore these days. And so I didn't know if you had any insight into how it's working in Rhode Island.
I don't, but I can get it. Unfortunately, Ted's testimony is one of the few ones that I missed today, or I would have looked it up beforehand. I think the one thing I've learned in representing this industry, if you've seen one state, you've seen one state. They are very different. That's why the efforts of NAIC and NCOIL, et cetera, and the development of Model Acts is so important to the industry, so that we can have consistency across markets as much as possible. But I know Rhode Island has 1 or 2 major carriers as opposed to our 6. So maybe a little different makeup, but I will be glad to look into it and get back to you.
That would be great. And then with respect to the 340B program, I know that the law that's before us is really targeted in part at PBMs. My understanding is that the law itself, the federal law, is targeted at the manufacturers. Is that, I mean, you were just to move cautiously. Obviously, the problem is what we heard today from the health centers, which is that it's already impacting, their viability and their patients. Are there? I would just sort of open the door. Do you see opportunities to work together, sort of more expeditiously to tackle that particular issue?
I'm always happy to talk about that, but would prefer obviously that it be a discussion at NCOIL. I think they have a meeting coming up this summer, and I know a number of you attend those meetings fairly diligently. So I think it would be a better approach to go that direction. I'm not sure on the manufacturer side. I'm not. I know a little bit about it, but probably enough to be dangerous. So if the committee chose to go off in that direction, I don't know that that's part of the NCOIL conversations. I'm always happy to sit down with the FQHCs. I don't think anything that I'm aware of is targeting that reimbursement rate to the FQHCs. We have to be a little careful because of antitrust, so I don't want to get the carriers in trouble on that. But if we're under the legislative purview and under the Department of Insurance and having those conversations, always happy to have them.
Thank you very much. Representative Wood, did you have your hand up?
I did, but it was more on the NCOIL 340B Act, which I think is something we can explore down the road. Thank you.
Great. Thank you, Representative Wood. Any other questions for Ms. Halpin? If not, you got off easy today.
Wow. See, I need to be at the end of the list every time I testify.
Well, you'd figured that out a long time ago. Your MO.
It's nice to see you all. Have a wonderful day.
You too. Enjoy the weather. Next, we have Dr. Yanagisawa, and I apologize again if I'm butchering anybody's name, followed by Daniel Davis, Dr. Dan Davis. Dr. Yanagisawa, are you there? Dr. Yanagisawa, going once. Okay, we're going to hold on off on Dr. Yanagisawa for the moment, and then we'll go. Oh, no, there you are.
Oh, hey, how are you? Hey, sorry, I just walked back in there. I've got somebody bleeding across the way.
Oh my goodness! If you need to go back to your patient, that's quite all right.
I got patients controlled for the moment, so thank you. Sorry about that. I walked in, I heard my name. I was like, oh, good, I didn't miss you. So thank you. Sorry about that.
Please proceed, and again, please put the safety of your patient over us.
Rather brief and swift. Okay. So, my name's Ken Yanagisawa. I'm an ENT doc here in New Haven, Connecticut, managing partner for my practice, and here representing as a past president of the Connecticut ENT Society. You have my written testimony, and we have sort of a basic framework that multiple of us have submitted. So I wanted to just go through a couple of comments of my own, sort of my own reflections on how this is impacting our practices. So, high deductible health plans, I don't think really serve patients very well. And it actually is degrading the relationship that we have with our patients. Physicians have certainly devoted their lives to serving patients, delivering optimal care, and I think we're very good at that. But the administrative challenges that are being thrust upon medical practices, where we have to spend precious time and resources for deductibles calculations, are really contributing to both burnout problems, with doctors, extenders, staffs, and particularly we're still in a COVID-19 pandemic era. So it's really impacting us badly. Medical practices, small and large, are not good at the request of what we're being asked to do, which is, sort of escalating tasks that are being put on us by the insurance companies. I think the economic impact of unpaid deductibles, which typically occurs right now, first quarter of each year, and the administrative burden, which consumes enormous amounts of time and resources, are really hurting physicians. We're not equipped with the tools or the resources to either quickly or efficiently calculate even, monies that are owed to us. And as a result, it sets into, effect sort of a lot of turmoil of how to get there. So I think if the current methodology remains, we are in danger, certainly, of having medical practices either, not continue, possibly even struggling to find, possibly even forced to not even consider seeing patients if there's not some kind of a good change. And I think that's not going to help the citizens of our state because we need to maintain high quality healthcare in our state. I think the points that I'm trying to make are we didn't make the rules for these plans. We don't collect upfront premiums for any of the insurance policies. We definitely do not have at our fingertips easy access to financial details such as unmet deductibles. I mean, we may know what they pay for our practice, but it's not simple for us to find, their collective amounts due or even exact reimbursement amounts because different companies may publish numbers, but each company has different carve-outs and different subset plans. And it makes it challenging. I mean, we spend an awful lot of time trying to figure this out. In my common sense opinion, I think insurance companies would be the logical choice to administer deductibles. So as I zoom before you, I think I'm here to ask for assistance. If we as a committee and physicians are trying to secure a stronger public health policy, where we are strong advocates for patients.
Your 3 minutes have ended. Can you please summarize?
Yep, and consumers, then I would ask that we consider that the insurers, not the physicians, be the ones to collect medical premiums. They have the data. They're good at it. We're very good at taking care of patients. I want to not take time away, from our patient care, and would prefer much to try to, level this playing ground a little bit so that we have more time to take care of patients and get some assistance with doing some of the other calculations and collections. And with that, I thank you. And again, apologize for the delay at the beginning.
No problem. It's great to be able to hear from you. And I think that's one of the wonderful things about Zoom hearings is that we don't have to take you away from your practice during the day. So really appreciate it. Are there questions or comments for Dr. Yanagisawa? If not, thank you so much. We really appreciate you waiting.
Much again. Thank you all.
Of course. Take care.
Bye-bye.
Next up, we have Dr. Davis. And I believe after Dr. Davis, we have Dr. Moeller. And I will just remind folks that we're still waiting for a couple of people who were supposed to testify earlier, but are still waiting in the queue because they've not accepted the clerk's opportunity to promote them.
Hi there. Am I on?
You are. If you could turn on your camera, that would be great. If you can.
According to my camera, I'm on, but I guess it's not coming through. But yeah, it doesn't look like I'm blocked, so I apologize for that.
Well, we can hear you, so please proceed.
That's a good thing. Well, I can see you, and I hope you can just hear what I'm saying. That's a good thing. My name's Dr. Dan Davis. I'm a resident of Orange, and I appreciate the opportunity. Let's see here, starting my video. Let's see if I can come up. I apologize. Let's see if that's, oh, there we are. Hi there. Can you see me?
Now we can.
Okay. My name is Dr. Dan Davis. I want to thank you for the opportunity of addressing this committee. It's important. I'm a representative of Orange, so I say hello to Senator Maroney. I want to thank Senator Looney for speaking in support of our bill. I've been in private practice in Bridgeport for nearly 40 years. I'm a graduate of the Temple University School of Podiatric Medicine, and I'm in favor, speaking today, of Senate Bill 363. I wanted to address Dr. Arno, who gave presentation. I guess I've been on here all blessed day. And to address some of his statements, he was not aware of the data. You heard some of the data that was presented before by Dr. Khan, and I would love to present some more additional data here. Bottom line is we are paid 23% for 23% less for a regular office visit, 26% less for a new patient visit, surgery on a bunion, 61% less. I&D of an abscess, incision and drainage, 43% less, and x-rays, just for taking the x-rays and interpreting them, we're paid 52% less based on our degree. That is just not right. He stated that the bill will undermine the ability to negotiate payment rates with an insurer. Quite frankly, the bill protects the individual and independent practices who, because they are smaller groups, cannot honestly negotiate with any clout with any insurance carrier. We can't, we don't have the numbers. Basically, you sign it, take it or leave it. And that forces the independent groups now to join larger practices or hospital groups, where interestingly enough, we are actually paid with a parity of our allopathic and osteopathic counterparts. He stated that Medicare does not pay the same to those with the same subspecialty. For patients with straight Medicare, that is not true. They do pay the same. But patients with Medicare Advantage plans, which are run by the same companies that currently discriminate against DPMs, he is correct. They do pay us differently. If this bill is passed, the fee schedules would be paid in parity right across the board. And he feels that their years of higher educational training should be a value they should be paid more for. Just to give you some of the background on our training, we sit side by side allopathic and osteopathic students throughout med school. We have the same textbooks, same professors, the same tests. And at the end of the day, when they get to go home, we have to stay and take additional courses on lower extremity training. We have more cadaveric surgery training. We have more biomechanical courses every year of our training. We have a minimum of 3 years of residency training where we rotate with allopathic and osteopathic counterparts. And we perform over 1,000 cases of foot and ankle cases before they graduate residency. Of note, by the way, Dr. Arno didn't mention that he wrote an article in a journal of bone and joint surgery that in essence stated that foot and ankle orthopedists are grossly undertrained, and that in their 5 years of residency, many of them only receive 24 foot cases after completing 5 years of training. An additional year fellowship might give them 50 additional cases, which is still only a fraction of the education training of a podiatric physician. By his standards, a podiatric physician should actually be paid more, and by his definition, and we're not asking for that. We're asking we just don't be paid less.
Thank you. Your 3 minutes has ended. Can you please summarize?
I sure will. He tried to use an analogy on us, that a paralegal and attorney. Bottom line is we're defined as physicians. We are physicians. Medicare defines us as physicians. By the way, the federal House Bill 2545 was just signed by President Biden yesterday, defining physicians, again, equal parity of physicians with DPMs in the VA, the Veterans Administration. He said that we should include PAs on this and APRNs. We're not mid-level providers. We are full 4 years undergrad, 4 years medical school, 3 years residency. You're comparing apples and grapes. Just the reason I'm here one more time, for those who remember me from last year or 2 years ago, you remember that the Connecticut Podiatric Medical Association, when this came to pass, we brought this lawsuit in front of different insurance carriers. Anthem Blue Cross Blue Shield said, we're sorry. And they made adjustments. And you know, it cost less than $5 over the premium over 3 years. So by the end of 3 years, it cost $5 more, which if we only had a $5 increase in insurance payments, that'd be great. United Healthcare, however, fought us all the way to the Supreme Court. And in the last case of last resort, they asked the CEO of United Healthcare, who was on the stand, and said, "Doctor, would you explain about podiatric physicians within United Healthcare?" And he looked at them and said, "They are the best trained foot and ankle physicians that we have, least complications, and most efficient." And the attorney leaned forward and said, "Then why do you discriminate against them?" And he leaned forward and said, "Because I can." The Supreme Court, we lost there, and the one Supreme Court justice said, "Doctors, we believe this is discrimination, but we have to go by the law. You have to go back to your legislature and make the law a stronger law so that we can support this." That's why I'm here. That's why the CPMA is here. This has been discrimination. It is time. Discrimination in any form should not be tolerated in the state of Connecticut or anywhere in this country for that matter. And I'm hoping that you will pass Senate Bill 363.
Thank you, Doctor, and I can hear the passion in your voice. You're clearly animated about this, and I understand. I understand your point of view, and it's really important to hear from the podiatric community about this issue. So, with that, are there questions from members of the committee?
If not, thank you so much for making time for us today.
All right, well, thank you for the opportunity again. Thank you very much.
Good to see you. Next up, we have Dr. Carl Moeller. Actually, we have, before we get to Dr. Moeller, we actually have Dr. Martin Pressman, who was supposed to testify earlier, and we skipped over him.
Thank you. Can you hear me? Can you see me?
Yes, we can.
Thank you. Okay. Okay. Senator Lesser, Representative Wood, members of the committee. My name is Martin Pressman. I'm a practicing podiatrist. I've been in practice in Connecticut for 43 years. I have offices in New Haven and Milford. I live in Woodbridge, Connecticut. I am currently the chairman of the Connecticut Board of Podiatric Examiners and have been since appointed by Governor O'Neill. And don't ask me to name the rest of the governors, but it's been a long time. And I'm the former section chief of podiatry at Yale from 1997 to 2017. So, you know, I've lived this type of unfair discrimination for 40 years. When I came here, podiatrists couldn't get on medical staffs. We couldn't amputate. There was a lot of issues that we've, over the last 40 years, have solved. And, you know, this particular issue that's addressed in Senate Bill 363 is sort of one of two of the last kinds of discrimination that we have to deal with. Now, I gave you my written testimony. I'm just going to, I know it's late, and I'm just going to touch on a few of these issues. The first thing I want to say is that this bill is 9 sentences long and basically says that no insurer shall pay a reduced reimbursement to a healthcare provider who provides coverage within their scope of practice solely because such provider is a podiatrist. It does not stop an insurance company from negotiating contracts with PHOs or what have you. What we're looking for is, if I'm a member, and I was a member of Yale Medicine for many years, and I'm sure they have contracts with all the payers, it would be, I think, improper if and discriminatory if in those same contracts they carved out podiatrists and said, because you're a podiatrist, we're going to pay you less. I mean, that's simply an unfair kind of discrimination. Now, Dr. Davis basically told you that the training of podiatrists is 11 years and 3 years of training. We have 15 residents at Yale, and they rotate at Yale with all the other subspecialties, and our training is every bit as quality as any other allopathic physician. It's interesting that the general statute 38A 81610, which is in the insurance statutes, basically prohibits, quote, any unfair discrimination on the basis of licensure for healthcare providers. Now, this was the problem that we had at the Supreme Court. Is the Supreme Court justice, if you read
Thank you, your 3 minutes has concluded.
Okay, let me just basically thought that that it wasn't specific enough to say that the reduction of fees as opposed to not paying at all was unfair discrimination. But you know what? If you see unfair discrimination, you just know it. Thank you.
Thank you, Dr. Pressman. Appreciate your testimony. Glad you were able to make it in.
Thank you. Appreciate it.
Any questions or comments from members of the committee? If not, now we go to Dr. Moeller. Sorry for the head fake a minute ago.
No problem. Thank you. Good day, co-chairs Lesser and Wood, vice chairs Almar and Comey, and members of the Insurance and Real Estate Committee. I know it's late in the day. I'll be brief. I'm Dr. Carl Moeller. I'm an otolaryngologist who practices in Hartford, Connecticut. I'm president-elect of the Connecticut Ear, Nose, and Throat Society. I'm here on behalf of the physicians in the Connecticut ENT Society, Society of Eye Physicians, Urology Society, and Connecticut Dermatology Society. We're here in support of Senate Bill 357, copay accumulator programs and high deductible healthcare plans. If we think back to pre-pandemic times, 52.9% of American workers covered by health insurance plans provided by their employees were enrolled in high deductible health plans, up substantially from 39.4% in 2015. With the cost of rising healthcare, higher inflation, many Americans will choose or really be forced to choose a high deductible plan. This is bad news for patients, hospitals, providers, and the healthcare system overall. I'd like to deviate a little bit from my written testimony with the rest of my time, if that's okay. I was sitting with my wife and son, my 7-year-old son last night eating dinner, and I was discussing my testimony with my wife, and my son interrupted us and said, "Dad, you're worrying about the money and you should be focusing on the patient." I think sometimes kids get it right. To echo Dr. Yanagisawa's testimony, high deductible plans are very effective at a couple things. A, forcing patients to self-ration care, and B, driving a wedge between patients and their providers. I've been a part of my practice for approximately 10 years, and probably 5 years ago, we noted our accounts receivable were increasing exponentially year over year for several years. When we kind of looked into it further, we realized this was due to unpaid bills for surgeries we had performed. As a result, we had to institute a policy requiring upfront payment, or at least instituting a payment plan prior to all elective surgeries. As I'm sure you guys are all aware, many of these plans have individual deductibles up to $5,000 for individuals, over $10,000 for families. This is really untenable for a lot of Connecticut families. And then further, it really does truly drive a wedge between the patient and the doctor. It forces us into the role of bill collectors, and it compromises the doctor-patient relationship. We see it all the time. I think this current bill, it doesn't solve all the problems of high deductible plans. It's a good start at reining in the excessive shift of expenses to those who are supposed to be protected. I thank you for your time and attention. Happy to take any questions if you have it.
Thank you, Doctor. Any questions from members of the committee? If not, thank you very much. Appreciate your comments on high deductible plans, and we will have more legislation about that issue very soon before us.
Thanks for your time.
All right, that concludes the list of folks that we have in the panel. I want to give one last opportunity for Vanessa Kramer to accept promotion. Ms. Kramer, if you are able to hear us, you need to accept promotion to the panel to testify. If not, we will be adjourning this public hearing. Ms. Kramer, are you there? Okay, Ms. Kramer is not there. So based on that, we will unfortunately have to adjourn the hearing for today. I want to thank all the members and the staff who were keeping with us, as well as all of the members of the public who were able to testify. Our next public hearing is scheduled for this Thursday at 9 a.m. I want to wish everyone a wonderful rest of their day, and go out and enjoy the weather. And with that, I move to adjourn the public hearing.
Second that.
I think I could just adjourn it. I don't have to have a vote. But thank you, Representative. I appreciate you having my back.